Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing. And that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
The key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up-to-date all the physicians are.
And they're very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging, I mean, this is not a dull conference. This is I don't want to use the word entertaining. I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
This meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, you know, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hi everyone, I'm Alex from the PCRI and welcome to the 2025 Men's Health Virtual Conference. We're so excited to be able to present this information today. We're going to be talking about the importance of sleep, weightlifting, how to fight insurance denials with AI, and so much more. Dr. Scholz and Dr. Moyad are going to be covering a wealth of information in their Q&A. But before I get to that, I just wanted to remind you to click that subscribe button. We are a YouTube channel, and when you push that subscribe button, it helps our videos get out to other people who need help with men's health and prostate cancer. So it's just a great way to support what we do. And if you would like to support us financially, you can do so at pcri.org/donate. Now, we're about to begin the first session, and before I do, I just want to thank our sponsors. We have Bayer, Janssen, Novartis, and Dendreon who have donated and sponsored this event today, so we can provide it for free here on this platform for all of you. Now, we have an exhibit hall and so much information. You can go to pcri.org, and we'll link the conference page on the chat for YouTube and in the link below in the comment section so that you can go ahead and access the wealth of information we have there. It's just a great way to learn about what they provide. Moderating today's conference is Dr. Mark Moyad. He's been an incredible friend and volunteer for the PCRI for almost 20 years. Now, he has moderated so many of our conferences, almost all of them, I think, in the last 20 years, actually. And he is an author. He's a world-renowned expert in men's health, supplements, prostate cancer. He's written multiple books in these areas. He's done tons of videos for us and so much volunteer work. One of the things that he does when he moderates is he finds the speakers and helps us figure out the topics and really what are the education gaps that PCRI has, and what are things that we believe patients need to know for senior men's health. And today, Dr. Emmett Lee Rice, who previously presented with us at our Men's Health Conference a couple years ago, he covered addiction, but today he's going to be talking about the power and recovery of sleep, how important sleep is to get. And I know that this may sound like a very simple discussion, but it's actually not. There are a lot of nuances because we find that so many older men and women are losing sleep, and it's so important for recovery, and it's so important for everyday life and quality of life. And as you know, PCRI is very focused in quality of life, and we're excited to have this topic today. Dr. Rice is the CEO and the medical director for Life Wellness Institute, and you can find out more about him and the information and the foundations that he runs in the exhibit hall. We're so excited to have him today, so thank you so much, Dr. Rice, for joining us.
Hello, everyone. Today we're going to talk about sleep for peak performance. I'm a family physician and sports medicine physician, and what I have found in my regular practice in dealing with families and also dealing with elite athletes is that sleep is one of the least appreciated things for optimizing performance. Sleep is really, really underappreciated in terms of how important it is, how useful it is, how much benefit we get from proper sleep. And more than that, most people don't appreciate at all the problems they have when they don't sleep well. So this talk today is going to be about secrets to being better in bed. I hope everybody would like to be better in bed. And there's lots of things that improve in our lives when we sleep well. And we suffer from many things, physical, emotional, psychological, and physiological when we're not sleeping well. So I'd like to explain to you today what we've learned about sleep, some of the things that we need to be aware of about sleep, what you need to be aware of to make sure that you're optimizing your own sleep. In athletics, here's a good example of a basketball team traveling, trying to get sleep in a cramped airplane, and you can imagine how they're going to perform that night on the basketball court. So this is just an example of the kind of things that we have to deal with in sports medicine. But in everyone's life, we find that sleep is very critically important and very much underappreciated. So I want you today to know how important this is for you. I want you to evaluate your own sleep patterns, and I want to give you some tips on what you can do to make it better. Why do we want to sleep? What's the importance of sleep? Well, sleep improves immune functioning. It improves our own immune status and our ability to fight off infections, to be resistant and resilient. It improves both declarative and procedural memory in our brain. Declarative memory is memory of facts and factoids that you've learned in your brain that you have to recall. Procedural memory is skill sets and how to do things. That type of memory is improved with sleep. It decreases the inflammatory response, and I will tell you that inflammation is the bad guy. The more things we have in our bodies that create inflammation or allow inflammation to persist, those things increase aging processes. They increase our risk of cancer. They increase our risk of dementia and brain deterioration and overall cellular aging. So everything we can do that decreases inflammation and the inflammatory response in a chronic basis is a good thing to do. Sleep is one of the key things to maximize that benefit. Sleep improves healing. We find not only do we heal faster from injuries, but we also heal faster from infections. So systemic healing from bacterial or environmental infections like viruses, common colds. Studies have shown that people who sleep well fight these things off better. And athletic studies show that people who have injuries heal better from their injuries. They return back to full functioning, back on the gridiron as fast as they can when they're sleeping well. Most people don't appreciate the importance of restoring hormones. Everything in our brains and everything physiologically that we do is balanced by neurotransmitters. If we've got the right neurotransmitters affecting the right receptor sites at the right time, in the right balance and proportion, then our brain functions as efficiently as it can, and that controls everything else in our body that goes from there. If we don't have the right amount of hormones, if we don't have the ability to replenish and restore hormones, if the neurotransmitters are not working well, then our brain function and everything else, the ripple effect of that is devastating. Body composition is important, and obviously for sleep. We find out, and we'll tell you more about this later, but if you don't sleep well, then the ghrelin and leptin, the two hormones that regulate appetite and satiety, are distorted, and we gain weight when we're not sleeping well. So weight loss is very important to understand. If we're going to have a weight loss program, that we have to sleep well. People who are not sleeping well have a tremendous difficult time losing weight. Sleep improves reaction time, it improves cognitive speed, and it improves working memory. All these things are brain functioning, very important. The other things, it decreases our resting blood pressure, and it also can decrease our work blood pressure. So the blood pressure that we have that increases naturally when we do activities, that can be less if we've slept well. It decreases our pain tolerance, not our pain tolerance, but it decreases our pain perception. The ability of us to feel pain is increased when we're lacking in proper sleep. It increases creativity. Studies have clearly shown that people are most creative when they've been well rested. Our ability to, what we call, do emotional categorization. One of the very interesting things about sleep deprivation is it prevents proper emotional categorization, meaning it doesn't allow us to recognize what our true emotions are and what the meanings of our emotions are, and we get everything in our life out of perspective, especially as it relates to relationships and other things in our life that affect us emotionally when we're not sleeping well. So sleep is very important to maximize our ability to understand our emotions, to categorize what things mean in our life and put them in proper perspective, and not to overreact to life itself. And then happiness, interestingly, with romantic relations have been shown to improve with people who sleep well. So for all these reasons, we want to learn how to sleep properly. In 1917, Dr. von Economo coined the term encephalitis lethargica. And what he found was that when people were prevented from sleeping on a continued basis, they had all kinds of physiologic negative effects, and eventually they died. And familial fatal insomnia was the word that he was using to talk about people who died from improper lack of sleep. But there's all kinds of also other complications here that you see, from psychological effects to blood pressure effects to heart disease, obesity. All those things are ripple effects of not sleeping well. So when we don't sleep well, it can be catastrophic. In animal models, mouse and rat studies have shown when you prevent sleep within 7 to 10 days, totally prevent sleep, those animals will die. That's the result of not sleeping well, even in the animal models. That's parlayed into what happens with us as well. Other long-term effects of not sleeping well, things like type 2 diabetes are made worse. Our insulin resistance is greater. Our insulin sensitivity, the cell's ability to use insulin and store carbohydrates appropriately, decreased when we're not sleeping well. We have increased cardiovascular disease. We have more sleep apnea, chronic inflammation, as we talked about, but things like stroke, neurological decline, mild cognitive impairment, PTSD impacts, and executive functioning. All those things are made worse when we're not sleeping well. And then we see all kinds of things with just brain function, with dementia, depression, irritability, concentration problems. Suicide risk is interestingly increased. Depression is increased, and that leads often to suicidal ideation. And Madigan did a wonderful study a number of years ago looking at people who did not sleep well on a regular chronic basis. And he found out that 23% of those people who didn't sleep well had depression, 17% had increased anxiety, 13% claimed they had symptoms of PTSD, and 25% ended up on opiates just to handle the pain that they were feeling because of the increased pain recognition because of lack of sleep. So lots of long-term effects that affect everybody when we're not sleeping well. When we're looking at the athletic realm, we see lots of negative effects on performance. We see decreased overall athleticism, the ability to be athletic on the field, increased injury risk and incidences of injuries. Interestingly, increased use of substances. So alcohol, opiates, and stimulant addiction is much more common with athletes who are sleep deprived chronically. And then significantly decreased neurocognitive performance, just our overall executive functioning of our brain is significantly less when we're not sleeping well. When we sleep only 6 hours, for example, for 11 nights in a row, that has the same cognitive effects as one night of not sleeping at all and how we're going to feel and operate the next day. So it's a very significant problem and a very significant thing that we see. One thing that's not as appreciated is what are the long-term effects of sleep deprivation on family relationships. We know now from studies that family relationship dysfunction is increased when anybody in the family is not sleeping well. People who don't sleep well, interestingly, have a lack of ability to perceive affection. One night of missed sleep makes people perceive that their spouse, their family, their kids like them a lot less the next day. Pretty interesting thing, but our ability to perceive how other people feel about us is impaired by lack of quality sleep. It's no surprise then that divorce rates, spousal abuse rates, and child abuse rates are all increased statistically with studies that have looked at people that don't sleep well and have chronic sleep deprivation. So this is a major effect that affects everything in our lives and everything that's significant. When we look at performance, we see 18 hours of wakefulness, meaning sleeping only 6 hours at night, is the same in its effect for us as a blood alcohol level of 0.05%. Not a good thing. It's interesting that 19 to 24-year-olds are 4 times more likely to be involved in a fatal fatigue-related motor vehicle accident than an alcohol-related fatal motor vehicle accident. And interestingly, 56% of men and 43% of women report driving drowsy, not just occasionally, but on a regular basis. So One thing you don't want to be is on the road at 2 a.m, out there on the road with all kinds of people who are sleep deprived. One night of decreased sleep decreases libido. So oftentimes people come in complaining of, I want to get my testosterone checked. I got to maybe take some extra testosterone. They don't need extra testosterone. They need better sleep, because sleep enhances normal hormone replenishment, normal testosterone. One of the first things we can do for people that feel tired, they don't have great libido, ability to work out well, they're afraid of low hormones. If they increase their sleep on a regular basis, they naturally enhance their normally recurring hormones, especially testosterone and estrogen balance. Interestingly, when somebody doesn't sleep well, they only perceive that lack of sleep effect for the first night primarily. So if they sleep poorly one night, the next day they'll, say, I don't feel as good, I'm pretty tired. The next night they don't sleep the same way. The next day they'll say, well, I'm a little tired, but I'm okay. And by the third night of sleep deprivation, they say, you know what? I feel fine, I'm doing great. So the sleep deprivation impairment, it's only observed for 2 to 3 days accurately. And after that, our own ability to understand how much we're missing sleep is way significantly decreased. This is an interesting factoid here. Loss of 2 hours of sleep increases daytime hunger the next day by 25%. So the fact of that is that if you miss 2 hours sleep tonight, if you need 8 hours and you only get 6, tomorrow on average, you're going to eat 25% more calories just because your hunger drive is increased. So people that are trying to lose weight, one of the first things we have them do is learn how to sleep well and correct that if they're not sleeping well, because it's really hard to lose weight if you're sleep deprived. Loss of 1 hour per night in terms of weight gain is 14.3 pounds of fat in the next 12 months. So it's a significant effect physiologically. Sleep is required for procedural memory, learning how to do things and how to remember how to do things and not make mistakes in following procedures or skill sets. It's required, as I talked about, for emotional categorization, which is very important. What's important to understand is that there is no active mechanism to turn sleep on. Sleep is a naturally occurring thing. We sleep primarily because of the absence of things that wake us up. So there's 2 controllers that affect sleep. One is clock-dependent alerting. So if you wake every morning because an alarm clock goes off, that sets your biological clock. If you don't have that alarm clock, then it's the normal circadian rhythm that tends to regulate whether we feel sleepy, what time we go to bed, how well we sleep, and when we wake up. So what we have to learn is that there is a natural circadian rhythm, and the more we can emphasize the regularity of that rhythm, the better that we're going to sleep. So if you look at just overall cortisol levels, you can see this graph here where cortisol levels are increased around noon. At 8 p.m., they start to go down, 6 p.m., 8 p.m. At 12 in the morning, they're the very lowest. And then at 6 in the morning, 7, 8 in the morning, they tend to be their highest. So when cortisol levels are their highest, it's when we're trying to wake up. It's nature's own way of trying to allow us to be alert, to be organized, to have our brain wake up and be able to do cognitive functioning. And then it gradually goes down the rest of the day until about midnight again, when it starts to be at its low. So normal adrenaline regulation is regulated by circadian rhythms. When we sleep, our biorhythms of sleep are very much the same. Turns out that we have sleep cycles, and about every 90 minutes, we cycle through all the various stages of sleep. If you look at this graph will tell you what our sleep stages are. Stage 1 of sleep is very light sleep. It's where we're not even really asleep totally. We're aware of our environment, but we're not interacting with our environment. Our activity slows down. There's occasional muscle twitching. Sometimes people feel like that as they're starting to go more and more into sleep. And then stage 2 sleep, which is 45 to 55% of our total sleep, the breathing pattern changes, the heart rate slows down. We have a decrease in body temperature. That's one of the reasons why it's better to cool the ambient temperature down if we want to sleep well, because our body temperature naturally falls down. And then stage 3 sleep, which is not much of our sleep, only 4 to 6%, It's the start of deep sleep. And our brain begins to generate very slow, what's called delta waves. And if you look at the top here, you can see the difference in brain wave activity for each one of these stages of sleep. So when we do sleep studies, we can tell you what phase of sleep you're in just based on looking at your brain waves. Stage 4 sleep is very deep sleep. So 3 and 4 are progressively more deep sleep. That's very rhythmical breathing, very limited muscle activity. And we have delta waves that are wider waves that you see. And those are very, very important for brain restoration. And then stage 5 is the REM sleep, the rapid eye movement sleep. That's where our brain becomes very active. Total sleep in REM is about 20 to 25%, depending on the person. That's where dreaming occurs because our brain is very active. Our muscles are totally relaxed. Our muscles basically are paralyzed. We're not moving at all. And our heart rate increases, our breathing is rapid and shallow, and our brain waves are quite different. So that's the cycles of sleep, and we tend to rapidly go through those things, or I say regularly go through those things, about every 90 minutes. It's different for each person genetically, but on average, we cycle through that a number of times. And many people say, as an example, I just feel fine on 5-6 hours sleep a night. I don't need more sleep than that. Well, I'll tell you what, people that think they're doing fine on less than 7 hours sleep at night, when we measure their sleep activity, we measure their hormones, we measure their brain activity, their memory, their cognitive abilities, they're decreased in their abilities when they're not sleeping well, even though they think they're functioning fine. And if you look at this, this gives you a clue as to why. The REM sleep here, this first phase of REM sleep may only last 10 minutes, but every progressive next phase of REM sleep is longer, longer, longer. The final stage of REM sleep here may be up to an hour. So if you miss the last cycle of REM sleep, you're missing the most restorative part of REM sleep in the entire night cycle. And you can see that the deep sleep primarily is in the early part of sleep, and the REM sleep is in the greater part of sleep. So all these things are naturally occurring for us, and unless we allow ourselves to do normal sleep and have normal sleep architecture with normal brain wave cycling, then we're not going to be fully restored and rested in the morning, even though we may be not awake. So you can see here, this is again an example of stage 1, 2, 3, 4, and then back up to REM sleep, starting with maybe 5 minutes of REM and 30 to 60 minutes of REM later in the evening, and then we finally wake up. So what's interesting is that in stage 1 sleep, that stage where we're almost not asleep, we're aware of our surroundings, but we're not interacting, we're not speaking, but we are aware of our surroundings, that's when we're easily awakened. So if there are things in the environment that are stimulatory, like dogs or cats moving on the bed, or the room being too warm, or if you have to pee and your pressure from the bladder is high, somebody's coughing in the room, you hear a noise or a light, anything like that that is stimulatory, when you phase back up to stage 1 sleep, that can wake you up, and that can be very hard to get back to sleep. So when we're looking at sleep patterns, we have to understand that we have to cooperate with the whole environment as much as we can. And there's ways that we can design that, and we'll talk about that. So we are designed by our natural endocrine system to sleep well. So everything is designed to help us be appropriate. When blue light decreases, blue light is full spectrum light. So that's the sun. When the sunlight goes down naturally, that stimulates the pineal gland in our brain. It's a very small gland in our brain to release melatonin. And melatonin is the natural neurotransmitter that triggers restfulness and eventual sleep. When we have appropriately triggered melatonin, that decreases our adrenal function. So that's why one of those things that causes the cortisol to go down, because our adrenal cortical function goes down. Because adrenal function decreases, our body temperature decreases, our heart rate decreases, our blood pressure decreases, our brain waves slow down, just like we talked about. The blood sugar drops, so our glucose utilization drops. Our immune system is increased. And all those things are dependent, each one, on the thing before it happening. And if one of those things doesn't happen properly during that cycle, we're going to have impaired sleep. And finally, our hormones are replenished. So we think, well, when we're sleeping, not much is happening. That's not true. When we're sleeping, our hormones are totally, especially growth hormone, growth hormone is being replenished, our testosterone is being replenished, all of our sexual hormones are being replenished, our neurotransmitters are being replenished. All those things happen when we sleep. So physiologically, what happens in this pathway is tryptophan turns into hydroxytryptophan, which produces serotonin, which supports melatonin, which lowers adrenal function. So that's the physiologic pathway that's naturally occurring without us having to do anything. Our bodies just do that for ourselves. And number two, the 5-HTP turning into serotonin and supporting that, and then melatonin, all that requires vitamin D3 and magnesium. So when we look for why people are not sleeping well sometimes, we have to appropriate all these things to see whether or not you are performing them as you should. And if you're low on vitamin D3 or you're low on magnesium, you're not going to have the ability to have all these physiologic effects occurring naturally for you. So that's one of the reasons we check vitamin D and magnesium to see if that's low for you. If you need to supplement that, that can actually improve sleep. And many people, when they don't sleep well, they go, I know what it is. I know it's my thyroid, right? There's lots of reasons why people may not sleep well. And if you look at these basic 5 things, these are the categories that cause sleep problems. You can have medical conditions like asthma or COPD or congestive heart failure, diabetes, allergies, all these different things biologically can hinder sleep. You can also have psychological disorders, including depression and anxiety primarily, that prevent sleep. You can have basic sleep disorders such as obstructive sleep apnea, which we'll talk a little bit about in a minute. You can have central sleep apnea. You can have restless leg syndrome. You can have pharmacological agents. Many drugs affect sleep, and most people don't appreciate how many drugs there are that can interfere with and affect sleep. Especially if you look at the bottom there, nicotine, alcohol, those things affect sleep adversely. And selective serotonin reuptake inhibitors, SSRIs, those are mental stability drugs that many people take for depression. Those things can affect sleep. And then we can have environmental factors such as what's the temperature, what's the light in the room, what's the noise going on, how much does your bed allow you to sleep comfortably, pets jumping up and down, mates in bed with you, all those things can affect sleep. And every one of those things can alter sleep adversely. And so when we're going to do a sleep evaluation, we really have to look at each one of those things and say, okay, where is it that you're not optimizing any of those things? And how can we fix those things when they're not working well? People ask how much sleep I need. Well, it depends on what your age is primarily. You can see that newborns need 12 to 18 hours of sleep, and then it progresses through to teenage years where you need probably 8.5 to almost 10 hours. School-age children, 5 to 10 years, up to 11 hours of sleep a night, and adults on average, 7 to 9 hours a night. I had a good talk. I was on a panel for wellness in Florida earlier in the year with a person that was there from the University of Arizona Longevity Institute. And they asked him, how many hours does the average American adult need to sleep every night? And the answer was very interesting. He said, if you sleep at night by yourself, you go to sleep without causing anything like drugging yourself to sleep, you fall asleep and you wake up in the morning without an alarm clock and you feel rested, that's probably how many hours you need. And there are some people that feel they can do fine on 5 to 6 hours, but as I've said before, most people who do that are actually, when we test them, they're not functioning well on 5 to 6 hours. But most people, when they're on vacation, if there's no stress in their life, if they're just sleeping naturally, they'll find that they need 7 to 8 to 9 hours sleep at night. There are also some studies, interestingly, that show if you sleep more than 9 hours a night, that may be a problem. Maybe it's because of depression or other things going on medically that are causing that. The average adult does need 7 to 8 hours sleep a night to optimize that sleep. If you get that on a regular basis, it's going to be the very best for you. So when we don't sleep, what happens is very interesting. We don't release growth hormone or testosterone as we normally would. Because of that, we have chronic inflammation, or in addition to that, we have chronic inflammatory markers that increase. Because of inflammation and the lack of hormones properly assessed, we don't feel like moving. And so we have less motion, we have less activity. Because of that, our metabolism slows down, we get fatter. Fat turns testosterone, interestingly, into estrogen. So when we're not exercising, the testosterone that we do have as a male gets turned into estrogen. You get fatter, your muscles shrink, and you get movies. And so that's all the negative effects for men that don't sleep well. For women, it's a similar kind of a thing, and they're not sleeping well either, and they're having the same kind of adverse physiologic and anatomical effects. So what do we do to sleep well? How do we mitigate poor sleep? The first thing is I would look at all those 5 areas we talked about before and figure out which of those things may be interfering with your sleep. There are certain things we can do to plan for proper sleeping. One is when we wake up in the morning, we get exposed to bright lights. They have for areas of the world where people don't have full spectrum light early in the morning. You look up in Alaska or Canada where the light dark cycles are quite different. Oftentimes people get depressed unless they figure out a way artificially to expose themselves to bright light early in the morning for at least 15 to 30 minutes. So one thing you can do is get out early in the day, spend at least 15 minutes in the sun, or if you don't, you can get on Amazon, you can get bright full spectrum light, artificial light things, and you can put that in your face next to it, 12 to 18 inches away, and that can help wake you up. Stimulating music or loud noises actually also help wake us up in the morning. Movement and exercise is wonderful. That's why many people find exercise being most helpful when they do it first thing in the morning. They get up, exercise wakes them up and makes them feel better. Staying hydrated all day long helps us be alert and functional well during the day and be ready for sleep at night. And not having caffeine after 2 p.m. Many people are addicted to caffeine without even realizing it. They feel like they need caffeine to be alert. They start having more caffeine, and pretty soon they're dependent on caffeine. Their brain's actually quite dependent on it and is tolerant to it. If you want to know whether you're dependent on caffeine or not, try stopping caffeine and see if you get a headache. Because if you get headaches when you stop caffeine, then that's a withdrawal symptom from your brain trying to get rid of the effects of no caffeine. We weren't made to need caffeine or caffeinated beverages to be alert, awake, to function properly, or to not fall asleep. But we've learned to be able to do that. The reality is there's probably, for most people, not a problem with 1 or 2 cups of coffee or caffeinated beverages per day, usually earlier in the day. But many people who have high blood pressure, who have arrhythmias, cardiac ectopy, we call it, they can't sleep at night, or they wake up after they go to bed without being able to go to sleep again. It's because of extra caffeination. So one of the things we do is we decrease or stop caffeine. That can really help. More mitigation. Look at all these things. Avoiding sleep aids. Sleep aids seem like a good idea, and occasionally they can be if it's just an episodic kind of a thing. But on a regular basis, when we use other artificial means medically, either hormonally or just supplement-wise, to help us sleep, then our brain adjusts to that and then eventually needs that to allow us to sleep well. So avoiding sleep aids in general is a good idea. Sleep restricting when necessary, but not all the time. Planning for optimal sleep. Again, no alcohol at least 3 hours before bedtime. Alcohol is an interesting thing. I'll talk about that again in a minute, but alcohol actually can keep us from sleeping well. So we say that sedation is not the same as sleep. Many people use alcohol to sedate themselves and help them go to sleep, but then that doesn't result in useful, normal sleep. Stopping vigorous exercise 4 hours before bedtime is a good idea. Some people say that exercise makes you sleepier. That's true. It makes you sleepier at night, but it's best to do vigorous exercise earlier in the day. It takes 3 to 4 hours from really strenuous exercise, hard exercise, for your brain neurochemistry to calm back down again and optimize itself to be ready to sleep. So easy exercise, a walk around the block, doing something very comfortable, lightweight, 60% capacity, that's okay. But not strenuous exercise within 4 hours of bedtime, especially if you have a problem getting to sleep well. About an hour before you go to bedtime, just kind of shut yourself down. Just sort of cool your engines. Don't do things that are activating. Quiet your lights, quiet the music, quiet your brain engagement. Use your bed for sleep or for sex, is what the experts say. Don't sleep, if you're sleep deprived, while you're trying to sleep in bed, look at your screens. Don't look at TVs. Don't read mystery novels that are aggressive, kind of horrible things. Use your bed for relaxation things, just sleeping or sex, but avoid things that are very engaging or activating for your brain, because then your brain gets used to not expecting to sleep well because you're too cranked up. Decreasing the room temperature. Most people like the room temperature around 68 to 72 during the day, but at night, probably 60 to 66 is a better range for people to sleep comfortably. Having a hot shower or bath about an hour and a half before bed can be very effective. That helps you relax your muscles. It helps your blood pressure fall. It helps your respiratory rate go down. Those are just things that naturally help us relax. Doing muscle relaxation practice, yoga, or doing just gentle yoga, gentle stretching exercises. Those are things that relax us again, slow our heart rate, slow our blood pressure. It's a great thing to make a gratitude list. A lot of people who are stressed at night, they say, what do I do to get rid of the stress I feel at night? One of the best things they can do is write down 3 things that you're grateful for that you've been experiencing that day. And that just switches your brain to thinking things that are positive for you, not things that are problematic and cause your brain to go nuts and trying to solve problems. So focusing on gratitude late in the evening, especially right before you go to bed, or even journaling it, writing down, what am I grateful for today? What was the meaning of that thing for me? And why was that important? And how did that make me feel when I experienced it? Can be a wonderful thing to start your brain getting ready to expect to sleep well and have a feeling of forgiveness and gratitude as you go to sleep. And then a patient of mine said, I've got a God box. I said, what's that? He says, well, I've got a God box. And when I'm really stressed about something at night, I can't go to sleep, and I know I'm going to have a bad night because I'm ruminating about what that is, I just write it down, whatever that is, and I put it in this little box, and I ask God to hold that for me at night, and then they'll give it back to me in the morning. So having a God box to just write down things that you're worried about, knowing that you can come back to in the morning. You don't have to deal with them at night when you're sleeping. They'll wait for you. They'll still be there for you in the morning. And then allow yourself to relax. Very, very important. So alcohol and sleep. I want to just say a word especially about that because people don't appreciate it. Lots of people use alcohol to allow themselves to relax, thinking that's going to help them sleep better. And it does actually have a different effect. It decreases restful sleep and it decreases REM sleep. Alcohol disrupts the normal sleep architecture. So when we look at those normal variations in sleep cycles every 90 minutes, alcohol doesn't allow that to happen. It induces sleep, so it sort of drugs you by making you tired, but then you fall asleep, and within 1 to 2 hours later, there's actually a stimulatory effect. What happens is when the blood alcohol level falls below a certain threshold, there's a stimulatory effect where your brain wakes itself up. It causes adrenaline, and then you wake up, and then you can't go back to sleep. So it's interestingly how many people tell me when I've stopped alcohol, I can't tell you, doctor, how much better I slept. And one of the first things that sleep experts tell people in sleep study clinics is if you're having trouble sleeping and you drink on a regular basis, stop drinking alcohol at night and see how much better your sleep gets. And most people find it really does help their sleep. So I recommend if you're having trouble and you drink regularly to try a trial just for a week or 2 weeks of no alcohol at all. And then retrospectively figure out, is that helpful? Did it really make a difference for me? Because remember that sedation is not the same as sleep. And what alcohol does is it causes artificial sedation, but that's not normal sleep architecture and sleep waves. What are 10 things you can do to help perfect your sleep? Blacken your room. And I'll just tell you the thing that really impressed me about this. I had a doctor working with me who is the head Navy SEAL team doctor at Coronado. And he'd been a Navy SEAL himself. Then he went to medical school. He became a doctor, specialized in undersea medicine. And then he specialized in helping out the SEALs. He became the head SEAL team doctor for Navy SEAL teams in Coronado, most of whom have trouble sleeping. A lot of them have chronic pain. They've got sleep-wake cycles that are totally abnormal. They sleep when they're in the day. They try and stay awake when they're working at night when it's dark. And he's got plenty of SEALs who had sleep insomnia for 6 to 12 months, even longer than that. never having had a good night's sleep. So he took a group of SEALs who were all insomniacs. They hadn't had a good night's sleep on the average at least the last 6 months. And the very first night, they put them in a black box closed container environment. Zero sound, zero with, total buffers in all the walls and the ceilings and the floor, so they couldn't have any sound penetration at all. Blackout curtains, they had no lights at all, no LED lights, nothing. So total blackened room. They had no electronics, they had no light, they had no stimulation at all. And when the average SEAL who hadn't slept for 6 months was put in that environment, they slept on average for 10 hours the first night, 10 hours sleep. So that was just because they were no longer stimulated by things that were waking them up. Don't use electronics in bed. Make a consistent bedtime and stick to it, because when you go to bed at a certain time, your body will gradually get that cycle going where you're sleeping for the right amount of time. We also try to have you get up at the same time every day, because that's, some people feel, even more important than going to bed at the right time. If you get up at the same time every day, that sets your biological clock to feel tired about 16 hours or 12 hours, whatever it is that you're going to need later on. So when you get up at the same time each morning, it sets your biological clock to have the same sleep time at night. That can be very helpful. Practice stress reduction. Be aware of, this is emotional categorization. Be aware when you're at increased stress. A lot of people, I don't have any stress. Well, a lot of them they do, and they don't really appreciate it. So think about, what are the ways that you do have stress in your life, and what are 5 ways, whether it's exercise, whether it's eating right, sleeping better, writing down a journal, talk therapy, whatever it is that you can do to decrease stress. Practice that on a regular basis. That'll help you sleep better. I would say the majority of my patients that are not sleeping well have unresolved stress that they're dealing with subconsciously at night when they can't shut their brain off. So being aware of stress and dealing with it, very important. Improve your insulin sensitivity via diet. And the way we improve our sensitivity to insulin and the ability of insulin secreted by our own pancreas to control glucose in our brain and decrease inflammation is by decreasing simple carbohydrates. When we decrease simple carbohydrates, our insulin becomes more productive, it's more active, we're more sensitive to it. Our hemoglobin A1C, which is the average measure of our blood sugar over the last 90 days, goes down. And interestingly, we were able to lose weight much better. So learning how to eat properly, mainly it's not late night eating. Mainly it's getting rid of nutritionless calories, which are primarily saturated fat and simple carbohydrates. And simple carbs are the white things: white bread, white pasta, white rice, anything with added sugars, sweets, and alcohol. Those are the things that have no nutritional value, but decrease our insulin sensitivity and increase inflammation in our bodies. Exercising on a very, very regular basis. They took a group of people that were, again, insomniacs. The only thing that they did for this entire cohort for 6 weeks, they didn't change a thing about their lifestyle, except they gave them every day for 6 weeks 45 minutes of vigorous exercise. And those people who got 45 minutes of vigorous exercise on a daily basis for 6 weeks, at the end of that time, their average time to fall asleep was 50% as long as it was before. And their average time spent actually sleeping was a full hour more. So exercise has a wonderful effect, a responsive effect afterwards, to increase our sleep. It increases our relaxation ability and increases the quality of our sleep at night. So vigorous aerobic activity, not always just strength training. Strength training is fine, but it's aerobic activity that really tends to set our biological clocks to sleep better at night. So I encourage you to do that on a regular basis. Decrease blue light therapy 3 hours before bed. That's full spectrum light. So dampen the lights down. Don't have bright lights. Cognitive behavioral therapy, CBT, that's called. It's reframing the experience. Many people don't sleep well because they convince themselves they're not going to sleep well, because, we're all habits of yesterday. I didn't sleep well last night, so I'm not going to sleep well tonight. Or I've had to deal with something tough today, or I've got something tomorrow. I know it's going to be stressful for me. I know I'm going to be worried about that tonight, so I'm not going to sleep well. Well, all you've done is you've programmed your own brain to not sleep well. So learning how to reframe the experience of tonight, I'm going to have a great night's sleep. I'm going to give myself permission to relax. I'm not going to worry about other things, and I'm going to sleep well, and I'm going to be glad I did in the morning because I'm going to wake up really feeling rested. Very, very important how much our brain can control. Expectation does breed reality, and we can learn to change our expectation, reframe the experience, and inform us basically the placebo effect that we give to ourselves. We are the placebo, and that placebo effect can help us sleep better. If you're not sleeping well and all these things are already taken into account, consider getting a sleep study, especially if you snore. People that snore, maybe you don't know that you snore, but somebody you sleep with hears you snore and they tell you, hey, you do too, snore. If you snore, you may have interference with sleep. You may not be sleeping as well as you should, and a sleep study can be very helpful for that. So this is just an overall clock kind of a thing of all the things that we can do to help ourselves sleep better. Develop the goal of getting to sleep in a regular ritual. I'm going to sleep at a certain time of night. Sleep in silence and in the dark. Don't eat much before going to sleep. Big meals late at night, one of the biggest causes of not sleeping well, because our body is trying to digest food as opposed to allowing us to sleep. Not smoking at all is a good idea, and not using alcohol can help sleep a lot, as we just talked about. Doing something gently active before bedtime, like taking a walk, can be beneficial. Giving up caffeine after 2 o'clock in the daytime, good idea. Sleeping on a firm level and a comfortable bed. Some people just sleep better because they didn't have a good bed before. So check out how comfortable a bed is, how appropriate is it for you. Some people like a soft bed, some people like a firm mattress, but whatever it is that you sleep best on, figure that out. Figure out what time and temperature you sleep best at. Most people, if you dampen the temperature 5 to 7 to 8 degrees at night compared to what you are during the day, that's going to help you sleep better. Going to bed, waking up at the same time. Don't working, especially on electrical appliances near your bed. That just makes you think about, I got to check my cell phone, I got to check my whatever it is. But get rid of those screens in bed. That's not a good idea. Don't watch TV, especially murder mysteries, right before you want to go to bed. And don't focus on insomnia. Focus on gratitude. Don't count sheep, count blessings. That's the critical thing. Napping, people often ask, how does that matter? Well, napping is okay if you're sleeping okay. Naps are actually a healthy thing if you're not using a nap instead of sleeping well at night. So napping during the day for a short period of time doesn't interfere with sleep, studies show. Early afternoon is probably the best time for a short nap, and 30 minutes max. 15 to 30 minutes is sort of the max time for sleep. If you sleep longer than 30 minutes, you can get more into that deep sleep state, and then it's hard to wake up and you feel groggy for a long time afterwards. So short naps are good. Setting the room temperature comfortably, that helps with that. After 3 p.m. may interfere with nighttime sleep. So I do recommend, if you sleep with a nap a little bit, that you do it earlier in the day, and you don't do it as a substitute for sleeping at night, just as a beneficial kind of a thing. People ask, well, what about supplements? And there are some supplements that are reputed to be safe, but remember that anything you use to alternately affect your brain to help you sleep is not natural. And the more you can do it naturally, the better it is. And I'm going to be very interested. Dr. Moyad is one of the world's experts on supplements. I'm going to be very interested in what he has to say about these safe supplements like valerian root, chamomile, melatonin, and passion flower. Those are things that are often in benign over-the-counter sleep aids. There's another one that's often listed, and that's all the PM drugs. The PM have basically, it's a diphenhydramine, which is like Benadryl. That's the brand name that most people know. It's a Tylenol PM, Advil PM. They have diphenhydramine in them. That's an antihistamine that causes sedation. So sedation is a side effect of that, but it has a longer half-life and can cause a hangover effect in the morning. So be very careful of getting sleep regularly because of those PM drugs. They can be a problem. There are brand names like Insomnitol. I'm not advertising that one, but that's just an example of a drug that has some of these quote safe supplements in them that may not be negative. A gamma aminobutyric acid, it's a naturally occurring neurotransmitter that alcohol is involved with. And that may be a safer drug. It's using now a lot. Gabapentin is used for pain relief for a lot of people. Some sleep experts are using it for sleep, but that's something really ought to be used under doctor's prescription. And anything you do on a regular basis, again, what happens is when you take something in that sets up increased potency to your brain has to adjust to that. And when it has to adjust to it on a regular basis, your brain changes what it naturally does to accommodate that thing you're taking in. So for example, if you take melatonin in every night, your pineal gland in your brain says, hey, I don't need to make as much melatonin myself because I'm getting it exogenously. I'm getting it from an outside source. I'll just stop producing it. And then when you stop taking melatonin to sleep, your brain isn't producing it on its own, and now you can't sleep at all. So be aware of dependence that can come from sleeping with those kind of things. Sedative hypnotics, like the other drugs like Ambien, et cetera, typically can have a hangover effect. They can affect memory. They can affect during the day attention. They cause physiological and psychological dependence. The psychological dependence on those things can be very, very significant. There are some of those drugs that cause hallucinations at night. They even can cause suicidal ideation. There are concerns. Some of the more recent studies have shown that people who sleep regularly with hypnotic drugs have greater mild cognitive impairment as they age, and they get more dementia potentially. So that's a concern we have. Some of these drugs actually separate out the front brain from the midbrain. They knock you out, so they're sedative, but the whole brain is not in connection. It's not working. And so that's where we get, sometimes people get up at night, they sleepwalk. They can actually do physical things like driving their car, like going down to the store, like cleaning out the refrigerator and not remembering any of it in the morning. And they're called parasomnias. Those can occur because of sleep drugs that inhibit your brain from working naturally. Alcohol can cause respiratory depression, even respiratory arrest in people who have either congestive failure or pulmonary problems. And sedative hypnotics can be linked to all these medical things like heart disease, cancer, depression, anxiety, et cetera, and even all-cause mortality, which is interesting. There are some newer drugs on the horizon. Rosarum is one that just helps melatonin work a little bit better theoretically. Belsomra is one that's called an orexin receptor antagonist. Orexin is the receptor site that when it's stimulated, it wakes you up. So rather than having drugs that try and put you to sleep, this one helps block the thing that makes you wake up. But those are all relatively new drugs. I think they can all be abused. They're reputed not to be as addictive, but I wouldn't recommend using any of those things without checking with your own doctor, making sure that you need them, using them for the shortest period of time, the least possible dose. A word about sleep apnea to close. Sleep apnea is a breathing-related disorder. It's involved in repetitive pauses in breathing, where you're not breathing rhythmically. You've got areas of your night where you stop breathing. And it can be periods also of just shallow breathing, where you're not getting deep inspirational breaths that really aerate your lungs and your heart and your brain. It can be involved with snorting or choking sounds. Spouses often say, yeah, my husband or my wife has these funny sounds they make at night after a period of not breathing at all. And it can result in snoring and daytime sleepiness. When we sleep with abnormal breathing, we don't have restorative sleep. We're less alert during the daytime. That causes increased inflammation. I've already told you, inflammation is the bad guy. And it decreases immune function and multiple negative physiologic and brain effects. So if you're concerned about sleep apnea, I would get a test. There are tests for it. There are home tests. There are sleep study places where you have to go in and get a test sleeping in like a strip mall, and they wire you up with everything. I'll talk about that in just a second. To prevent sleep apnea, it's interesting how many people have sleep apnea that just totally get rid of it by weight loss by exercise, stopping alcohol, dealing with stress, and avoiding late night eating. So sleep apnea is not often something that you're just concerned with for the rest of your life. It's things that are lifestyle created, and lifestyle can help prevent those things as well. If you want a sleep study, the formal sleep lab is where they just wire you up and you sleep in an artificial bed in a totally closed, like that seal type environment where there's no light, no sound, nothing, and they measure everything. Home sleep studies now have been done. They're very, very good. They give you wearables. You can do about 90% of all the information acquisition with a home sleep study that you used to have to do at a formal sleep lab. So it's very easy to do now. They'll send you the stuff in a box and you hook yourself up and you turn it in the next morning, and it's a pretty good deal. It measures brain waves. It measures your blood pressure. You can measure heart rate, measure respiratory rate, how many episodes you have where you're not breathing and how long those are. It measures body movement, like restless leg syndrome, how much movement you have. It interestingly measures what position you're sleeping in, how much of your sleep is on your side, on your back, on your stomach, and it measures obviously the sleep stages. So looking at all that, they can figure out what your overall sleep architecture is in a sleep study. And based on that, we can figure out where we need to intervene to help you sleep in a more effective way. There are also some novel remedies to help people sleep. One is called the Inspire procedure, where there's a little wire inserted in your mouth that actually stimulates the muscle that keeps your airway open. And so the ENT doctor that was they trained at Mayo Clinic is doing that here in San Diego, says it's probably 80-85% effective at people who have obstructive sleep apnea, preventing them from needing to be on CPAP, which is very interesting. CPAP is a very good device which causes positive pressure and keeps the airway open. And many people just sleep tremendously better with CPAP, but it can be cumbersome and it's harder to live with that kind of apparatus on you. They have made a smaller device now, though, for CPAP that actually is for travel. So it's not as big of a deal to travel with that mechanics, but it can be helpful to use that CPAP in many ways. It just saves people's lives, literally. But the Inspire procedure is something that may prevent you from needing that. They're making newer and more effective oral devices that you wear that just sort of maintains a more open airway. The nasal strips probably are not that effective for most people, but they can be used. And then there's a new bit of evidence with transcranial magnetic stimulation, TMS we call it, where people get treated with stimulatory things in their brain. It basically, I think, helps them deal with stress better. And because they're dealing with stress better, they're more relaxed at night, and then they can sleep better. So that has to do with depression. People that are very depressed, it's been FDA approved for depression. And if depression is increasing lack of sleep, then that's one thing that can help that. So there are some resources I'm giving you here. If you're interested in looking at some of those resources, they're very good at just giving you more up-to-date information and any way that you can get information on a regular basis, because this is a rapidly growing field. Lots of new information coming about on a regular basis. Happy to give it to you. And my recommendation is to stay up to date on what's possible, understand what's happening for you. And if you need help, please get help, because sleep deprivation is something that's way underappreciated and can destroy not only the quality of your life, but increase many, many disease states that are going to bite you in the end. So thanks for listening. Hope this is helpful. And Dr. Moyad would be happy to answer any questions.
Standing ovation. Hold on a second. I'm going to standing ovation. Ooh, my knee hurts today. I went running this morning like you, and I kind of overdid it. And part of the reason is I got so excited that my brother from another mother, Dr. Lee Rice, I call him Instant Rice. Do you know why I call you Instant Rice?
I have no idea.
Because you're fast in giving an answer. So whenever you and I are talking about a consult or something like that, where nobody is seeing our phone call, if I have an answer and I need an answer quickly, you give it to me quickly. So I call you Lee Instant Rice. What do you think about that?
I'll go for it.
You don't seem.
I appreciate it. I'll take it as a compliment.
Okay, so I've known Dr. Rice maybe 20 years, 15 to 20 years. He's a very humble man. He still has a very busy practice. It's an amazing practice that sees all sorts of conditions. I couldn't think of anyone else better to talk about sleep. I also recommend to people they look at the previous lecture that he gave a year or two ago on addiction. And if you look around the internet, it's not easy to find an objective, in my opinion, lecture on addiction, types of addiction, what to do about addiction. I actually watched that one over again about 6 months ago. That was awesome. So he's already done one for us, and his background is amazing. Not only has he done this for, how long have you been in practice? You've been in practice 40, 50 years, right?
Something like that.
I mean, that's incredible. That's an amazing amount of knowledge. You're like an AI guy. Like, just your brain's got so much in there. You're sort of an AI person. And then you used to be the personal physician, or actually the physician to the San Diego Chargers.
Right. 16 years.
16 years?
Yeah.
How was that experience? Did you get to travel with the team?
Yeah. Yeah. It was a great experience. One of my more fun experiences in life. I've been fortunate to be involved with a lot of teams, but that's been one of the most interesting and exciting things that I've done, because I love football, and it's been a great time to be just the networking of the wonderful people you get to deal with and the things you get to be associated with. It's a real blessing.
That's really amazing. And you still do some work with the NFL now, don't you?
I do now. I do work with the NFL Alumni Association. There's a nonprofit called NFL Alumni Health, and we're trying to use NFL veterans who are icons in their communities to take messages of wellness back to their communities and elevate the level of health in the communities that they come from, often communities of color, communities that are not as well-to-do and well as educated as other communities. And the average person in those communities can die up to 10 years before average communities. And so all we can do to improve the education and the access to healthcare and the ability to access healthcare resources, very, very worthwhile.
That's like your 28th job working with the NFL. Every time I talk to you, you're in some other country. You also do some work with the Olympics, right?
I'm the chief medical commissioner for the International Surfing Association. So I'm in charge of the international surfing for the Olympic, like Tokyo and the recent one in Paris, which was actually Tahiti, and upcoming in the LA Olympics. I'm in charge of the organization of the medical care for those events.
And you have a busy medical practice in San Diego.
Right.
And so if people want to see you for any of the conditions you see, I think we have your website that will be listed. So you're still seeing patients most days of the week. Is that right?
I am.
Okay. So let me ask you a softball question. Who's your best friend in the medical world?
Oh, it's you.
That's a good answer. That's you got right. So, all right. You've just humbled me with all the stuff that you do and how busy you are. And I have to tell you from behind the scenes, you know how I don't like to give too many compliments because then I think it makes the cranium too large. And then suddenly that doctor or person can't walk out of the door. There's not only did I just reveal all the other stuff that Dr. Rice does, Dr. Rice is one of the few doctors that I talk to on a regular basis, or we talk back and forth and trade stories and education, that the man practices what he preaches. There's not many people like that. I tend to bring up the names of those individuals. So all the things that he talked about today, the things of being healthy, the lifestyle changes, he's the one guy I can relate to. In fact, when we talked this morning, I said, I'm going for a run. He said, I'm going for a run. You've always not only been kind and great and brilliant, but you've always practiced what you preach, because you have a lot of preaching to do. And what I find behind the scenes is that a number of people will not practice what they preach, and that just makes me absolutely wacky. It's just go do this, listen to what I say, not what I do. Anyway, I wanted to throw that out. All right. I want to show you pictures of what it looks like to get really great sleep through one of my family members before we start. Can I do that?
Go for it.
Yeah. All right. The great Peter Scholz, the technology mind, one of the minds behind the scenes he's going to bring up. And I want you to comment after you see a couple of these photos, if he can bring them up. That's not me. That's my dog, Grazie. Do we have another shot of him sleeping? Look at that. Look at the position, Dr. Rice. Look at that. Do we have another one there? I want to look at that. Do you have any critique, Dr. Rice, for my dog who just...
That's a great sleeping position. It's not on the back. It's sleeping nice, comfortable cushioning. I think the ergonomics are excellent, and I think that dog's going to wake up feeling rested.
Okay, we can cut. Oh, I forgot. This is my balcony.
Now
This is
that
the
dog
funny
died. You should get a different dog.
My friend texted me that. He said, "Is the dog alive?" I said, "Of course he's alive." And I said, "This breaks Dr. Rice's rule. Like you're supposed to sleep in a dark room. This is
Yeah.
out bright sun on the balcony. It keeps him warm." And so this is the life of a dog at the Moyad house. And so do we have any others that Dr. Rice can critique or not critique? Or did that the last one? Brilliant, isn't it? And the dog's 5. Oh, okay. So there you go. You're right. So this is after the dog went to sleep. You said he was in the right position.
All right.
Okay. So he wasn't just on his back, he was more on his side. And so he was great. All right. Thank you for doing that. I appreciate it. I didn't think about that sleep position. That is true. It's amazing how sleep position, and we'll go back to sleep, but this is, how I'm tangential. It's amazing how sleep position changes sometimes your health, whether it's for sleeping on your left-hand side for acid reflux. I've heard that, for the position of the stomach. But can you just comment on that again briefly, why you said that about my dog?
Well, there's a couple of things about positioning. One is, especially as people get older, they often have infirmities, they have neck pain or they have a shoulder problem or this or that, their back hurts. And if they don't get into a good ergonomic posture when they're sleeping, they're awakened by pain. And some people can sleep on their side, but they've got shoulder bursitis. And so if they lay on their side, or maybe they've got hip bursitis, and every time they sleep on their right side, their hip bursa wakes them up because of the pain, the swelling in it, and they have to turn over, and they're constantly doing that. Or if people have urinary problems, and some positions make you more aware of that. And so most people find that they sleep better, more soundly, if they're either sleeping on their stomach or angled. I have people use lots of pillows so they can sort of orchestrate their sleep. They're not just directly on their stomach, they're a little bit angled on their side, one way or the other. On the back is probably the least helpful for people as they age because they tend to snore more on their back. The soft palate collapses down, the airway becomes smaller as the muscles relax, and then they wake up because they're not sleeping well. So side or stomach sleeping tends to be back best. But many people also have reflux, GERD, we call it, gastroesophageal reflux disease. And for people who have GERD, it's important to have the stomach be higher than the waist, because otherwise, if you've got a little hiatal hernia, allowing reflux to come back, anything that by gravity increases the reflux back upstream can irritate your esophagus. Had one person, very interesting story, but it sort of elucidates this, complained of hoarseness and sent him to the ENT doc because of hoarseness. He had no reflux symptoms, no heartburn at all, but he had inflammation of his vocal cords caused by reflux that he was not even aware of. So he got on GERD protocol, elevated his head of his bed, didn't eat large meals late at night, stayed away from things that increase acid production like alcohol, got some antacids and H2 blockers, and eventually the inflammation on the pharynx and the esophagus, the vocal cords went away, all the hoarseness went away. He was totally getting an effect of reflux, had no symptoms of reflux other than hoarseness. And he was totally unaware that could be caused by reflux of acid up from your stomach. So sleeping can be very tough positionally and very helped if you do it right.
Yeah, that's really interesting, because isn't it true that if you go see someone in primary care, one of the differentials that you should think of if someone has chronic cough is possibly that they also have reflux that they didn't know they had?
Yeah, totally. Chronic cough is one of the biggest signs of chronic reflux.
That's so, because, I'm sure you must see a ton of people with chronic cough. It's become like a new epidemic.
It's one of the most common things.
Thank you. Let's talk pills so we can talk about your expert recommendations combined with some of mine. So let's get the pills out of the way. Does that sound good? It's nothing against pills, but I think it's always easy to give away pills or talk about pills. So let's talk about the first one that gets all the attention. Let's talk about melatonin. All right?
Yeah.
And so the good news about melatonin, I decided to put some up things because I know you deferred to me a little bit, but I want to show you. I thought I'd make a sign that you would find very interesting. And I call these the Moyad miscellaneous melatonin moments with Dr. Instant Rice. So now you know why I call you Instant.
Okay.
What I think a lot of people don't realize is that if you take massive quantities of melatonin, if you overdose, and maybe you've seen this, if you take too much melatonin, you start going in the double digits, that essentially it can start wreaking a lot of havoc. It can actually cause daytime fatigue. You know, you can get some of the side effects of the. So I don't know if you see this. The reason I put testosterone here is that in the old days when I was first starting out 35 years ago, in prostate cancer, they were combining huge doses of melatonin in some studies with different types of therapy. And they suggested that there was a testosterone lowering effect, but some studies were seeing that when you took mega doses of testosterone, it affected your LH. So your LH got blunted. It couldn't stimulate the cells in the testicles to make testosterone. So even though we talk about all the things that affect testosterone, melatonin is probably not one of those, but in some people that take massive dosages of melatonin, they can run into a lot of problems. And so I don't know if you see that problem, but I just think there's a problem today with too many companies selling high dose over the counter melatonin. What say you about that? Do you agree or disagree?
Well, I totally agree. And in fact, some of the studies that I like the best, I think are most accurate, show that the best effects of melatonin when they are used at very low dose, 1 or 2 milligram melatonin, not 5 or 10.
Exactly. So I talked to a researcher long ago in my career who did a lot more melatonin work than I've done. I said, what's physiologic? So what's a physiologic? Like when your body makes melatonin, let's say you listen to everything Dr. Rice says, because I think what we have to reiterate is that you tend to maximize your melatonin output when you listen to Dr. Rice's sleep hygiene steps, right? When you create darkness, when you get away from blue light, all these things. An ancillary effect that people don't recognize is they are optimize their melatonin machinery. How about that? So I asked the guy, if you optimize your melatonin machinery, what is the physiologic level? Is it 5 milligrams? He said it's between 0.5 and 1 milligram. And I'm going, nobody takes 0.5 to 1.
Yeah.
But your body is saying, I do really well at 0.5 to 1. So I just found that really, really interesting. And it makes you realize, I'm not saying that 5 doesn't work or 3 doesn't work, which is very common. I don't know where people are getting these recommendations. They're supposed to be taking 10, 20, or 25.
Well, you know, there's a tendency to think that if a little is good, a lot's better. And if 2 doesn't help me or three doesn't help me, then I better take 5 or I need 10. And what you're doing is you're upsetting your normal basic physiology. You know, we say what you do during the day, set yourself up for how you're going to spend your night. And same with the night, if what you do is you try and short circuit the melatonin receptor site neurotransmitter mechanism, all you're doing is decreasing your own body's ability to help itself by secreting the normal amount of melatonin that your body wants to get used to responding to. And if it gets used to being exposed to more, then the response is going to be less. You develop tolerance to it, and basically it's addiction.
Yeah, I think that the pilots got it right? It's used for jet lag. That makes sense. They don't use it continuously. They just use it when they are going a certain direction, when they want to sleep at the time they're going to end up being at, you know, whether it's in Turkey or Austria or wherever, you name it. And I think that it's one of the most common items used for jet lag overall. The other thing I like to say is that people forget that a lot of healthy foods have melatonin, but the dose is really small. I don't know, you know, tart cherries, for example, fish. So people don't realize that there's actually melatonin in some healthy foods. Nuts like pistachios have melatonin. So that's kind of cool, I think. You eat healthier, you kind of get natural melatonin, although these dosages are really tiny. They can pick up the compound in the lab.
Right. And it's all your brain needs. Really, that's the deal.
Maybe, exactly. Quality control issues. I cannot emphasize this enough. Every study that I've seen from colleagues, every time they take out 10 different companies, a very large number of them will report an amount of melatonin that is either not accurate. They've either put too much in there or too little in there. So one of my rules is that you look for melatonin by itself as a compound, not stacked up with 20 other compounds, which is a good way to make you pay more without research. And you look for a third-party quality control seal, you know, a company that's tested that company to make sure that if they're selling you 3 milligrams of melatonin, that's what you're getting. I don't know what you tell patients about drug interactions, but to me, you're only as good when it comes to drug interactions and OTC, you're only as good as your last literature search. And what that means is, we think now with melatonin, there may be some interactions with some blood pressure medications. Maybe your blood pressure drops a little bit more when you sleep, some anticonvulsants. There may or may not be some interaction with some blood thinners, but I don't know what you tell your patients about drug interactions. I find that it moves so quickly that I think more physicians and medical professionals should be just always updating and checking their interactions, or talking to a pharmacist, or making sure the pharmacist is involved when the person goes to the pharmacy to pick up the OTC. That's a lot there, but I don't know what you think about that.
I couldn't agree more. I think that there was a couple of studies recently that showed getting samples from pharmacies, actually in the US, Mexico, and Canada, that especially over-the-counter supplements that were not branded.
Yeah.
30% of them had stuff in them that wasn't supposed to be there in the ingredient label, and about another 30% didn't have in it what was supposed to be in them. So the quality control of those substances is very, very poor because they're not FDA regulated or monitored. And so the last thing I tell people, don't get Joe's Garage vitamins, get them from a basic brand that, like you say, has a third-party quality control seal of approval on it. And then you're much more likely to have in it what you want. And I think you just have to be very careful about adding and adding and adding. I learned very early in my medical career, we had a nursing home across the street from the hospital. And as a freshman doctor, student Dr. Rice, go over there and look and listen, poke, prod, feel normal from abnormal, figure out what it is. And you're now the doctor for those patients. And what we found was that as repeated rituals of doctors would come through, they'd rotate in, rotate out, rotate in. Each doctor that was there wanted to give more medication to control any symptom that was abnormal. And you ended up with patients on a giant list of drugs. And the first thing we learned to do was to stop all the drugs. And amazingly, how many people, when they're on 10 drugs, you stop 8 of them and their symptoms totally go away. So polypharmacy, especially with over-the-counter supplements, can have all kinds of unknown effects where one interacts with the other and either prevents the interaction or prolongs the interaction or makes it worse. And patients have no idea.
Yeah, is exactly right. I find that some of the lowest cost melatonins have some of the best quality control. We just got a get together with the residents, and I said, if you remember nothing else from tonight's dinner, I want you to repeat this Dr. Moyad saying, if it costs more than Costco, then maybe you're paying too much. Meaning that Costco carries a strong line of supplements, but what they do, whether or not you like them, most of them or many of them, you can see the seal on it. You can see NSF, you can see USP. They have the third-party quality control seal right there. Right. So we're not saying you shouldn't spend more. I'm just saying, just so you know, when it comes to me, when I spend more than if it costs more than Costco, then a lot of times I'm not buying it. And I'm not saying that because I'm cheap. I'm saying that because they carry quality control seals. So does CVS, and Walgreens will carry them. But it's an important point on drug interactions and what you said. Polypharmacy, another big problem with sleep. You're just loaded up. Polypharmacy can happen with supplements too, as you see. And the name I learned was deprescribing, right? That's when you start taking away. So how often do you recommend your patients relook at their med list and their OTC list?
We do it with every quarter. We do it.
Really?
Yeah, because they may go to other doctors and they add on. And so every quarter, we take all our patients that are in our program and we review every medicine they're on and talk about that. And you mentioned something that's important too. Pharmacists now have software where the patient can ask the pharmacist, plug in all my drugs that I'm taking and all my supplements and see what the interactions are. And they can give you really good information about that.
That's a good point. That's a really good point. I mean, that's their business, right? Keeping up with drug interactions. Ask the pharmacist. Okay, so now that we said pros and cons of melatonin, we're going to leave melatonin, but I always never like to leave a supplement unless it also gets its due in the scientific world. There's a condition that all of you can look up called REM sleep behavior disorder. I don't know if you've dealt with it much in your clinic, where someone is in REM sleep and they actually act out their dreams. So rather than when they're in dreams, if they're punching or throwing or kicking, they do that. Yeah. And it can be an early sign of a problem, right? So if you go to Mayo Clinic or you go to the journals, there's not many treatments for it, except there's a couple treatments for it in terms of pill. One of the treatments that's still listed as I argue standard of care is melatonin. And I just always found that interesting. So when a doctor tells me that, or someone never tells me that supplements are worthless, they don't help any medical conditions, that's just one of 100 examples in my head. Well, that's just not true. Melatonin is recommended in that situation. So are other prescriptions, but I don't know if you see that condition. I just thought I would throw that out there.
Yeah, we see it sometimes. But more often what I see is the parasomnias that occur when people are on the prescription like Ambien drugs, where they actually have quite complex motor activity with no brain control over it, because those things aren't working because the drug has basically shut that connection off.
That's interesting. And the other thing is people sometimes get things confused with sleep. There's another condition that I'm sure you've dealt with, which I find interesting too, is related to a nutritional blood test for some patients called restless leg syndrome. So if you look in guidelines in other places, it says if you have restless leg syndrome, ask your doctor about X, Y, and Z, but also ask to do a ferritin test. Also ask to see what your iron levels are, because in some people, low iron levels are associated with restless legs. So do you see that, or is that not still as prevalent as the other stuff we're talking about?
No, we see quite a few patients that have restless leg syndrome. That's one thing that sleep monitoring can diagnose, how much leg motion there is.
Yeah.
A lot of patients can complain of that a lot, and that's not a one size fits all kind of a thing. There's lots of reasons why different people have restless leg syndrome. It may be magnesium levels, it may be stress in their life, it may be just poor sleep architecture, they're having legs move. Some people think they've got less restless leg syndrome and they really don't. They've got other things going on. So you really have to sort it out, but it is actually quite common. I mean, it's not the majority, but it's not unusual that I see it.
But it's multifactorial, right? It's exactly what you said. I mean, some drugs, some interactions can cause it. But as we leave melatonin, I want to tell you where this was in my own family. And I was dealing with some people who were helping a family member with hospice. And I thought this was a really educational moment for me. They were recommending all these sleep aids. And I talked to one of the medical people there that was handling this family member. And I said, this came out a while ago, a prescription. It's a prescription melatonin agonist called Roserum. And they said, there's a prescription melatonin. I said, there's been a prescription melatonin that's been out for almost 20 years. It didn't get many commercials. But if someone's really nervous, but they want to try melatonin, there's a prescription melatonin agonist called Melatonin, or also known as Roserum. And these come in at dosages of 8 milligrams. And I find that a lot of people, you mentioned it in your lecture, which is why I showed that sign. Yeah. I find that a lot of people have no idea there's a prescription melatonin out there. Have you used it? Do you like it?
I have used it. Yeah, the half-life is appropriate. It's not real strong, but it helps melatonin that you have work better. So as it says, as an agonist, it works with the melatonin that you have. So it makes your own melatonin maybe be a little bit more effective. And like you say, I have no problem with people trying those things as long as it's limited time. And I like it, the people I use it primarily for are executives or family members who travel different time zones, or athletes who travel and have to compete in a different time zone, 3, 4, 5 time zones away in the next day, and they've got to compete. You want them to sleep well. So for 2 or 3 nights to reset their biological clock, the new time zone, fine. But I just always warn them, don't start doing it on a regular basis. It's a short time thing. It's a quick fix, but it's not meant to be chronic.
I'm going to tell you my final melatonin story. You're going to enjoy it. Are you ready for this melatonin story?
Hit me with it.
Again, because I will defend supplements to the death as much as I'll criticize them. That will help legitimize the field. Not me just saying that they all work for everything, never take a that's too much. It's like someone telling me that their football team is always the best, every other team stinks. Well, maybe that's the truth in terms of Michigan football, but that's a whole other story. But the truth of the matter is, I go over to Italy with my wife, and then we talk to this doctor. I had trouble sleeping. And the doctor tells me that I can get a prescription of a drug called Circadin, Circadin. And I thought, wow, this sounds magic. What's the dosage? He said 2 milligrams. It's prolonged release Circadin. It's approved in the European Union for primary insomnia. You can see it as a commercial. And I thought, well, let me look this up first. I look it up. It's 2 milligrams of prolonged release melatonin. It's a prescription over there. It's over the counter here in a prescription. Don't you find it interesting that one of the biggest sleep aids in all of Europe, I think they also sell it in a variety of other countries, is 2 milligrams prolonged release melatonin. They've had tons of clinical trials, and it's melatonin, but it's prolonged release, so the half-life's better. I don't know why I thought you'd like that story of mine. Okay, I want to talk about, before we go into the experts' recommendations that I have, and then we'll go back and forth. Can you talk to me a little bit more? I think home testing, or even if you can pick up something, some of them have these actigraphs, and there's a thing called Aura Ring now that can do some testing. I think any of these, just to see how you're sleeping, are really good. I think the home sleep apnea test or the home sleep test is a game changer, because you remember, like I do, anytime someone wanted to get tested, they're like, wait a second, I got to go to a laboratory. They're going to hook me up. I got to sleep on some gurney, and all these people are going to be watching me behind some booth. And a lot of people just couldn't sleep there. So I don't know if you want to comment more on, have you found homes? I mean, all the societies are now recommending it, the major sleep societies, but I think this is a word that no one's ever used, game changer. I'm just kidding. I think it's a big deal. Is it a big deal to your practice?
Yeah, some people like data. I'm one of them. I like data. I like to know what I'm doing. I've got a basic concept. Most people aren't aware of the prices they're paying for the choices they're making, largely because they're not aware of the consequences of their choices. So I like data. I like to know what is, and I think that a lot of people are now, with all the technology that's available, really liking this. You can get addicted to data too, and it can worry you like crazy and take it to the extreme. But I think these Aura Rings are a good example. I can't tell you how many patients I have now and friends that are using Aura Rings. And it's like what gets monitored gets addressed. Well, if they're aware because of their Aura Ring that they're not sleeping well, or the quality of their sleep is worse, or their heart rate is greater, then they're going to be more apt to wonder why and want to do something about it. So I think home sleep studies kind of fall into that category. It gives you really good information for most people. It's not as good as a, all-night sleep study in a shopping mall somewhere where it's all regulated. They can test more things there. They can wire you up more. But at 90%, most people don't need all that extra stuff. Most people, if they do a home sleep study, they get all that they need in terms of useful information that the doctor can then say, okay, based on that, here's my recommendation for what you do about it. So you can measure blood pressure responses, you can measure heart rates, I was amazed to see that this one that I was surprised to, they knew exactly how much time they spent on their left side, on their right side, back, front, when they woke up, how often they had sleep apneic episodes and how long they were, and what their position was when they had them. Amazing information that really enlightened the patient about what the issue was to be addressed. And so I think it's great. I think
so you're a fan of any sort of test, including Aura Ring, trying that, setting up with your primary over just a home sleep apnea test, for example. It's really called a home test, a sleep test. So any of that you're a big fan of.
All these wearables, heart rate monitors, it's amazing now, all the wearables, the information that's giving the doctor's office, and some of them are, the doctor can monitor real time in the office based on signals that come by. So I think in the future, wearables are going to be more and more important, and it's going to allow us to do more precision medication than we ever had before.
Okay, so we talked about supplements a little bit. I mean, I can talk about with later on the Q&A with Scholz about valerian and some of these other ones that don't get as much press. And I'll tell you the concerns I have with some herbals and some of the positives, but the diagnostics are better. Then you have melatonin prescription or non-prescription overall. Before we go through your list, do you want to say, I think the best way to think about prescription meds is, who do you like on a prescription med for sleep, and who do you not like off of the top of your head? I mean, who is a really bad candidate and who actually may be a candidate? I find that everyone, when a prescription sleep aid, everyone thinks, oh, that's success to sleep. Then you have a million people asking for it.
Yeah.
The actual people that qualify. So I'm just kind of trying to pick your brain a little bit. Who do you think actually qualifies for an Ambien or a Lunesta? Yeah, not to throw you a curveball, but I'm just wondering who gets them in your clinic once in a blue.
The people I feel good about prescribing them for are
better
basically people who don't really beg for, they don't want them. They don't come in saying, I got to have some sleep aids. They go, I'm taking this trip. I'm going to Europe. I'm giving a big talk, and I want to have good sleep before that talk because it's for a big board meeting or whatever. And I just want to make sure that I'm not fatigued when I'm doing that. Do you mind if you give me a couple days of whatever? So they understand it's short term. They understand what they're using it for. They know I've got a 12-hour or 13-hour sleep thing on the plane, and I know I can never sleep because my knees are up in my chest, and if I don't have something, I'm going to be just, sleep deprived the whole time. So it's somebody if they've got a particular circumstance, they know it's temporary. They're not typically on medications. They're not on other psychiatric medications that could interfere with those medications.
Yeah.
And they're very conversant. They're willing not to take it if I tell them not to. So it's the ones that I worry about are the ones who are afraid that they can't do without it. They're wanting more. They've had it before. They've tried this one. Now they want to try that one. It's sort of an ongoing thing. You get a feeling with some patients that this is going to be a problem. They're not going to be able to get off of it. And if I give it to them, I'm going to have a problem controlling it from them psychologically.
That's a really good answer. I think that kind of puts it in perspective. And before I leave the prescriptions, because that's a whole other lecture and game. Have you ever dealt with prescription fugue, which we called it in the business, where you read it in the label, it says just be careful. Some people sometimes do things while they're sleeping. They'll operate machinery or a car, and they wake up the next day and they don't remember. They call
That's
it
the parasomnias. Yeah.
Parasomnias. So you actually dealt with that where people have.
I had a lady call me. She was a well-known actress in Hollywood, and one of her biggest problems was weight, and she was very well known. And she called me crying, saying, "I woke up this morning, and my entire kitchen was destroyed. My refrigerator door was open, everything in it was opened, wrappers of everything on the floor, everything had been consumed. Obviously, it was me. There's nobody else here, and I remember none of it." That patient was on Ambien. And Ambien from that was a parasomnia, where it's like some patients have, gone to 7-Eleven, they've driven to 7-Eleven at night, got something, come back, and they don't remember it in the morning on prescription sleep medicines. So there can be disturbing things that can happen where people can drive, and they can do very complex motor activities like driving. They have no idea what's going. So the risks of self-harm, other people harm, whatever, or just things like eating too much at night, not good.
The only other thing I can say about prescriptions that I wish we have time to talk about, but we really don't, is I find it interesting that these weight loss drugs are now making people sleep better. And I think it was semaglutide or semaglutide, any way you want to pronounce it, I think got approval for sleep apnea, obstructive sleep apnea, or maybe both of them now. I can't keep up. And I just think, here we go. All this weight loss is now going to get multiple approvals throughout all these medical disciplines. And the common theme is they lost weight. So I don't know. That's not a bad thing. It's just amazing how GLP-1s are getting all these indications now, including you sleep better if you lose a certain amount of weight.
Well, it's just incredible. What started out as let's control blood sugar.
Right.
And they're finding, well, you can control blood sugar. And if you do that, you lose weight. And if you lose weight, there's less heart disease. And if you lose less heart disease, there's less mild cognitive impairment and less dementia. And it's the same thing. This is all about self-induced mortality. We're with exercise and healthy nutrition and weight control, everything gets better. And that's a drug that, for better or worse, is helping people lose weight. And it's getting I've got a lot of cardiologists now that are really encouraging patients to be on those medications because they find when they're on them, their blood pressure is better, their cholesterol is better, their inflammation markers are better, and their health is better.
Look, if we do this interview a year from now, Zepbound and Wegovy and all the ones who get approved in the future are going to have 20 indications for what they make better.
Yeah.
And I'm going, okay, but just so we all agree on what the mechanism is anyway.
Yeah.
I think those drugs are great, but I think
the big problem with those is, again, if you follow these people over studies, when they stop first of all, they're very expensive right now. People can't afford them for a lifetime. When they stop them, they're going right back to where they were before because they've never learned the discipline of changing their lifestyle like those medications allowed them to change without having to think about it.
Yeah.
So, knowledgeable lifestyle is the critical thing, and being willing to stay. And again, if they don't exercise doing resistance training, half the weight they lose is muscle weight, which is not what you want to lose at all. So it's got all negative sides. You got to know the whole story.
Well, I just wish people to say, those are serious drugs for serious weight loss. People have life-threatening weight. They're carrying life-threatening weight. Those have been miracle drugs. But the idea that I want to lose 4 pounds because I got to go to some party and put me on that and pay my doc cash, I'm going, ooh, I don't know about that, but don't get me started. One more pill that kind of makes me wacky, and you mentioned it, thank goodness. OTC PM medications is Benadryl. The primary ingredient in your OTC PM medications, there's so many, is diphenhydramine. You said that. And I wish it would instead say, helps you fall asleep faster, OTC Benadryl, but nobody says that, of course. So
right.
These sell really well, these over-the-counter PM, PM.
Yeah, PM this, PM that.
PM, yeah, but you're taking Benadryl, and do you have any more comment about that? That always kind of scared me.
Well, it's again, it's a the biggest problem I see regularly with patients is a hangover effect. They say, I went to sleep, but then I couldn't wake up in the morning. I felt drowsy in the morning, groggy for the next couple hours after I woke up. So the half-life of them is such that it can cause a hangover effect. That's one of the bigger problems. And it's also something that if you take it on a regular basis, you become tolerant to it, and then it doesn't work as well. And then you're averting the whole deal.
Now, that's what I find, every time there's a magic pill, even a melatonin, you take it too much, you take it too often, there's daytime grogginess, people develop intolerance. And by the way, I think this, I have to review a different article every month for physicians so they get credit. I've been doing that almost 20 years. This is the one I wanted to review. I just think you'll find this interesting because you mentioned this too. This is by Young et al. This has been Alzheimer's and dementia. This just came out. So let me just read this to you.
Yeah.
This was a good study done at the University of Texas Health Center, and it got a lot of attention in my field. Here's the highlights from this observational study they did, which consistently supports previous observations, but for some reason this got more attention. Sleeping greater than 9 hours per night was associated with worse cognitive performance. This association was stronger amongst those with depression. Long sleepers were more likely to report symptoms of depression. Sleep may be a modifiable risk factor for cognitive decline. In other words, we're supposed to get a good thing, but we're not supposed to overdo it, which is what you said. Do you want to comment on that? Is this the idea that you stay in bed all day and sleep 9 or 10 hours?
Correlation doesn't prove causation.
Right.
And because people sleep longer, doesn't mean the sleep caused them the problem medically. The reason they're sleeping longer is because of those other things. If I'm depressed, I'm sleeping longer because I just don't want to get out of the bed. I want to pull the covers up over my head and not face the day. So people that are depressed are going to have less activity. They're going to have more weight gain. They're not going to eat properly typically. They're not going to have as good social relationships. All those things have all the negative effects that we know of. It's not the sleeping that does. Sleeping is the cause of those things. Sleeping is a mechanism that people use to cope with those things, but it's not a cause of the medical problem other than the fact that they're not doing all those other things.
Yeah, it's a symptom of the greater problem. It's a consequence, right? But that's why it's such a powerful indicator. We're not saying that if you sleep too long, suddenly you get depressed. We're saying if you are sleeping too long, it might be an indication of something else going on.
Yeah.
And that's why I've always felt like this is the most powerful part of your talk. I kind of summarized the expert's recommendation, including yours, because when you really hone in on these recommendations, these are pure power. And a lot of them is lifestyle. And let me go through them and we can both comment if you want.
Yeah,
The
good.
first one that I thought changed my situation was the fact that many of the sleep societies do say 60 to 67 degrees Fahrenheit or 15.5 to 19.5 Celsius. Man, converting that to Celsius without using a computer.
Yeah, I know. Yeah.
Oh my gosh, you got to help me. So the idea that at night, so we sleep at 65 now. And I don't know if you want to comment on that. The body was meant to sleep in a colder state. So 60 to 67 is the general recommendation from the National Sleep Foundation. What say you about that same temperature range you mentioned?
I totally agree. I find personally, one of my biggest issues, if I go to a hotel and I sleep on a upper level story of a hotel, and if I have the air conditioning on to keep it cool, the noise can wake me up. If I turn the air conditioner off, it gets hot because the heat from the other floors comes up, and then I'm hot. And so can't fix both things. I think that the body temperature naturally cools down, as I said, when we sleep. Our normal core body temperature goes down, and we need less warmth in the room. We need covers, but we need less room. So most people sleep well. Studies are pretty clear that they sleep better if it's around 60, 65, 66 degrees as opposed to 70 degrees. And many people wake up because they're too warm.
I think that's so powerful. And a lot of people would say, well, you mentioned this. Well, I took a hot shower and that helped. Yeah, because you took a hot shower, you come out of the hot shower, then the body cools down very quickly. So it's actually the cooling effect that's helping you sleep. In fact, I had to review a paper many years ago. I didn't realize, and I had been there to give a lecture, I didn't realize that the country with the most saunas per capita is Finland. Finland has over 3 million saunas for a population of about 5.5 million. So I spoke in Helsinki and Lapland, and they were telling me how the sauna is the elixir, and especially they would use it at night before they would go to bed. And then I began to realize, well, wait a second, that's awesome, but that's like the hot shower effect, right? They go in these saunas, come out freezing cold, jump into bed. And I don't know if you thought that. I just thought that was fascinating when I was over there.
Yeah, I think that anything you do like that is just what you're doing is you're relaxing yourself. It's part of it is mental. You're mentally, if you go into a sauna or a jacuzzi, you're mentally going, it's a diastole, and so you're relaxing. Your blood pressure is going to naturally go down. Your pulse rate's going to go down, and reflexly, as you say, your temperature is going to go down too.
The next recommendation is, I should probably hide these. You mentioned quiet, dark area. It should be quiet in your room and very dark for sleep sex. We won't talk about that extra part, but now here's what I found. I have found the darker the better in the room. And one of the tests I use, because I know when I travel, when I'm in a hotel, if I can read my hand in the room, there's too much light going on. So in our bedroom, I can't see my hand. I can't count my fingers. It's so dark. We've used dark curtains, dark blinds. And I have found that pure darkness really helps. And I find it so interesting that my wife got one of these gifted the other day for her birthday, right? And I can't, I mean, I love these things. People like them. I can't use them. Instead, I just want the room really dark. But the concept's the same, right? The darker, the better, right?
We sleep often because of lack of stimulants that wake us up. And light wakes us up.
But yet we're surrounded by light. I find it incredible that the fire alarm has a light. The extension cord has a light.
Yeah. The nightlight has a light.
The nightlight has a light. And so people need to start getting rid of those or blocking those.
Yeah. Even like cell phones and LEDs have lights. Those things actually change us too. So I read one study, I don't know if I believe it or not, but they shined a laser light, a LED kind of light on somebody's leg, and it changed their brain waves. I'm not sure how far you go with that, but I think that all these clocks ticking, clocks that tick, or little clocks that they're light enough you can see them, that's enough to affect your eyes, and anything that stimulates your eyes stimulates waking.
Well put. Here's one area we didn't get to talk about, but I have put in a lot of attention, and that's mattresses and pillows. Don't you find it amazing? Don't you find it amazing that you spend a third of your life sleeping, a third of it, yet we invest probably the least of anything else in our house? So I have started paying attention to consumer reports, looking at foam, innerspring mattresses, which one's better if you have hip pain, which one's better if you have back pain. And a lot of these societies now rank them. So avocado green, for example, is ranked really high and with some categories, purple. And same with these pillows. And I'm thinking, as of this year, we invested more in the mattress and the pillows, and I feel that's your equipment you're sleeping on the rest of your life. Why aren't we putting more money in that? I don't know if there's a question or a comment there, but I just find it so fascinating that not more people invest in the equipment.
I agree totally. I think for me, the reality is most people are not aware of what equipment they would do best with.
Right.
And I think it's not a one size fits all. I think because of people's maladies, neck, cervical arthritis, or whatever, what pillow is right for you and it may not be the best pillow for me. But I think what I would urge people to do is to try different things and figure out what ergonomically allows them to sleep in the most comfortable way for the most time at night, and not to assume that just because it's a new bed, it's a great bed. Some people do better in a soft bed. Some people do better in a firm bed. And sometimes you got a spouse who likes one thing and you like the other thing. Now, we just actually purchased a new bed for a place up in the Sierras, and they have these mattresses that cool things. The
cooling mattresses.
Yeah. So I think there's lots of ways to spin that, and I think I would urge people to be aware of the great variety of things and the health. I don't know if that's the brand, the Healthy Back Store. There's all kinds of stores now that make things that have memorable foam and so forth. Try things out, see what works for you. If you're not sleeping well, change positions, change structures, change textures. Something's going to work best for you. Do what works best.
Yeah, I can't. We've now tried a bunch of different stores. We tried the Purple store, a Sleep Number bed where someone wants their bed up. I mean, there's a whole game going on out there that is medical that we need to be jumping all over that stuff.
I'll give you an example of that. You got a bed that the top of the bed raises, right?
Right.
And they had reflux. The gastroenterologist said, you got to raise the bed 6 inches high. So they did. And they can't sleep on their back because they've got, sleep apnea. So they got GERD, they got to raise this. So now they're sleeping on their stomach with their back elevated, but now they're in an extension position of their spine and they've got low back pain. And so they're sleeping in a position that helps their GERD, but screws up their back. So you got to, lots of different parameters, but be aware of what you're doing and what it's causing and figure out what works totally for you.
Yeah, there's a science behind this, right? It's almost as if medical teams should go, by the way, what bed did you purchase for yourself and why? And I bet you a lot of people, I don't think a lot of doctors could answer a single brand and why it might be superior for them. I have really found that Consumer Reports has done an incredible job breaking down the different companies, the different beds, the different pillows, and I just couldn't stop reading it. Anyway, that's just my thought.
I like Consumer Reports a lot. Just for that reason.
Exercise. We're moving down your list. Okay. Are you telling me there's some thought that if you exercise in the evening, that can keep you up, that you should exercise in the morning? I'm a morning exerciser. Exercising in the afternoon, evening just doesn't make any sense to me. But what say you in terms of how much exercise and when in the day, ideally, so it knocks you out, makes you more sleepy? And by the way, I think you pressed on it. What I keep telling people is exercise helps you get into those more deep phases of sleep as you get older, because you get robbed of that with age.
Yeah.
And so exercise does a heck of a lot for you. Plus, in the area of urology, we know you get up less at night if you exercise. What's your take-home final points about exercise and sleep?
Studies very clear. It doesn't much matter when you exercise, other than vigorous exercise, max exercise, aerobically, right within a couple hours of bedtime. It decreases your hormones' ability to totally relax everything right when you want to go to sleep. So it ought to be no more than 3 or 4 hours before bed, right?
Yeah.
But studies are pretty clear that people do regular aerobic exercise, not so much strength training, but aerobic exercise that stimulates the cardiovascular system. There's a reflex relaxation component that makes us more sleepy at night. People sleep better. And there are people say, when should I exercise? There's another study that looked at people that are types of people. And they had animals for the different types of people that there were. There were wolves who stayed up later at night, and I forget who it was, woke up early in the morning. But some people are morning exercisers, some people are afternoon exercisers. I tell people, I don't care when you exercise. Do it when it feels best to you and when you like it best, when it fits in with your lifestyle, and when you're less likely to omit it because it doesn't fit.
Yeah.
Well, like you, I'm an early exerciser. What I find for most people is if they put it off, don't do it in the morning, I'm going to do it in the afternoon, something always too often creeps up that seems more important at that time to exercise than exercise, so they don't do it.
That's a good point.
I said, do it when it's not going to do it, like when it's going to be appointment, and you'll do it every day because it's in your appointment book, and you're more likely to do it because it fits in with your lifestyle and your occupation or whatever it is. Some people feel better exercising at certain times of the day. Okay, exercise, make it so that you can do it at that time of day. There's no data, hard evidence based, that says it's better to exercise physiologically in the morning than in the afternoon. It just, most people don't do well exercising right after a heavy meal. So it's got to be at least, a couple hours typically after a meal. But whether you're a morning exerciser, an afternoon exerciser, or an early evening exerciser, it doesn't really matter as long as you do it and you enjoy it and you do it at a time when you're more likely to keep it up.
I like that. You know what the next one is? We're halfway down. We're moving through. It's getting easier. Limit caffeine, especially in the afternoon. Limit caffeine, especially in the afternoon. My take on caffeine, before you say anything, I want to throw this out because you and I often pass ideas to you and vice versa, and then you do some of these tests. I have become fascinated by this newer test that's available online, and some doctors can order it. It's a caffeine metabolizer test, and it's a gene test. It's the CYP1A2 gene in the liver that metabolizes about 95% of the caffeine. Caffeine's also metabolized other places. And what we found is that research has shown, not definitively, but it's shown that there are slow metabolizers of caffeine and fast metabolizers. And through the test, I have friends, these guys, they can pop, and gals, they can pop caffeine at work all night and day, and they sleep like a baby. And I know other people like myself, if I have caffeine after 4 p.m., I'm wired at 2. Yeah. And so what I'm saying is, I'm not saying this is a definitive test, but the CYP1A2 gene test, this is really interesting, and a lot of companies offer them. So if you're one of these slow metabolizers, it might explain your anxiety. It might explain your tachycardia or your fast heart rate. And if you're a fast metabolizer, it might explain why you can have 3 or 4 cups of coffee and not feel anything. So I don't know if you started to use that or you talk about it, but I'm not a big fan of doing a ton of genetic tests or recommending a ton of genetic tests, but I just find this one fascinating because we're all obsessed with caffeine on some level.
Nobody really needs caffeine to be awake, right? Conceptually, many people just have programmed their brain to think that they need it. Otherwise, I'm not going to be awake today. I can't focus this afternoon unless I have caffeine. So if they think that, that's probably going to be true. That's the placebo effect, right? Having said all that, I think you're exactly right. There's some people that tell me, I drink caffeine at night. It doesn't bother me. I sleep fine. Should I stop it? I go, no. If your blood pressure's fine, you're not getting ectopy, you're not getting irregular heartbeat, you sleep fine at night, I wouldn't worry about it. You don't need a genetic test. You're sleeping fine. But if I'm not sleeping well and I can't stop from waking up at night and I can't go to sleep or whatever, and I have caffeine, knock off the caffeine and see if it makes a difference.
To me, in a lot of ways, you're my personal physician for a lot of things. If you ever told me to stop caffeine, I might come over and I might hurt you. Maybe I'll emotionally hurt you with some sarcasm. I'm just saying, I just have to have my cup of coffee in the morning, and then after that, I can slow it down. But I'm definitely, this is a cheek swab. It could be blood, but I'm just fascinated. I would be fascinated to know what your gene test says. I think you and I should get them and come back. I'd like to
get it. Give me information. I like it. Most people do fine. The statistics are 1 or 2 cups of caffeinated beverages a day for people, not a problem.
Yeah, but I just think for those of you out there, if you want to just cut to the chase and figure out if you're one of those slower, fast metabolizers, again, it covers about 95% of the metabolism is CYP1A2 in the liver. But it's one of those tests I just find fascinating. Alcohol and or nicotine. I put yikes.
Yeah.
After
nicotine, there's no problem with that. Stop it.
Yeah. Nicotine, I think, is the easy one, right? People kind of get hit with that, but I don't think people are understanding how even one drink can affect their deep sleep. I can tell you now, I've become so sensitive to it. I had a drink last night and I had trouble sleeping. I'm to the point where I'm getting older. I don't know what your thoughts are, but alcohol really, with some people, I think most people, and I looked at the data, it doesn't allow you to go into deep phases of sleep. So it might knock you out, but you're not getting good sleep. What
Right.
say you?
Alcohol is now, more and more, the benefits of alcohol have been wiped out. The World Health Organization has now declared there are no health benefits to alcohol. So I think we've put that one to bed. So that doesn't mean you shouldn't drink alcohol, but don't do it thinking you're doing yourself a health benefit. Alcohol is now considered to be carcinogenic, and it's just a dose response level. So the more you drink, the more, cancers of esophagus, the entire GI tract, mouth, esophagus, stomach, colon cancer, prostate cancer, breast cancer, all those things are increased by alcohol. And it is a dose response. And for women, especially, even 1 or 2 drinks a week does increase their breast cancer risk, which is interesting. So I think that's where you got to go. Well, what's my family history of breast cancer? Am I at risk for that? What's my genetic testing and so forth? But for sleep, I'm impressed. A couple of things you said. One was, as I get older, most people find that as they age, they don't tolerate alcohol as well. They just don't metabolize it as efficiently. It affects them more. They feel worse the next day. They get a hangover effect where before they didn't get a hangover effect. They get a headache where they didn't before get a headache when they were in college. So I think the reality is that most people, as they age, can tolerate efficiently less well alcohol, and they just have to decrease their consumption. And for sleep, as it speaks specifically, I can't tell you how many people have come in without me asking at all. They've just said, I stopped drinking. It's amazing how much better I sleep. Almost always they say if I stopped, and I thought it would be different. I thought I needed it to sleep. And now I find that it actually interfered with my sleep. And when I don't drink, I sleep much better. And so I think that there's, like I said, there's a stimulatory effect apparently with alcohol. When the blood level falls, that wakes you up, and then it's harder to get back to sleep because it doesn't let you go into that deep sleep. And so I just think it's not a good thing for sleep. And if people have trouble sleeping, I would certainly give it a trial of not having alcohol and see if that makes them sleep better.
Yeah, that's what dry January did in these other dry months. A lot of these people will come back. I've had people in the family that try it. They'll always say 2 things. I can tell you, when I worked in advocacy, I put out a Dr. Moyad challenge: just go for a month. Any month, just try it. And the letters I used to get back were always the same two letters. It was, well, I missed it, but I sleep better and I lost a bunch of weight.
Yeah. And I can't wait to get back on it.
I know. So, okay, these are the last few, and then we're done. This is, you mentioned meals. Some of the experts are saying, I called out everything that the experts said. You said, and some of the societies, they want you to finish meal 2 to 3 hours before bedtime, which makes sense. So you want to talk about that and then reiterate your carb recommendation?
Yeah, the studies show that late night eating big meals, especially within 2 to 3 hours, differentiates, it screws up the architecture of normal sleep. People don't fall asleep as well. They tend not to get into the normal sleep patterns, et cetera. And I'm not sure exactly chemically all the things that are going on, but when your body is spending so much energy trying to digest food, it's taking away from the normal hormonal changes that will allow you to sleep better when you do sleep. So there's no question that late night eating for many people interferes with healthy sleep. And it's probably not only late night eating, it's also type of eating, it's quantity of eating, timing of eating, and what's in the food. It's all those 3 things. So I would say if you're going to eat late at night, have a smaller portion. Don't have a big meal. Don't have it be a heavy meal, especially with carbs, because sugar, again, rises your glycemic index, and that changes sleep and the attitude and so forth in your brain. So you don't want big sugar. You don't want a big heavy meal. And you don't want things that have stimulations effect in them. And probably heavy protein meals, like big, heavy steak, hard to digest. So things that are hard to digest probably at night, not as good also.
Well said. Here's some things I saw. You briefly touched on them, but this again, I just culled all these together, and I'll give these to PCRI too, along with your 10 recommendations. How do you feel about noise machines? I have some friends that use different types of noise machines.
Masking, yeah.
Yeah, masking. If you want to, are you a fan of using a noise machine to sleep? Because I tried one and it just didn't work for me. I have a friend that tried one. It worked beautifully. Where are you with noise machines helping you sleep by drowning out anything external?
Well, the biggest reason for people to use noise machines that I found is people who have tinnitus. When they've got hearing loss and they've got this ringing in their ear and they can't shut that off and they can't stop thinking about it, then the noise machines can kind of drown out the tinnitus, which is caused by hearing loss.
Yeah.
What happens when you have hearing loss? Usually it's high frequency hearing loss as we age. And when you can't hear high frequencies as well, what you do hear is your own noise, which is normally drowned out by the normal stuff that you hear. So anyway, I think if you got tinnitus, then and those noise machines, the ocean noises or whatever, they can try it and see. If you sleep better with that and it helps you, do it. But if there's no other reason and you're just putting noise in there, for most people, no noise is better than some noise. I go back to it's precision medicine. If people say, when I put on that ocean wave sound, that feels better. Just that white noise, it's just a chronic, whatever it is, the noise. They sleep better with that. Do what works.
Yeah, I mean, that's a really good point. This is where Instant Rice comes in, why I always talk to him, and I hope he likes to talk to me. But tinnitus is a major problem in terms of going to sleep. I mean, that's that constant buzzing and ringing sound. It's a big problem with vets, for example, people in the military. They're used to big, loud noises that cause damage. The tinnitus is one of the biggest problems going on in medicine today without a clear-cut, amazing solution, right? So that's a good point, that the noise machines really help with that ringing, drowns that out so that they can get to sleep. I'm glad you brought that up. That's a great one.
The only other people I'd say is if some people, because of stress, they're stressed, they can't shut their mind off, and the periodic wave kind of sounds or white noise kind of shuts off their brain, makes them relax better. So, again, the issue would be do relaxation techniques, learn how to relax, learn how to use the power of your brain to help your own brain relax rather than depending on noise to do it. But if noise helps you do it, and that's a problem for you and helps you shut your brain off and just, be like a mother's breast sound, do it. If it works.
Yeah, I mean, the noise machines now is a whole new science. There's different types of noise.
Yeah.
It can be applied to help you sleep. It's fascinating. And a lot of that's over the counter. So nasal strips, I put a question mark.
Yeah.
You know what I use nasal strips for? I use them when I sometimes go for long runs. If I'm a little congested, I feel like they help me breathe better. The downside of nasal strips is I already have a pretty big nose. And when I put on a nasal strip, it makes my nose look even bigger. And so I don't want my nose to look bigger than it is. It's already big. So how do you feel about nasal strips? I mean, do you even recommend them for sleep?
If nothing else is working and people just they tend to be mouth breathers because their noise often is people with congestion. They've got allergies or something, or they've got nasal polyps, they've got chronic sinusitis. The nasal strips can help them get a little more, but I tell them try it. It's not a one size fits all again, but if it helps, do it. No problem.
Yeah, and what I learned,
no downside.
I mean, what I learned is you just got to clean your nose off first. Otherwise, it doesn't, when you put the adhesive strip, it doesn't pull correctly or it falls off. So I'll clean it and I'll use it when I go running, but I wish I could use it at sleep. I think I scare my wife when I put that on at sleep. I look scary.
I'll tell you one thing that our ENT guys have really emphasized with me is that many people who can't breathe well because they've got congestion or nasal polyps or whatever, or sinusitis that's chronic, if they use saline nasal irrigation before bedtime.
That's a good one.
Now that helps really well because it just people see this kind of seems funky. You're just squirting this thing and it comes out the other side. It doesn't feel, but people that do it, they swear by it. So sometimes if congestion is the problem, saline, warm, lukewarm, nasal saline irrigation, just with a squeeze bottle, both sides, 5 minutes right before you go to bed, can make a big difference in how well they breathe.
Ooh, that's a good one. I had a call last night from a friend in California who's having sinus problems. I said, "Are you using Simply Saline?" That's what I use. I use a
Yeah.
metered spray. It's one of the most popular brands at CVS and Walgreens. It's cost effective. I don't use it that often. I use it once in a while because you can also overdo it. But, it's a sterile metered spray. Boom, boom. It drains. There's no prep time. And that's a good
Yeah.
one. Those have really been game changers in the over-the-counter world. Here's a term that's thrown out in medicine so much, and I'm going to tell you and you talked about it. And this is mentioned in the cancer world. And so let me just put this up here. Cognitive behavioral therapy for insomnia. All right. If you look at a ton of medical journals, I don't know if this is PC or what it is, but everyone says before doing anything else, before popping any pills, going to OTCs, prescriptions, all the experts agree that the most effective way and the safest and healthiest way to work on your insomnia is cognitive behavioral therapy for insomnia. Now, the reason I first of all found that interesting is that in cancer-related fatigue, which is in the cancer world, fatigue from cancer treatment is an epidemic problem. And people are always asking what to do. And there's a variety of recommendations, but in the largest review that was ever done, that was published in JAMA, they found two things were very effective for cancer-related fatigue from treatment. One was exercise. Not overdoing it, but getting exercise was a reboot, gave you more energy. And the second one was cognitive behavioral therapy and kind of just change. So here's how I looked at cognitive behavioral therapy. I think this is also a way of saying somewhat sleep hygiene. It's teaching you about sleep, but I just want I want to end on this because if you pick up any journal, if you look in AI, it's recommended for first line therapy in sleep by everyone. Can you finish with this and tell me why this is really so powerful? CBT. I'm not talking about CBD. We didn't talk about marijuana, which I'm
Yeah.
sure you don't recommend for sleep either, but CBT, and that's how I think we should finish it, unless we should finish.
No, one of the most underappreciated things in medicine today is the power of our brain. And we give away oftentimes the power of our brain to determine how we feel to the world, to circumstances, to people we're affiliated with, to relationships, to our economic problems, whatever. The power of our brain, the power of our ability to choose our attitude and to use the placebo effect of expectation by deciding how I'm going to expect to feel, and by reframing my experience to be a positive experience for me rather than a negative experience, is really, really powerful at changing our brain neurochemistry. And Viktor Frankl said it best years ago. He wrote Man's Search for Meaning. He said they can take away every one of your freedoms except your last freedom. They can't take your last freedom away from you. And your last freedom is your freedom to choose your own attitude in any given set of circumstances. So our ability to happiness is an inside job, and people expect to just be happy because they've always been happy or whatever. And when life hits them in the face, it's easy to blame the world for how lousy we feel or what our outcome is. And the really healthy person is the person who has the ability to internally choose my state of mind in any given set of circumstances. So if I'm not sleeping well, I can very honestly choose to sleep better by deciding that I'm going to sleep better, by reframing the experience. And rather than focusing on, I'll give you an example. I have an arthritic thumb, right? And it's one of those things I went to my PRP guy, told me PRP isn't going to help that for this particular thing that I've got. It's osteoarthritis, and it aches all the time. Not a lot. Yeah, I'm aware of it. If I don't focus on it, it doesn't hurt me at all. But if I want to sit there and look at my thumb, I can feel the pain right now in my thumb just by thinking about it. If I choose to focus on my thumb, it can screw up my night's sleep. And it has. But if I choose just to ignore it, and I'm going to accept that, I can't change that right now. It is what it is. I'm going to focus on something else. Then I have the ability to set that aside. So cognitive behavioral therapy is understanding, I think, with cognition, what behaviors I have, both body and mind, that I can employ to put myself in a position where I can relax, I can accept what is, I can experience the feelings that I want to experience in the way that I want to experience them, and I can choose my outcome. There's a guy named Mihaly. Do you know, have you ever heard Mihaly? He's a Czechoslovakian guy. He's a emeritus professor now at Claremont Men's College. He coined the term years ago, the flow state. And flow turned into, in athletics, the zone. You know, athletes say, I'm in the zone. Well, the flow state was a state of mind where everything just seemed to be flowing perfectly well. Time stood still. You're loving what you do. You're totally in the moment. You're immersed in something that's meaningful and purposeful for yourself. And that's the state of flow. And what he said was about inner experience. He said, he who can control his own inner experience can come about as close as anybody can possibly come to being truly happy. And I think that's it. CBT is about learning how my body and my brain work, what I think of life, how I can reframe my experience in life to be in a way that cooperates with my own values and goals and what I want to do, and put myself in a position of peace and love and forgiveness and joy. And by framing my life like that, like I said, focusing on counting blessings, not sheep, just if there's all kinds of stuff in our world that we feel badly about, but there's so many things in our world that we're blessed for. You can't count the blessings of my life, where we live, the weather we have, the water we have to drink, the food we have to eat, the friends we have, the education we have. Worrying about my thumb is getting it out of perspective. That's what, cognitive dissonance. That's what one of the things I said about sleep was, when you're sleep deprived, you have lack of emotional categorization. I don't have the ability to put things in proper perspective because everything irritates me because I'm sleep deprived. CBT, I think, is about reversing that, using the power that is in our brain and present for all of us, focusing on our feeling state rather than our brain state, to allow us to feel good and enjoy our life, and to focus on what I can do, not what I can't do, what I can do to help myself feel better about myself and my life, and have a great night's sleep tonight because I deserve it and I'm worth it.
Yeah, that's really well put. So what I learned, what I have learned is that CBT, cognitive behavioral therapy, there are sleep professionals you can meet with on multiple sessions. They'll do it. But I've also found that over Zoom, just doing it on the computer with a sleep professional apparently has been pretty effective too. And they're saying, anywhere from 5 or 6 sessions. So it's multiple sessions, meeting with a professional, reframing, and they also provide sleep hygiene tips. They also talk about a lot of the Dr. Instant Rice tips, and that's all combined in this web-based situation or one-on-one situation called cognitive behavioral therapy. And I think you put it best. It's practicing to reframe things. And a lot of us at first go, what can that really mean? What it can mean is that, what's the one thing I always hear? It doesn't matter. Family, friends, you name it. The advocacy groups. I can't sleep because I ruminate. I can't turn my brain off. My brain keeps going, right? And I think cognitive behavioral therapy helps you no longer ruminate. It helps you quiet down, helps you perceive it differently and look at the glass half full. But that takes practice. I think people think like, I'm just going to think positive and be positive. So I think you said it best. So it sounds like you send patients for cognitive behavioral therapy a lot.
Well, and also, one thing that's very parallel to that is mindfulness meditation.
Yes.
Mindfulness meditation, very much aligned. Just learning the power that's in my own mind to allow myself to just focus on relaxing and breathing and being present, fully present in the now, not worried about yesterday, what I did, or afraid of tomorrow. I'm just focused in the now, and I'm fully present for myself. Like you said, it's a skill set, and you can learn that skill set, but it does take practice. And in practice, you actually do change your brain neurochemistry. And that's the power.
And that's the power of the scientific method too, because that's what stunned me, that CBT, cognitive behavioral therapy, tended to beat out everything else. And it became the primary mode, the safest and most effective mode of helping you improve your sleep and reduce your insomnia. And I just thought, I have got to bring this up with Dr. Rice. And then when you mentioned it, I thought it's the best way to end, because what greater message to leave the audience than, if you don't think lifestyle makes a difference, look at the world of sleep medicine. The dominant theme is the most effective intervention is not a pill. It's actually working with a professional and becoming more mindful, becoming less stressful, less anxiety, and practicing how to think before you sleep to sleep better.
Harnessing the power within. It's already there.
You know, it's so funny that you just talked about this. When I was getting my computer ready today, I had to move aside a book. Not that I read this book all the time. It's just people give me this book. They give me all sorts of books. It was the teachings of Buddha. So I thought, and now we're ending on this. That's kind of what we're talking about. It's that quieting the mind. So here we did it.
I'll show you.
Oh, there you go. There you go. That's right. So look, and plus then all those awards. So we covered it, the Fahrenheit and Celsius temperature, the quiet, dark, the mattresses and pillows, the exercise, the limit caffeine, the caffeine test, the alcohol or nicotine, finished meals, low carb, noise machines, nasal strips, and then we finished with cognitive behavioral therapy. Just so people don't think that we're saying CBD and marijuana, you're not saying use CBD or marijuana to sleep. We're saying cognitive behavioral therapy. Am I correct?
Bingo.
Why do you think CBD is so popular for sleep?
Everybody wants the magic pill.
Yeah, isn't it funny? Everyone thought it would bore out. I mean, I know it helps some people some time, but in the studies have been kind of
the placebo effect of any of those things for chronic whatever are very, very significant.
Yeah. Anyway, well, people aren't going to like us for this talk if they want to make a lot of money off of it.
I know. Well, there's uses for everything, but I think
We're useless.
You got to look at evidence-based information.
Did I miss asking you something about anything?
I think you did it. I think you did a good job. You pretty much covered the waterfront.
Rule? Did you like my rule before we started? I said, we're going to do this in 30 minutes. And I think we did an hour and a half of Q&A. Once again, I'm accurate as ever. I'm only an hour off.
Usual. As usual.
So before you leave, we want to give everyone a present. And what do I give the guy who has everything? I thought, well, we'll send this to you. And I am really reluctant to send this to you. So just so you know, it's new. It's got its. So here's what we're going to do. We're going to send you an official USC football cap, because I know you like to go to the games. You know, this is painful to just hold. I feel like this is somewhat.
I know it's hard for you, isn't it?
Terrible. It's terrible. It's almost as bad as this. If you don't think people like to razz me, I keep showing them this. There was an ex-Ohio State player just sent me, you can't get these caps. These are ex-players. He sent me one of his caps. And if everyone's like, you got to throw that away, I'm going, I'm not throwing this away. I might not like Ohio State one day a year, but I don't mind them the rest of the year. So same with USC. I love Ohio. I love USC, Lee, Dr. Rice. I just will not like them in October when they play Michigan, and we're gonna go to that game together. But
okay, I'll wear it.
USC, for your lecture, I thought, to make myself feel better, this is reframing. This is perfect. I thought USC should stand for something else after the Dr. Rice lecture. It should stand for "You sleep comfortably." Oh man! Right?
Good job. Good job.
Oh my gosh! Drop mic. Don't hand the mic. Pick up the mic. How brilliant is that? So we're going to send you this cap. It's new, but I want you to remember that you're USC. You're helping us sleep more comfortably.
Thank you.
Thank you. It's always an honor. The great
blessing. Always
an honor. And I will see you at the game.
Okay.
And we can root for our own team, but I think I'm sitting in the USC section, so I'll pretend to like USC. Thank you so much for covering this. This is a power lecture, and I thought a good Q&A, and hopefully we'll do this again, maybe a part 2 or something else in the future.
Whatever. We'd love to. Thank you.
Thank
Cheers.
you.
Okay. Bye. Have a great day.
Thank you, Dr. Rice, and thank you, Dr. Moyad. That was really great. If you would like to learn more about Dr. Rice and the foundations he works with, the nonprofits, and the education that he's produced, you can go ahead and check out our exhibit hall on PCRI.org for this conference. And it's just a really great way to stay educated in a lot of senior men's health issues. Now, our next session is something that's a little different, and we've never done anything like this when it comes to prostate cancer or senior men's health. I'm really excited about it. A couple of months ago, Dr. Eugene Kwan, who has written the Combat Manual for Advanced Prostate Cancer for PCRI, it's kind of a DIY video series where he's come in and he has broken down advanced prostate cancer topics, what people need to know for imaging and what people need to know for side effects. He's just done an incredible job. He came to us and said, hey, you guys are doing a lot of work in just helping men get access. Well, one of the biggest points of access is insurance. And insurance denials are something that every patient may come across in their time when it comes to having prostate cancer. And he was talking about that he has two incredible people, Dr. Nancy Way and soon to be Dr. Lauren Rhodes, who does do a great job using AI models to teach patients and help patients fight insurance denials. So how to write the letters, what are these AI models, what's ChatGPT, what is Gemini? These are really powerful tools that, when it comes to artificial intelligence, I think it can seem a little scary as an older patient just using something that's so new, but they're going to break down just how do you do it. You're going to hear words like models as far as what the names of the sites are, and prompts, which is how you write a question into these and how you ask it to formulate these letters. Dr. Mark Moyad does an incredible job just going through the details and simplifying it for us on how do we use these, how is it beneficial, how can caregivers use them, and what you need to know. So this is kind of a bigger part of a series that PCRI is going to be doing. We're also going to be talking about it in September, where we talk about the power of just not accepting an insurance denial right away, coming back, reapplying and saying, hey, here's the NCCN guidelines, here's what I can do. And we're really excited to present this today. I want to give a special thank you to Dr. Mark Moyad because he's done an incredible job helping to develop this curriculum, and also to Dr. Eugene Kwan for going above and beyond to provide patient care and education on a whole new level. This is just a new adventure for us and we're so excited. And also to Dr. Way and to Dr. soon-to-be Dr. Rhodes, because their work is something that's going to be really impactful and practical for a lot of you patients, and so we're very honored to have them today. Without further ado, here is insurance reimbursements at NAI.
Hello, everyone. Dr. Way and I would like to thank the PCRI for giving us the opportunity to speak, and we would also like to thank Dr. Kwan for introducing us. Since beginning work in Dr. Kwan's clinic, we have become familiar with the insurance denials that patients receive. We understand that, unfortunately, these denials can be intimidating and make you feel powerless. That inspired Nancy and I to make this talk so that patients like you are familiar with the tools you can use to help write appeals for your insurance denials. We believe that you all, as patients or loved ones, are powerful forces in the care that you all receive. And making appeal tools more accessible and personalized to your needs is a great way to amplify your voice in the healthcare process. While our talk will focus on prostate cancer care, these methods can be used for any health insurance denial that you can receive. We will also have a pamphlet released in the fall summarizing our talk and with some resources for writing your own appeal letter. I'm going to introduce okay. Sorry.
Hi everyone, my name's Nancy Way. I am a doctor from Australia. I'm currently working on Dr. Kwan's team at the Mayo Clinic as one of his research fellows. Again, thank you PCRI for the opportunity to talk. And I'll let Lauren take you through the first part of our presentation.
We also want you to know that this is only one pathway to go about insurance denials. There are a wide variety of resources that you can use to help you appeal your health insurance denials, all of which can be used in tandem with AI chatbots. Writing an appeal letter with AI won't hurt your chances of getting help from other sources like your physician, HR department, unions, social workers, or nonprofits. Writing your own appeal letter with AI can be a useful tool for sources of help to use as a jumping off point for their own supporting appeal letters. At best, your appeal letter will be used to inform other members of your care team. And if you would rather go about this process alone, you'll still have a well-written appeal letter at your disposal. We want to stress that you do not have to go through this process alone, and we actively want you to use any and all resources available for you to appeal these denials. Our talk has 3 main points, all of which focus on health insurance denials and available AI chatbots. Part 1 details the basics of AI chatbots and some specific models that are publicly available. Part 2 dives into insurance denials, helping you understand your own denial letter and what you should do to improve your chances of a successful appeal. And finally, Part 3 is where rubber meets the road, and we'll actually use AI chatbots to draft and appeal edit letters. Now that we know our outline, let's dive into what chatbots are and the specifics of some models. AI chatbots are computer programs designed to accept and answer questions in layman's terms. You probably used a simple chatbot before, like when interacting with a customer service agent online. AI chatbots like ChatGPT are far more sophisticated models than these customer service bots. These AI chatbots, technically known as large language models or LLMs, can understand long and complex questions, provide detailed answers, and even write paragraphs to be used in insurance appeal letters. Think of them as highly advanced research assistants that you can access through your computer or smartphone. Before getting into the nitty-gritty of individual AI chatbots, let's first discuss how AI chatbots learn so much about a wide variety of subjects. This will be an extremely broad discussion of training and refining AI chatbots. The actual process can take years before any AI is released to the public. These chatbots learn very similarly to how we learn, so I'll be comparing the way of learning to ours, so it's a bit easier for us to understand. So let's talk about training an AI chatbot. These AI systems learn from vast amounts of text from the internet, such as books, articles, and many other sources. They've essentially read millions of documents, including medical literature, insurance information, legal texts, and discussions about healthcare systems in order to generate arguments and responses to your questions. Basically, the AI is like a student of every subject in the world. Right now, the AI, just like us students, is studying materials from class to get a better understanding of the topics. Next, human trainers provide examples of helpful, accurate, and safe responses to various questions. The AI learns to mimic these good responses. Without seeing examples of accurate and helpful responses, the AI might not know how to answer your questions in a clear and concise manner. Think of this as like the AI is completing some practice problems after attending class. It's working on new problems, but still has access to the answers if it needs them. Finally, the AI is given freedom to answer new sample questions. The AI still receives feedback from its programmers as to the accuracy and readability of its responses, but now the AI is being fine-tuned. The majority of the work has already been completed. Once the AI is consistently producing quality responses, it can be released to the public. Of course, as with anything digital, all AI models are constantly being refined and updated to know the most up-to-date information and present that information in an understandable way. This is like the AI taking a final exam. It has studied how language and grammar work, and it has seen some practice problems and responses. And now it is time for the AI to generate responses to new, unseen questions. So as an overall statement, we want you to think of these AI chatbots as very intelligent helpers who have memorized a lot of information on many topics. Now that you have a general idea of what a chatbot is, we'll get into some of the major AI chatbots on the market. But before we get into that, I want to make something very clear. All of these programs are completely free. While some chatbots have premium versions, you do not need to use them for writing appeal letters. You don't need to spend any money on what we'll be doing today. We'll be going over 3 chatbots that are currently on the market. These aren't the only available chatbots on the market, but they are some of the most well-known and user-friendly options available. If you or a loved one have a different chatbot that you would like, you can almost certainly use it for writing appeal letters. We'll begin by discussing ChatGPT. Its popularity makes it well-known and constantly updated, but it can be slow if a lot of people are using it at the same time. If you have ever heard of an AI chatbot before, it's probably been ChatGPT. Then we'll move on to Google Gemini. Its integration with Google searches and Google applications is extremely useful, but it's not always the most human-sounding. We'll end with discussing Claude by Anthropic. While it's not as widely used as Gemini or ChatGPT, I personally find it very easy to understand and easy to use. Now that we know what we'll be talking about, we'll get into the specifics of each chatbot model with some advantages and disadvantages of each. We'll begin with the most well-known chatbot on the market, ChatGPT. It's available at the website on the screen, chat.openai.com. We'll discuss the advantages and disadvantages of ChatGPT. So first of all, ChatGPT is easily the most accessible chatbot as you do not need an account to begin using the program. All you need to do is navigate to the website and start asking questions. Another benefit of ChatGPT is that it is connected to the internet, meaning that it links all sources it used to generate its answers so that you can verify the truth of its responses. Finally, it has iterative capabilities. Now, that's a very scary word, but it just means that ChatGPT can remember the conversations you've had with it in the past and reference them in your current conversations. This means that you can take a break while using ChatGPT and come back later with no setbacks. While ChatGPT is easily accessible, it's not without some disadvantages. First, you only have a limited amount of messages using ChatGPT's most refined AI model. This does not mean that you only have a limited amount of time to use ChatGPT. It just means that you can't always use the most up-to-date model. Second, since ChatGPT is the most popular model, it gets used a lot all of the time. During popular hours of the day, usually around mid-morning, ChatGPT might be slow when generating responses or your appeal letters. It still works, but the extra time is very noticeable. Finally, ChatGPT struggles with large amounts of text, meaning that you'll need to be concise and clear with your questions and requests. You probably also run into Gemini before when searching something on Google. While the Gemini you've encountered in Google searches can summarize information, the model available at gemini.google.com is much more advanced and can write things like appeal letters. Since Gemini is owned by Google, it can write into any Google application, like Gmail or Google Docs. This is useful because you won't have to worry about copying and pasting your final document into a Word file to print or email out. Additionally, Gemini can be integrated with your Google search history. This means that it can predict what you're working on by seeing what you're looking up online. Finally, the newest model of Gemini is connected to the internet, meaning that just like ChatGPT, it can provide links to sources it used to generate your appeal letter. While Gemini is very advanced and user-friendly, it doesn't come without some downsides. Firstly, while it is connected to the internet, some newer or experimental models are not, and thus they wholly rely on the databases they were trained on, meaning that sometimes Gemini will only know information from January 2025 or earlier. On a personal note, sometimes when I've used older Gemini models in the past, the AI model will sometimes forget that it's connected to the internet and doesn't link its sources. Further, this model is a bit more focused on research and might come off a little cold or inhuman. Finally, you will need a free Google account to use the premium or pro versions of Gemini. Once again, the free version is absolutely okay for our purposes. Finally, Claude by Anthropic is our last option that we will discuss today. It might not be as well known as Gemini or ChatGPT, but it's another user-friendly option. It's available at the link on screen, claude.ai. Claude's strengths really center around its user-friendly interface and tones. Claude has physical buttons that allow you to change its writing style with just a click of a button. You can ask it to have a more creative or human-like style or a more research-heavy, straightforward approach. Further, Claude can process large amounts of uploaded text, which just means that it can process more words than other models on the market. Finally, Claude has a very flexible model that can create visualizations of data. So regardless of how you learn, understand, and convey information, Claude's flexibility is a great plus. Claude also has iterative capabilities like ChatGPT and makes copying documents or writing easier as it can create separate sections for writing appeal letters. However, while Claude has an approachable interface, it's not without some downsides. The biggest is that Claude is not connected to the internet. This means that it cannot link the sources it used to create its responses. This just means that you might have to spend a little more time trying to find outside sources that are legitimate and support your claims. Further, Claude is not always up to date. Its last databases were updated in March of 2025. This means that Claude is aware of most things that happened before March 2025, but it might not know everything that has happened since 3 months ago. Of course, programmers and developers are always working on future updates, so Claude will continue to be updated with more recent information. Finally, Claude, like Gemini, requires you to make an account before having full access to the program. Once again, this account is completely free and only takes a few minutes to make. All of these tools are accessible online on your computer, tablet, or smartphone. They all currently offer free and premium versions. While the premium versions may offer more models with advanced research or writing capabilities, the free versions are more than capable of completing the tasks that we will be describing in this presentation. Before moving on entirely, we want to make sure that you all know some safety and privacy tips for using AI chatbots. AI chatbots can be a great help, but you need to be careful about the validity of AI-generated information and what you should share with AI chatbots. So first, it's very important to understand two things about AI and the information they generate. First, AI chatbots don't have any personal experiences and are only aware of the data available to them. This means that they can present biased information as completely true simply because they haven't been exposed to conflicting information. Further, AI chatbots have some very impressive reasoning capabilities, but they are not foolproof. Chatbots can hallucinate information that does not exist and is not true at all. Sometimes this means that they make up false sources or present false conclusions in a very convincing tone. So we want to stress that you should always carefully read through everything your AI chatbot tells you and do your own research on the sources and arguments that it provides. And before we move on, a quick note about privacy. You should always only share information that you are comfortable sharing with the AI. Real people might read and review the conversations that you have with the AI for training and refining purposes. Any personally identifiable information, like your full name, address, insurance ID numbers, social security numbers, or anything else that you don't feel comfortable sharing, should be removed from your prompt. Remember that you can always edit and add more information to your appeal letter after the AI has generated the letter, and you should never, ever feel like you must tell an AI model personal or secret information to generate your appeal letter. So now that we know all about the basics of AI chatbots, I'll turn it over to Nancy so we can learn more about insurance denials for prostate cancer.
Thanks so much, Lauren, for giving us a very comprehensive overview of some of the chatbots that are available on the market. Now that we understand what AI chatbots are and how they can help us, let's take a look at the challenge that they will be helping us with in part 2. And the reason why you've all tuned into this talk is insurance denials, particularly for prostate cancer care. Now, we understand that receiving a denial letter from your insurance company can be confusing, overwhelming, and frustrating, all while you or a loved one are already dealing with significant health challenges. And that's why we are providing you the tools so we can all tackle this together. But before we get into how we use chatbots like ChatGPT or Gemini to write a letter, we first need to understand how to read these insurance denial letters to improve our chances at a successful appeal. So first up, the denial statement appears early in the letter and states that your requested service or treatment is not approved. This is usually given in very plain language, in one very brief sentence. So examples of this sentence would be like, quote unquote, your coverage for your requested service has been denied, or something like your claim for a medical service has been denied. So typically the reason for denial follows the denial statement and explains why the insurance company is refusing coverage. This is the most critical part of the letter because your appeal must directly address this specific reason. Policy references will cite specific sections of your insurance policy that the company believes justify their denial. These might be labeled as something like medical policy number or coverage guidelines. The reasons for denial might not be as clear-cut as it is in the denial statement, and they can come in many different forms. The reasons might be presented in a list format, or they might be hidden within other technical language within the denial letter. Some examples of language to look out for could be, this procedure is not medically necessary because so-and-so. An example within prostate cancer might be your PSA is not high enough, or another option like conventional imaging is preferred. The appeal rights information section on your letter will outline how to appeal the actual decision, including important deadlines. Most insurers require appeals within 1 to 6 months of the denial date, so make sure to write this down in your diary for later reference. If you contact your physician or their practice for details, note this date as well so that both parties are aware of all the expected deadlines. The way that this information can be presented is quite variable, so be careful when reading through your original denial letter, as there are various deadlines for different appeal types, which we will go through in a bit. Let me emphasize something crucial. Always read the entire letter carefully. The real reason for your denial might be buried in the middle of a paragraph or within some confusing and complicated language. Sometimes there are multiple reasons given, and you'll need to address each one in your appeal letter. All right, now that you know how to read your denial letter, let's discuss a few common reasons for denials in the context of prostate cancer care. By knowing what language to look out for, you can provide the best prompt to put into your AI chatbot, and you can feel confident when reading and editing the AI's appeal letter. So, one of the most frequent reasons for denial is that the insurance company doesn't consider the test or treatment medically necessary. This is particularly common for things like advanced imaging, such as PET scans that your doctor might have ordered for you. Insurance companies often claim these are only necessary in specific scenarios. They might require your PSA to be at a certain level or ask for evidence that standard imaging, such as a CT scan or a bone scan, those sorts of older types of imaging, were insufficient before approving these advanced PET imaging techniques. So in this case, you'll want to look out for language that says the requested service does not meet medical necessity criteria, or standard imaging is considered adequate for your clinical situation. Next up, another common reason is unapproved treatments. So insurance companies might deny newer treatment approaches, things like genetic testing, or therapies that are considered out of sequence when you try a new medication before being prescribed its predecessor, for example. This could be because the treatments are so new, the company hasn't updated its policies yet, or because your insurance doesn't think you need that particular therapy yet. So in that case, you'll want to look out for language in the letter that says this service is considered experimental or investigational and is not proven to be effective, or something like this service is not covered until after documented failure of first-line prostate cancer therapy. Another reason that you might receive a denial is something called prior authorization failures. So insurance companies may deny coverage because there was not enough information supporting your need for therapy or imaging. Your doctor's office might have forgotten to submit some important paperwork, and while you might not need to write an appeal letter for that particular reason, AI can still help you figure out what information is missing. So in that case, you might see language that says required prior authorization was not obtained, or insufficient clinical information was provided from your doctor, something like that. Next up, this is, if you've not been paying attention, this is where you want to perk up your ears and listen in. Here is an actual denial letter that a patient in Dr. Kwan's clinic received. So we want to thank this patient, and we've also removed all identifying information here to be clear. While your letter might not look exactly like this one, all letters have the same information, just presented slightly differently. Let's go through this example together so that regardless of what your letter looks like, you'll be able to understand what your denial letter says. First, the plain denial statement is highlighted in yellow, as you can see by the red arrows. It says, your request was denied, in bold letters. Additionally, after giving a general reason why, the letter once again says that we cannot approve this request. Next, the reasons for denial we've highlighted here are in pink. You can see these are laid out in a very clear list-like format, and that these reasons are some of the common ones we've touched on before. The patient's PSA values did not rise over a certain period of time. The insurance company has determined them not to be a candidate for a treatment called salvage local therapy, and their PSA is currently too low. This letter is clear and concise in their reasons for denial, but not all letters are like this. Regardless, take the time to read everything in your letter and highlight your reasons for denial if you need to, like we have demonstrated here. Finally, the appeal rights information is highlighted in green. At the top of the page, you can see that this patient has 60 days to submit an appeal for his denial. The section below emphasizes why reading the whole letter is very important. As you can see, the patient has two different appeal options, with different requirements between a fast and standard appeal. Remember, your denial letter may look like this, or it may not be as clear. Regardless of what your specific letter looks like, remember always to take your time to read and understand every sentence in the denial letter. If needed, highlight the different sections like we've done in this example. Being familiar with your denial letter will ensure that your appeal will encompass all of the reasons that you've been given for denial. Before we show you an example on how to use chatbots to assist in writing the appeal letters, let's identify what you can preemptively complete to make the process as simple and streamlined as possible. So we would recommend that you get all of your diagnostic information all together before taking the next steps with the AI chatbots. So this includes collecting information on your initial diagnosis date, your cancer stage, your Gleason score, and PSA history over time. These are the fundamental facts that establish the severity and progression of your condition. If you don't have any of this information, feel free to reach out to your provider to get their assistance. We'd also recommend getting a complete treatment and imaging history of your prostate cancer. So we'd suggest compiling a chronological list of treatments you've already undergone or surgeries that you've had, even things like radiotherapy, hormone therapy, or any other interventions that you've received. This history helps demonstrate why the denied service is the appropriate next step. So you'll want to gather reports from any previous scans that you've had as well. This includes things like MRIs, CT scans, bone scans, or other PET scans you may have had. This history helps demonstrate why the denied service is the appropriate next step. So gather reports from any previous scans such as MRIs, CT scans, or bone scans. If your denial involves advanced imaging like a PSMA PET scan, for example, you'll want to show the limitations of previous conventional imaging. This can be crucial. So your doctor's clinical notes will be a great resource for this information as well. Finally, we also suggest looking into peer-reviewed literature. So this is things like articles from medical journals showing that the requested service is standard care for your specific condition, and this can be powerful evidence to back your appeal letter. So your doctor or their team may have or know some studies or literature to support your appeal. So reaching out to your provider or a quick Google search will help point you in the right direction to find scientific articles or literature to support your letter. Where possible, you can also reference any medical association guidelines. An example we provide is the National Comprehensive Cancer Network at nccn.org, which is free to access. And they have very comprehensive patient resources and also clinical practice guidelines that can be quoted. They cover many different cancer types, including prostate cancer. Referencing medical studies or guidelines improves your chances of getting your denial overturned. Now, we know this is a lot of information to compile all at once. In the wise words of Dr. Moyad, who's joining us today, you should think of your health records a lot like your tax returns. Having to collect years of records in a short amount of time might be overwhelming, but preventatively keeping well-organized records for yourself or with the help of a loved one will make this entire process much easier. If you do not have these records compiled, reach out to your provider's office to ask for some help compiling them. And now I'll hand it back to Lauren, who will take us through part 3, where we actually get to use the AI chatbot to help us write these letters.
All right. Thank you, Nancy, for giving us that information about reading your own denial letter and understanding all of the different parts and compiling information that would be useful. So now that we all understand AI chatbots and some common reasons for insurance denials, let's bring it all together. In this section, we'll explore exactly how to use AI chatbots to create effective appeal letters that have the best chance of overturning those denials. With all of the documentation that you've collected, you're already way ahead of the game. The key now is translating all of that information into a compelling, logical argument that addresses the specific reasons for denial. This is where AI assistants really shine. So, as exemplified by the title of this slide, quality in, quality out. Your appeal letter rests on the information that you can get and tell the AI. Remember that your AI does not have personal experiences with insurance denials, being sick, or having prostate cancer, so it cannot pull from anything outside of your specific circumstance. By compiling important information and presenting that clearly to your AI, you are setting yourself up for success. We have 2 main tips related to this. First of all, be specific about what you need. Talk to the AI like it's a person. Use full sentences and be as specific as possible. Instead of saying appeal letter prostate cancer, write something like, I am diagnosed with prostate cancer. Here are some exact details. Please write an appeal letter for my insurance denial. Second, provide relevant context. Just as Nancy pointed out in the last section, compile your health records with special attention to imaging, treatments, and responses, and some medical journals or guidelines to support your point. Now, while the information in your letter is incredibly important, it's not the only important part of your letter. Your appeal will also need to present the information in a clear and respectful manner. The AI model you pick out can also help you with this. This is very simple to do, but here are two main things that you should look out for or ask for. First, specify the format that you want of your letter. Request a formal letter format with your information at the top, the insurance company's address, proper subject lines, and your doctor's information. And second of all, indicate the tone. Appeals should be professional, fact-based, and respectful, but still assertive. You can directly ask for this tone. Now that we all know what you should include when you talk to your AI, we have provided a very general format for you to fill in with your own information and submit to AI chatbots. This covers the basics of what your prompt should be. It allows you to fill in your diagnostic information, your treatment and imaging history, current visit information, and any other things you feel are important. It also has space for you to elaborate on your insurance denial. Remember to include pertinent information that you feel comfortable sharing. This sample prompt keeps your message very clear and concise, which helps your AI chatbot stay on task and reference the most important patterns and themes to your treatment and responses. On the next slide, we show you an example of a filled out prompt. The only thing we did was fill in some sample information. We did this by copying the template into a Word document, then filling in the blanks with the relevant information. This generally should be what your prompt looks like. We recommend that you write out your prompt in a Word document, such as a Google Doc or something similar. This way, you can edit your prompt and make sure that it's perfect. Then, after you've prepped your prompt, copy and paste it into ChatGPT. I wouldn't recommend trying to write out the whole prompt into ChatGPT, mostly just because the text box is pretty small, so editing large texts would be complicated and it can be easily avoided. So on this slide, we have a real-time video of us using ChatGPT to generate a full appeal letter. While the actual process of writing and editing this letter only took 1 minute, we will go through and point out some important steps and details to notice. So first of all, we will begin in a browser tab. This is something like Google Chrome, Firefox, or Microsoft Edge. I'll type in the link to ChatGPT, and we are brought directly to the main page with a text box that says Ask Anything. So in that rectangular box, I paste the entire prompt that I filled out on the previous slide. I did not change anything from the previous slide. All I did was copy it and paste it in ChatGPT's text box. I give you all some time to read it just so you can be familiar with the text box size and how to work with ChatGPT before hitting enter. I'll then hit enter and you'll see ChatGPT immediately start writing a letter for you. So as you can see, I'm just going through, showing you the exact prompt. And then right there, you can see that ChatGPT asks me to log in, but I can also click the option to stay logged out, showing you that what I showed you before, you don't need an account to use ChatGPT. And it'll start writing it in real time. It's just thinking right now. And as you can see, it's begun writing your letter in real time with the formatting first. So since we asked for a professional tone and format, the letter automatically has those qualities. And as you can see, the letter is written in plain language and references all of the information that I put in that general format or prompt that I submitted to ChatGPT. It gives it in a very professional tone, and it lays out all of the treatments that this particular patient has already undergone. Not only does it discuss the actual treatments that this patient has had, but also the responses to those therapies and any other information I provided in my prompt. You'll see that there are specific paragraphs that detail your medical history, imaging and current status, and medical literature and arguments to help your case. So once again, I'm just giving you the time to scroll through and see that this is written in plain English and references every part of information that I referenced in my prompt. And I did not ask ChatGPT to do this, but notice how it offers to tailor the letter further based on other documents that you might have. ChatGPT will usually offer some helpful services after fulfilling your original prompt. When you generate your own letters, you can absolutely make use of these services. Now I thank ChatGPT because I feared the robot uprising and would like them to be on my friendly side. And you can see that I'm also going to ask it for something more. So we all make mistakes, and sometimes that might mean forgetting an important piece of information in your prompt. No need to worry about rewriting the whole prompt or starting from square one again. You can just ask ChatGPT to add in any additional information to your letter. So in the video, you'll see me ask ChatGPT to clarify the type and amount of chemotherapy a patient has received. So I ask it to do that in plain English, and you'll see ChatGPT immediately begin to rewrite the letter in the detail that I asked it to. So I submit it, and it thinks for a little bit longer, but then it will begin generating a new letter. Once again, it keeps the same format that I asked it to have in the previous response, just showing the iterative capabilities of ChatGPT. I don't need to continue to ask it to give me the same format that I already specified in a previous conversation. And as we scroll down here, you'll see that it gives more detail on the chemotherapy consisting of 6 cycles without a certain additive and an additional 6 cycles with a certain additive. And as I scroll down, I'm giving you the time to read through to show you that the rest of the letter is exactly the same in the details that it provides. All that it did was change the chemotherapy details that I specified for ChatGPT. And finally, you can see that ChatGPT actually offers to include references to specific clinical guidelines. And that's exactly what I'm going to ask it to do. I ask it to cite these references in the text and again after the letter is done. I also just specify the formatting of the letter again, just because I want to assure that it looks the same for this example. And once again, I'm speaking to it in plain English and keeping my requests very simple to the point. And ChatGPT, once again, continues to write the same letter with the same formatting at the top, the same introduction. All that will be different is that now it will include some citations, both in the actual letter and in the part below the letter or the footnote section. You can see there that it first references the National Comprehensive Cancer Network, as Nancy pointed out, in the kind of helpful guidelines for you to look at. So ChatGPT knows that those are helpful, unbiased sources of information, and it can cite them. And it also cites some specific studies within the text. And it gives you the actual footnotes that it will use later at the bottom of the letter. And as we begin to scroll down below the actual physical letter, we'll get to the footnotes, and I'll discuss those in more detail. So you can see that it provided 4 citations. The first is for a national medical guideline from the National Comprehensive Cancer Network. It's a very useful source of information and a great unbiased resource for you to use to reference in your appeal letters. Then it cites 3 individual impactful studies that also spell out the importance of this patient scan. Remember, as always, you will need to click on the links or give these sources a Google search to make sure that they're real and have specific applications to your medical situation. We also totally get it if you're a bit hesitant to share personal details with an AI device. Sometimes it can be difficult to figure out if the information you're sharing is necessary, or you just might have some privacy concerns. We want to assure you that you can still use AI to help you out when you are denied coverage, regardless of if you want to share your personal health details with an AI chatbot. This slide shows you an example prompt that you can copy and paste directly into your AI model of choice. The only difference between a template letter and a full appeal letter is that the full letter already has your details written in. One is not better than the other, and we wouldn't recommend doing one over the other. It's completely up to you to decide what letter type you would like. If you don't want to share personal medical information with an AI, you should always request a template appeal letter. So the next video we'll show you is how to request a template appeal letter. This way, you can still get a refined and professional sounding letter from your AI chatbot without having to share any personal information. As I did before, I'll walk you through another example using a different AI model, this time Claude. You will see that the beginning step was the exact same as when I went to ChatGPT. I navigate to the search bar, search up Claude's webpage, and I am taken to the webpage. There will only be one different point in the video between you and I. Since I already have an account with Claude, I do not need to make one. It takes me directly to this page. You would have to make an account, but this would only take a few minutes and it's completely free. Once you do that, you'll end up in the same place I'll be in. And just like in the last video, I paste the prompt that I used on the previous slide. And when I hit enter, you'll see how Claude automatically writes a new letter that has blanks for you to fill in with your own treatment information. As you can see here, this will not generate any text that directly references things like PSA trends or imaging results, but it does give you a general outline of what information you'll need, along with some helpful descriptions of each section. I'll let it play for a little bit as it generates more and more of the template letter, but you'll get to appreciate the differences between a template letter and a full letter. As you can see, this template is pretty bare bones in terms of specifics, but it's a great jumping off point for you to begin filling in relevant details about your own care. While this method might take some extra elbow grease in terms of actually writing out your own history, it's a great alternative for people who might not feel comfortable sharing personal information online. You can see that the AI also gives a general explanation of what you should add in for each section. And of course, you can always find a happy medium between the two approaches we've shown you. You can ask the template to add in some more specific template areas for things like PSA trends or historical therapies. You can find whatever method works best for you and run with it. There's no right or wrong answer when using AI chatbots, as long as you are careful and double checking the letter. Now that you understand how AI is taught, some AI models, what information you need, both from your insurance and your doctor, and you've actually seen how to talk to AI, you're an expert in the field. We want to leave you with some general concluding remarks and core ideas. First, we'll give you 2 wrap-up tips explained by Nancy.
Thanks so much for taking us through that, Lauren. Isn't it incredible how fast AI can generate those letters? I'm still amazed by it every time I use it. So now that we have gone through the bulk of the presentation, we'd like to just summarize a few points. Firstly, we need to present a clear and accurate case to your AI chatbot. As pointed out in the second part of our talk by Lauren, you want to try to present the most clear and concise message to your AI from all of the resources you have collected. By carefully reading your denial letter, carefully collecting important information, and creating a clear and short prompt to your AI, you are well on your way to creating a clear appeal letter. After the letter is written, make sure to always double check the information in your letter for accuracy, like we've pointed out previously. Next, follow procedures and keep a good record. Remember that the content of your letter is not everything. Take the time to understand your specific appeal rights, what information you need to submit, and keep good records of all the information and documents you submit with your appeal in case you need to provide further information to your insurance company, or if you need to file multiple appeals. By clearly understanding what you need to do to appeal a decision and conveying that information to your AI chatbot, you are well on your way to a clear, understandable, and hopefully successful appeal. Once your letter has been written, edited, and double-checked,
we'd recommend having a trusted person to give your letter a read for clarity and persuasiveness. Additionally, if you have access to specific sources of help, maybe that's your physician, a social worker, or maybe even a nonprofit organization, they would be an amazing source of help to guide you through this process as well. Other options are people like a HR representative if your insurance is through your work, for example. Once you're confident in your letter and other submissions, you can follow the instructions given to you from your insurance company on how to actually go about submitting your letter. An overarching statement is that chatbots are powerful tools that can help level the playing field when dealing with insurance denials. They can help you organize complex medical information, cite relevant policies, and research. They can present your case in clear and persuasive language. So they are a tool that can really help in this complicated space of insurance denials. However, we must remember that the AI is your assistant and not your replacement. Your knowledge of your own medical situation, combined with the documentation you've collected, remains essential to this entire process. With the right approach to using AI tools and the documentation strategies we've discussed, you're well equipped to challenge unfair denials and advocate effectively for the prostate cancer care you need and deserve. We want to leave you with one final plain message. If you are denied insurance coverage, we want you to know that there are options available to appeal. While denials are very difficult to receive and can be very challenging to navigate, they do not spell the end of your care. So in summary, we want to thank you again and thank the audience for tuning in and listening to this talk. We give our sincere gratitude to the PCRI for giving us this opportunity, to Dr. Moyad and Dr. Kwon for their guidance and assistance in developing this talk, and again, for the opportunity to share this with you all. As a final message, this is part of the larger combat manual series with Dr. Kwon and the PCRI. The other combat manuals can be accessed online by scanning this QR code on the screen or by searching Advanced Prostate Cancer Combat Manual on YouTube. Additionally, we'll be releasing a pamphlet with a summary of all of this information and some additional resources that you can use coming in the fall. Thank you everyone for tuning into this talk. We appreciate your time, and we hope that this gives you the tools to tackle these insurance denials. The whole point of this was just to empower patients and make you know that there are resources available for you to use when you get denied by your insurance. And we really just want to turn this dark and sometimes hopeless feeling and just show you that there are resources out there that you can take, and that there are also people willing and able to help you during this process.
All right. Team Mayo, baby. Team Mayo. Team Mayo. Right? 10 out of 10. Awesome. First of all, I want to tell the audience before we talk about other things, this is a very difficult subject. It's such a difficult subject that nobody wants to give it. Let me first tell you that. So then who should give it? It's the people who are going to give the time, the passion, and who have the experience. So as we began to find out with Dr. Kwon that they do this in the clinic, they help people, they help their resources generate letters that help their patients overcome denials. It became what we call a no-brainer to try to get them on to give this talk. So this is the first, even though they do this regularly, this is the first official talk, and we wanted them to give it here at PCRI. And so kudos to you, first of all, because again, if someone asked me to give this talk, I would say, forget it. Find somebody else that can give it. Because I did a random survey before this lecture of probably 10 of my different oncology, urology friends around the country in a variety of states. And they gave me 10 different answers as to how they appeal. But the answer always came back to, if I can get help from the patient, if I can get letters or information that I could utilize in the appeal, I will always welcome it. That's number one. Number two, I heard from a lot of people that said, I'm not doing this appeal. I am too busy. I have a huge clinic like Dr. Kwon's, and the patient's got to drive the process. So let me make that clear, first of all. If you take the time and watch their lecture, and you at least generate the minimum of what they're asking, and you can give it to your team, but if your team doesn't use it or want to apply it and you want to apply it in your own appeal, it's still a win-win. There's no downside to using these tools. Is that how I should put it there?
That's
Doc,
exactly right. Yeah, absolutely.
Doc Rhodes and Dr. Way. Okay. Okay. Now that I put that out there of why we wanted you to be our part 1 series, the part 2 is in the fall we're going to have, and with the extra information. But again, the reason we put this out there is because I looked online. There's just not enough out there to support patients going through this HE double toothpicks process. It's important that we get involved more deep here in advocacy. And because too, they're at Mayo and they've used this successfully. So I wanted to find someone that used it successfully to overcome the appeal. With that in mind, I'm going to ask you some really, really difficult questions, if you don't mind. All right. So the first one is a true or false. Since you're in Dr. Kwan's office, I know he has an ocean view from Mayo Clinic in Minnesota. Do you agree that Dr. Kwan has minimal athletic skills, but above average guitar talent? I mean, do you agree or disagree? You can't cop out. You can't just walk away from this.
We can't have like a middle of the road answer.
No, middle of the road's not acceptable because then I'd answer for you, and that probably wouldn't be acceptable.
I think Dr. Kwan would agree with that himself.
I would say.
He would agree with that statement. Yeah.
So he would agree with what you're saying. You're both saying that he has minimal athletic skills, but he has above average guitar talent.
You should ask him for his original CD with all of his original songs that he records. Yeah, he's very talented with music.
No. See, if I do that, I'll be encouraging his behavior. We want to make sure that you two do, and what he does is he stays in the clinic and keeps doing the amazing work that you all are doing. I don't need him distracted by the guitar or athletic skills. Have you heard him play guitar, by the way?
Yeah, on his recordings, he's given us he's burned some CDs. You know what they used to do in the 2000s. So
yeah, thanks for making me feel old. I used to know what went on in the 2000s. So he gave you a CD, and then what happened? Did you do it, or is it on a shelf someplace?
We had to find somewhere that would let us play a CD, like old cars. My laptop doesn't anymore.
It's only in my car. That's the only CD player that I have.
Okay, Dr. Kwan, if you're listening, that means they haven't listened to the CD. They really don't. They just want you to keep doing what you do best, and that is treat patients. All right, that's fair enough. You answered that. Now I got a couple questions that are specific to the both of you. All right, ready? These are my 3 questions game with the bonus, so I got to hide this. The first one is that true when you go to a sports? Because I've been to Australia many times, and you're from Australia, and you might be going back to Australia. Is that really a saying at sports events when you go Aussie, 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 then oi, oi, oi?
Oi, oi, yeah, absolutely. You got to say it loud and proud.
What does that mean?
It's just exactly what you said. Aussie, Aussie, Aussie. Oi, oi, oi.
I don't know what that means. Does that mean I'm thirsty? I'm hungry?
No, it's just like you just chant it, and it's just like, you know, what you say at sports games, and just in show of support for your team or the Australian culture. Yeah.
All right. So have you ever done that in the clinic with Dr. Kwan? Aussie, Aussie, Aussie. Oi, oi, oi. Have you ever done that?
Every day when I walk in, I'm Dr. Kwan, Aussie, 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 and then he'll go oi, oi, oi.
Okay. Number 2, have you ever had a Vegemite sandwich?
I have. It was my classic after-school snack. Every day I used to have one. Yeah, and I'm an edge spreader. If people know what that means, it's like I like a lot of Vegemite on my slice of toast.
Do you eat Vegemite sandwiches at Mayo Clinic?
Mayo Clinic does not provide Vegemite, unfortunately. Maybe I should instill that. I should get that going.
You can change the culture.
Yeah.
You can change the culture. Just first explain what the heck it is, and then when you then you can change. You can explain it now if you want, because when I ate it over there,
most people have seen people try it, especially the American people. It is basically a very salty yeast extract. Marmite is the equivalent British version, but it's a great salty snack, and you must butter your bread. You must put Vegemite, and I like mine with a slice of cheese. So that's how I would eat mine.
Nice, because yeast extract is actually very healthy. I I actually did a study with yeast extract in an area of cold and flu symptoms when I was much younger, and we were impressed by the results. It was the Saccharomyces cerevisiae. I'll never forget it. I don't know what yeast extract they use there. All right, this is a good learning process. Your last question, Dr. Way, is which band or singer is not from Australia? Okay. Okay, which one's not from Australia? Is it A, AC/DC, B, In Excess, or C, the Bee Gees?
Oh gosh, I'll be embarrassed if I get this wrong, but
No, it's okay. There's only an entire nation watching it. We have a lot of people in Australia that watch the PCRI. Peter and Alex can confirm that, and the whole team. So take your time. Which band singer is not from Australia? AC/DC, In Excess, or the Bee Gees?
can I ask ChatGPT? I think it's the Bee Gees.
Oh, man. Your answer is correct.
Is it? Okay.
It's
okay.
correct. I was going to make you change it, but that's right. AC/DC, In Excess, and the Bee Gees spend a lot of time there, but they're not from there. They're English, I guess. Again, this is what AI tells me, so it's not me if I'm wrong. All right, you did very well. You were 3 for 3. Now I have a question for you, future Dr. Rhodes. For those of you who don't know it, look at the talent we have here. We have a physician in Dr. Way. We have a future physician in Dr. Rhodes. And here's my bonus question. Has the future Dr. Rhodes ever been to Mount Rushmore? And why would you go there?
Ooh, so I have been to Mount Rushmore twice now, and I usually go there not for the mountain itself, but because it's surrounded by beautiful mountains. Like the
Wow.
hills are gorgeous. They have tons of trails. Like the nature on the west side of South Dakota is unreal.
And why do you know so much about South Dakota?
I moved to South Dakota about, let's see, when I was in middle school. So I had been there for over 8 years now. And
yeah, so to the audience, she's a South Dakotian, Dakotan. Well, I don't even know what that is.
South
Okay,
Dakota.
how do you pronounce the capital of South Dakota, seeing that for 60 years I've been getting it wrong? Would you like to walk through the audience how you pronounce the capital of South Dakota?
Yes, the absolute misinformation campaign that has been brought to the other 49 states of the United States is that South Dakota's capital is named Pierre. That is not true. It's called Pier, like what you walk down to get to your boat. When I first moved to South Dakota, I was so confused because I thought that it was pronounced Pierre. And people were saying that they were going to Pier. I thought that meant some kind of like shipping yard or something.
So it's Pier. So if next time you're in South Dakota, call it Pier. And Pier is the capital of South Dakota.
Yes.
Okay. We will go back to some other fun in about 10 minutes, but I want to do about 10 minutes of serious stuff, if you don't mind. Let's go to one of my favorite questions of all time. And why, another reason why, if anyone's out there wondering, why did we do this? It's because we have to do this. And we have to get people knowledgeable in terms of advocacy in challenging these things that we think are not right. And even though we agree they're not right, we got to give you the tools on how to overcome these appeals and to reverse the decisions. So if I thought I would provide you the greatest motivation of why you should get involved in the audience as of right now in this question, besides their talk, what percentage, all right, what percentage of denied health insurance claims are actually appealed by the consumer? This was done by the Kaiser Family Foundation, a very reputable nonprofit. They do it every year and check it. Is the answer A, 50%, 33%, or 25% of people actually go after an appeal their denials?
Before I begin looking at this talk, I would have guessed D or maybe C if I was hopeful.
Yes. So I would have guessed that also. And according to the Kaiser Family Foundation, it's a trick question. It's less than 1%.
Yeah, okay. Yeah, I thought, okay.
So, but you're actually also right, because it also depends on the group. So in Medicare, the number's been bumped up. It depends on the insurance type. In Medicare, now it's to 9 to 11% of people appeal. It's going up every year by about a single digit. Overall, though, in the marketplace, it's less than 1%. So if you have all these denials going on, which the latest figures are, these insurance companies spend about 20 billion fighting this stuff, 20 billion, whether it's annually or every 2 years, people will say it's annually. Anyway, they spend billions. It's amazing to me that somewhere between less than 1% and 10%, depending on your insurance, is actually appealed by the actual consumer themselves. And again, if you're out there, you might be in a different situation. Your doctor might have no problem appealing. They'll say, I'll appeal everything. Some offices will appeal nothing. Some will work with the patients to appeal as long as you're doing the work. It depends. But there's a statistic that's actually kind of sad for me because it's less than 1% in the marketplace. Anyway, we're going to change that with your talk. We're going to crank them up to 50% or more. That's part of the purpose. I mean, where else do we need more help in medicine, right? Here's what I decided to do because I didn't know diddly. That's an actual word, diddly. I didn't know diddly about what I'm supposed to do. So as you were doing your talk and as we were practicing it and talking about it, I decided to just go on my computer, and here's what I did. I just typed in ChatGPT and it said, hey, hi, how you doing? What's on your mind today? Okay. And then I typed in the other one in part one. You told me to type in gemini.google.com, and it said, meet your personal AI assistant. So again, right as I'm doing what you're telling me to do, it's taking me right to where I want to go to start things. That's the good news. The only question is, then I went to Claude, and Claude's throwing me out all these subscription services and, hey, do you want to do this? Do you want t-shirts? Do you want to buy coffee mugs? No, I'm kidding. I just make that up. But they're giving me all these options. So here's the three of them. I want you to try to answer this in general. What I love best about your part one is everything is my favorite four-letter word, free. That's my favorite four-letter word. So all this is free, but some of them are throwing subscription services at me. So again, can you reiterate the freeness, and then which one do you prefer someone starts with? Because they can't do all three, right? So can you just talk about part one again in terms of you're convinced it's going to be all free, they don't need to pay a subscription? And the second more important thing is, if someone like me is just starting out, which one of the three do you like to start with?
Most other free services offered today, there's usually always, the free and then a premium version. And at least for what we were using in our talk today, both of the videos that I showed and, walked you through, those are both using the free versions of ChatGPT and Claude. I didn't pay a single cent. And you as a patient or a provider, if you want to use AI, you will never have to spend a penny on using any of these services. The reason that they have more premium versions is just because, some people might use AI to help them code or other things that are more advanced, and might need more like technical training rather than just, plain simple English language and understanding, basic sourcing is all that the AI has to do. So while they do offer premium versions, the reasons that you would need a premium version aren't, really covered in our talk. You wouldn't need to pay to use those.
Oh, love that. That's awesome. And then if you're stuck on a deserted island, this is obviously a very realistic scenario. Well, I mean, Rochester's kind of a deserted island. Rochester's
a little bit.
No, if you're in Rochester watching this, I love that town. I've been there a million times. I've actually given a couple lectures there. So I'm just saying, I'm not saying it's deserted. I'm saying it's kind of in the middle of no place. You feel winter's a little tough there. But same with me where I am. You can see I'm trying to save myself here from what I said. But let's say you're in the middle of a deserted island, and you're only allowed one of the three AI chatbots. Am I using the right language? Chatbot.
Yep.
Which one am I going to use to use for my insurance denial on the deserted island? Which again, it sounds realistic.
I would personally recommend starting with ChatGPT. I feel like since it's the most, well-known model, even if you get really confused, there are a lot of resources out and available for ChatGPT. I feel like it's extremely user-friendly. It's very clear on where you need to type things, and it enumerates, other options that you can do after it's, fulfilled your original prompt. And it talks to you in a very human-like language. I feel like it's a good, middle ground between Google Gemini, which is really, research heavy, but might be a little bit less human, and Claude, which, is more human, but doesn't have the same internet connectivity that Gemini and ChatGPT do. I feel like it's a good middle ground, but also, well-known and easy to use.
I would say the same. Like, I use ChatGPT pretty much every day at work. I do my own work. It just makes me more efficient. I will say that. And if if you're dealing with this sort of stuff and you just have any sort of young person around you, probably 9 times out of 10 these days, they've all encountered ChatGPT. Another thing we should say is that we're saying a lot of these companies and these AI bots, but none of this is sponsored. These are just, again, like we said, free to use versions. But these are just ones that we're familiar with, so that we, would recommend to other people just starting out using AI, because they're to us the most user-friendly, like Lauren said. And just another thing to note with the premium version of, say, ChatGPT, you do run out of certain amounts of prompts you can give the AI, and then at a certain point it'll say you've used the most prompts. You'll have to either upgrade your AI, but you can always just leave it for a few hours and come back and you can use it like new again. So Absolutely. That's just one other thing to note.
But you're always doing your letter, even though it's generating it, I always get worried about something happening with the internet, something going down. I mean, I'm up here in the middle of no place a lot of time, and sometimes the internet just goes out. So you're always doing something initially when you get a letter generated or anything, are you copying and pasting and saving that to a Word document? Isn't that what you mentioned? Can you comment on that? It's sort of how do I go about making sure that if I lose the internet, I still can keep what has been generated?
First of all, a cool thing about all of these AI models is that if you do make a free account, it will actually save every conversation that you've ever had with it. The ChatGPT account that I have has conversations that I had with it in 2022. I can just go back and click on those and immediately go right back and start that conversation again. And it'll be like I had it, yesterday and not 3 years ago.
Wow.
So even if your internet, goes out in the middle of a conversation, it might not save the very prompt that you were working on, but the rest of the conversation will all be saved. And you can go back to that at any time, whenever you get your internet back, for example.
Yeah. I did not. It saves all the conversations. I mean, that's exciting and scary at the same time.
Yeah, which is why definitely be careful. And, like I said, never share information that you don't feel comfortable sharing with ChatGPT. You can always work with it and only use it when you're comfortable.
What I also found in the part 1, and is interesting, and when I tried this after you had done it, is that when you're asking it something and it's spitting out all this stuff, what's interesting to me is if you look around, it does reference their stuff, right? Yep. I remember the days when I had to do 100 papers where I had to type in all my footnotes, everything. I had to use the first 3 authors, et al., the journal, the format. I was exhausted just typing in references or finding references. But when you're bringing all this up, it shows you exactly where to look at the reference, right?
Yep, it'll give you a little icon sometimes right next to the end of a sentence, and you can just click that and it'll bring you to the web page, or it'll give you a direct link later down, also, which takes you directly to the web page.
Something to note, though, that Lauren mentioned earlier as well is that sometimes the references that it might give you are not always accurate. They might do something called hallucinate. So you should just make sure that they're correct and check those references before you submit your letter. So that's just one suggestion.
Absolutely.
Because when you all deal with patients, when you're all trying to help people overcome a denial, you're providing basically this information. You're getting it to the people at the clinic to provide the information to the patients, right? The staff is not hand-holding the entire denial and doing all the work. Isn't that correct?
Yep, that's absolutely correct.
And that's why for those people watching, because sometimes I'll read it on comments throughout all the internet, It's like, well, my doctor does all this. Well, let me tell you, in a lot of corners in the world, a lot of academic centers and a lot of private clinics, some of them do none of it, some of them do part of it, but nobody ever loses when the person generates their own letter because you're helping them do some of their work and recall some of the stuff, whether it's used by the doctor, whether it's used by human resources, the union, you name it. Okay, great. That's part one in my brain. We've covered that well. Let's talk about the denial letter in part two. The denial letter that you pulled. What surprised me, and you walked us through that, it was 2 pages. It was very succinct. It was very pithy. It had everything you wanted to know in there. And in this day and age, if someone sent me a 2-page letter in general, I'd probably read 1 sentence or maybe 2 sentences. Nobody has the attention span. But can you just reiterate, while if you get a denial letter, because you're supposed to get one the same time your medical group gets one. If you get a denial letter, can you reiterate, Dr. Way, why you have really got to line by line go through that?
Yeah, so like we went through in the talk, you must go through line by line because in that letter that we gave as an example, they had 3 reasons for their denial. So when you write your appeal letter, you'll have to address all 3 reasons. Otherwise, they just might send you another denial back. So that's why it's really important to make sure you cover all your bases, gather all the information that's required, speak to others, look out for resources like this talk or your provider or someone else to read it over with you just to make sure you're not missing anything. So that's why it's important to read through it. And yeah, that example we provided was quite nice. It was very clearly outlined, but sometimes, insurance letters come from many different insurance companies as well. They're not all going to look like that. Unfortunately, we can't give an example for every single denial. So just making sure, you know exactly what the reasons are for your denial are.
Yeah, well said. Okay, so that number 2 was just extremely interesting, walking us through that overall. Let's go to 3. And that's where you generated the letter using the chat GPT. I can't believe I'm using this language. I don't even know what I'm talking about when it comes to this language. Now, I think the most important part there is you use the word regular letter versus template letter. Can you just walk the audience through why I would use a regular letter with my GPT or my AI to appeal the denial, and then, or why would I just use a template? So I have a choice. I can use a full-fledged letter or a template letter. Tell me why you would use either one.
Absolutely. So I think the biggest deciding factor for if you would want to get a full appeal letter or a template appeal letter is how comfortable you are sharing your information with an AI model. Like I said previously, researchers or programmers might read over the prompts that you give an AI and the responses it gives back just to make sure, that ChatGPT isn't saying anything offensive or anything. And so, you always have that little risk that some real person could be reading over your information. And if you don't feel comfortable doing that, then a template letter would be a great way to start off because you aren't providing any of your own personally identifiable information, your diagnostic treatment, stuff like that. So it just kind of removes the need to provide any personally identifiable information. But if you feel comfortable with that, or for any other reason you would want a fully written letter, you can always go down the full appeal letter route. We have templates for both, so it's not like one's harder to get than the other. And it's also not a black and white kind of choice. You can always find kind of a happy medium. You can request a template letter with more specific sections, leave some space for me to mention specifically PSA trends, conventional imaging trends, or something like that, so that it has a bit more guidance, but still doesn't need your personal your personal information, if that makes sense.
Yeah.
Yeah.
No,
So
it actually makes sense a lot. So it gives people the 2 options, I like that a lot. That's really great. To me, this is sort of a landmark talk on insurance denials and AI by the Mayo team of Lauren Rhodes, Dr. Nancy Way, and Dr. Eugene Kwan. I put CEO General of the Combat Manual and BFF of Dr. Moyad in his mind. Okay, so that's one thing I learned, that he always wants to be best friends with me, and I understand that. But no commenting whether or not he's my best friend. That will take some more work on his part. This is why I reiterated it. These 3 sites they talked about, right? And I asked them, which one do you pick? And they said on a deserted island, they would use chatgpt.com, but the other ones are fine too. And this is all the free stuff. Part 2, this is the purest form of medicine. The 2 of them put this talk together. This is what they also do and help with. And that's it. There's no catch. They just wanted to empower patients. Part 2, once denied, get AI and a medical team to help with the appeal and use guidelines or evidence. That's what I learned from your talk. I know we've gone through this many times, but it's important when people are watching all different parts. Part 3, AI will write a great appeal letter if you give it the right information, or you can paraphrase your own letter. What I really thought was interesting in part 3 is, I tried this, you're right. If you don't ask it to write a respectful letter, you have to be clear, crystal clear. If you don't say be polite or be kind, it could go a little in a direction, let's just say, that's not appropriate. So do you find that just working with this in general, that if you aren't telling it exactly what to do, maybe like a child, you got to make it crystal clear what I want you to do here. It could, I don't want to say turn on you, then that's going to make it sound, then that's going to give all the conspiracy theorists a lot to work with. So can you comment on just the language one more time?
Yeah, I definitely think that it is very important to set your expectations very clearly and very early on with AI when you use it. I find usually that if you don't specify that you want it in a specific format, it might give it to you usually in a list-like format where it'll have a few full sentences, but then bullet points or something similar, which, you know, isn't necessarily wrong or unreadable or something like that, but just, you know, isn't always what you're looking for. So I think as long as you're very direct with what you want from it, you know, please be respectful, please give it in a letter format, it'll do all the heavy lifting for you.
That's so wild to me. Oh, and by the way, the other thing I also learned something else. It says, I also learned something else. This is again my world, which is just a wacky world. I learned if you put the words together of Rhodes, Way, and Quan, it sounds like a law firm or a Netflix series. You notice that?
Yeah, that's a good one. I think we should hit up Netflix and ask them to make it.
Yeah. See, this might lead to your Netflix series or your law firm. Here at Rhodes, Way, and Quan, we like to help you overcome denials.
Yeah,
Right?
yeah,
I mean,
exactly.
it's
It's gonna be our side hustle, yeah.
Yeah, I think you should think about putting those 3 together, you know, trademarking that and making a fortune if you go into this business. I decided based on nccn.org, because you want to refer to guidelines. And like you said so correctly in your talk, they cover all the different cancers. And I think this is another take-home point for the audience I failed to mention earlier. This is not just about prostate cancer appeals. You could be watching this in the area of dental. I don't know. You could watch this in the area of what I ran into not long ago, where I wanted someone to evaluate a hernia, for example, on me, and I thought I didn't have to go through imaging. Anyway, long story short, they didn't approve this general surgeon I just wanted to talk to. I went to talk to him anyway, and I got a big bill. And I thought, I called the insurance company and I said, wait, why am I getting rejected? This is just a basic referral. And they said, oh, your primary care coded it wrong. All you have to do is call back your primary care's office. And see, this goes back to what you said. A number of these mistakes are very simple mistakes that when you make a phone call yourself and call the insurance company, they just said, call back your primary care, tell them to do this type of referral. Me as the patient, I did that. She put it in the computer, the manager. 3 days later, they erased my bill, which was not a small bill. So you'll read online all the time that a lot of mistakes get corrected are just simple coding error mistakes, or someone typed in the wrong word and suddenly it's denied, and you just calling them up can reverse it. Anyway, using nccnguidelines.org, I decided just to make myself an account. It took maybe 30 seconds. I had to create a very interesting password, and then I had access to all this information that I could use in my appeal. Plus, it's interesting. You also pointed out, not only can you learn about guidelines in NCCN, this is 33 plus of top-notch academic centers, but the insurance companies work off of these things. If you tell the insurance company that this is what these guidelines say, a lot of times they can't do anything about it. They've got to follow it. That's enough evidence. I can't tell you how many clinicians I've talked to as we were preparing for this, and they said the moment I put NCCN guidelines or the patient does in the appeal letter, it's immediately reversed. So I created my own account, took 30 seconds, just had to come up with a password. And what you said was they have patient resources in there too. And those are pretty awesome also. The other thing I want to add is there's a group called Patient Advocate Foundation. You can also call the PCRI helpline, but this is Monday through Friday. This is what they do. They can help you with your appeal. It's a very well-known group, nonprofit-wise. And then you can look for other places that work on appeal, but maybe they don't advertise it as much. The Patient Advocate Foundation can help with appeals. They have appeal information there. American Cancer Society, I decided just to look it up, and they have a section on appeals, and you can call and they'll help you. It's not necessarily the section at the top of the website, but when you start looking, boy, there's a lot of information there, and it's got pages and pages of what you can also do. Almost done here. Hang with me. I just want to emphasize two other things because I know I can hear the internet screaming at me. They're saying, okay, when future Dr. Rhodes and Dr. Way talk about these appeals, you know, there's two types of appeals. There's a prior authorization denial. So that's what they were talking about. Let's say you go to Kwan's clinic and they say, we're not going to do your PET CT. You can appeal those. Or there's it's called a claim denial. That means you already received the service, but it wasn't approved by the insurance. So now you're stuck with that gigantic bill. And this is where people also run in. Medical debt is such an epidemic problem for a variety of reasons. And this is one of them. People get the service. They think it's going to get covered. The practitioner thinks it's going to get covered. And lo and behold, they get denied. And they're on the hook for this gigantic bill. So what these two brilliant folks are telling you is whether it's the prior authorization denial or the regular claim denial, you should generate a letter and go after this. I also looked at a couple companies out there. I looked at a couple PSMA PET scan companies, and I'm not going to mention names, but a number of them provided advice on how to appeal also. So everyone's out there, I guess, trying to help. I just don't know why there's not more information video-wise. I wish there was. The next thing I'm going to do is an actual teaser, and I feel bad about this before I go to the end. The teaser is they covered the free options today, and that was in AI. You get a dream letter, you get a review, an expedited review they talked about in the future. They also talked about social workers, human resources. We talked also about appealing to the drug and the image company. And then we're going to cover more of this in the fall lecture when we cover it at PCRI at the meeting. There's also something called a peer-to-peer review. Some doctors, I know many of them, they've actually given lectures at the PCRI. They're willing to get on the phone and talk to a person personally. It's a peer-to-peer review, and it's about a 5 to 10 minute call. It's arranged. And if they come in with good information, a lot of times they win. If they come in with the information that you've provided them, for example, you can always ask your doctor, hey, can you do a peer-to-peer call? The doctor talks or the practitioner talks to the insurance company. It's called peer-to-peer and says, this is why I think this is wrong. It lasts 5 to 10 minutes. And I have found, don't tell anyone, that most of my friends out there that do peer-to-peer, it's a very time consuming. So a lot of people also don't do peer-to-peer. But the ones that do it once in a while, they win the appeal. They win, in my opinion. This is also what I learned from the Rhodes and Way team. Move with organized speed, move with absolute confidence, work with your entire medical team and other free resources, and be kind and polite and evidence-based. And here's a saying I came up with. I thought you two would like this. The squeaky wheel wins the appeal.
Oh, that's really
great.
Right? Is that a commercial?
We should have called the talk that. Yeah.
Oh my gosh, we should have called the talk that. I only thought of it during the talk, so I started making up.
That's great.
But that's what we're saying, right? But I got it wrong. First, I thought squeaky wheel wins the appeal, right? So at the law firm of Moyad, Rhodes, Way, Kwan, anyway, Way, Kwan, Rhodes, but it doesn't matter. The squeaky wheel wins the appeal as long as you're kind and polite. Because squeaky wheel also implies that you can be a pain in the gluteus maximus. We're not saying that. We're saying you should stick up for your rights, use all your avenues. But I think, yeah, we can make that the next AKA for your talk. The squeaky wheel gets the appeal. And last but not least, if you're not impressed by that, here's my final piece of sage advice. You see, I have no life to try to come up with this. There are many roads to winning your healthcare insurance appeal, and you just need to find the way that works for you and your medical team to get there.
Yeah.
Holy, is that a mic drop or what?
Yeah, mic drop right there. That's very good. That is
Thank you very much. I'll keep my day job though. You're going back to Australia, or are you staying in America?
No comment yet. If they'll let me stay, there's potential. But at this point,
Well, if you're listening, Mayo Clinic, the firm of Rhodes, Way, and Kwan want to stay. They want their participants to stay in Rochester. But I do want you to comment on this. This was done in a recent study by the Commonwealth Fund. It showed the 10 highest income nations, and it showed the healthcare system performance ranking. I know this is rough to see, but these are the healthcare systems that were rated to perform the best. Here's US down at the bottom, which is, anyway, Australia is number one. So do you want to represent all of Australia right now and tell us, why do you think they put Australia as, in terms of performance ranking, the best healthcare system in the world? No pressure.
Oh gosh, no pressure. Great question. I believe that that figure that you've pulled from is from this study done by the Commonwealth Fund, which is actually an American based organization. So, it's not biased by any means, I would say.
Yeah.
And I can't remember exactly what all the domains are, but I think they measured it on 9 different domains about things like access, cost of care, timing, all of those things. And all of the countries in the top 9 kind of ranked relatively similarly. Australia didn't do, they weren't number 1 in all of the domains. And in one of them, I can't remember exactly which one, but they were, even lower. But it's the fact that they all kind of average, and then it just, we come slightly on top. And then unfortunately, the US ranks the lowest on average. But in terms of our healthcare system, it's just built very differently. We have something that we call universal healthcare that a lot of European countries have, and I believe Canada also has a universal healthcare system as well. And basically, it just means that we have a public healthcare system that patients can go to and access any sort of emergency care or elective care or cancer care, things like that, and not receive a bill at the end of your treatment or hospital stay. The reason why I think we do it well is that we also have a private healthcare system that helps to bolster our public healthcare system. So I'm very junior in my training at the moment. So I'm postgraduate year 2, which just means I finished medical school a couple of years ago. I did my internship at one of the large public hospitals in Melbourne and then came straight to the Mayo Clinic. But we do all of our training, education for our doctors in the big public hospitals. So it's a big workhorse. And all our research is typically based out of these big centres. So it's really the premier healthcare system for us. And then, depending on your certain income threshold, you might pay for private healthcare insurance, and then you can go and do elective procedures through there, whether that be a hip replacement or other simple procedures that helps to take off some of the weight of our public system, which allows people who cannot afford private healthcare to access the public system and get on waiting lists for things like a hip replacement. But yeah, no, those are the reasons why I think we.
Well, that's a good answer. I didn't expect you to know that. I didn't expect you to have looked at it. I just thought, in my opinion, why we're down here, maybe there's some bias, maybe there's not, but I thought when I read it, okay, I'm biased on this. I thought that the excessive administrative costs, the denials, everything we talked about today, burdens the system to such a degree, which is another reason why this is the most uncomfortable talk I could have ever imagined moderating or giving myself in the 20 years of moderating at PCRI, but one of my favorites to have to just get out there and do it, regardless of what we hear. Someone's got to do this. So part of my argument today of why we had to finally offer this from some experts on appealing was because of also this. This is symbolic of why we're having trouble. We're having trouble for a number of reasons, but the denial problem is pretty bad. But I found a lot of hope though in the data. I found in Medicare and ACA, just a lot of different places I found that, or Medicare Advantage, it could be Medicaid. I found that when people appealed it, regardless of the method, I was looking at 50% in a lot of cases get reversed. And that's without, in a lot of cases, without any training of how to reverse an appeal. So what I saw in the numbers was a very high rate of appeals that were reversed. The denials were reversed and they approved it when someone actually decided to be the squeaky wheel, they won the appeal. That's going to be our campaign logo when we run for office. Squeaky wheel wins the appeal.
That's right. I think, yeah.
Say it with me. Squeaky wheel wins the appeal.
Very good.
All right. So let's end it on this. Last quiz question for each of you. Ready?
All right.
Future Dr. Rhodes.
Okay.
Which state has the largest bison population in the United States? I looked it up and there are 40,000 roughly bison in that state. Is it Colorado, Montana, South Dakota, or Wyoming? Which state in the United States has the most bison in the state itself at 40,000+? What say you?
Is it South Dakota?
Oh, I don't take an is it answer.
Oh, I think it's.
You have to commit. So the whole state is looking upon you. If you get this right or wrong, this could be but it's not good. I mean, I'm not telling you that they do or they don't. I'm just saying that I think you should know this.
Okay, then it is South Dakota. It is.
Ah, you got it right. I like it.
Hey.
All right, so what we're doing is, since you got it right, Alex and the team and myself have spent a fortune. We decided the last second not to get you a puppy. You have a lot more to go in terms of education. You've got to do more videos. You don't have time for a puppy. You're at Mayo Clinic. You don't have time for any life at all. So we're going to send you instead a coffee cup that says, do not pet the fluffy cows of South Dakota, the bison.
Yep.
Do you own such a cup?
I do not own such a cup, but yes, the fluffy cows, I know them. The stereotype very well.
See, that's what we're about at PCRI, giving you expensive gifts that people can't afford themselves. All right, are you ready, Dr. Wei, for your final question, which impacts your entire Mayo Clinic team, including Dr. Kwan? Are you ready?
I'm ready. Let's go.
Dr. Moyad's game of true and false, or is it a trick question?
Oh.
All right.
There is an Outback Steakhouse less than 2 miles from the Mayo Clinic, somewhere around South Broadway. It opens at 11 a.m. that Dr. Wei, future Dr. Rhodes, Dr. Kwan, and entire Mayo team could enjoy lunch at very soon for free for doing such an amazing work on this lecture. Now, I'm not saying there is an Outback Steakhouse in your town. I'm saying, is that true, false, or a trick question? There's an Outback Steakhouse close to the Mayo Clinic, and you could possibly go there and have lunch. But first of all, is there an Outback Steakhouse in your town?
Yes, I know for a fact that there is, because I've never been to one and I know that there is one here.
So you're saying, so what's your answer? I need an official answer.
It's true.
You're going to go true? Yeah. Wow, there you go. True. And guess what? Dr. Wei and future Dr. Rhodes win free lunch from all of us, the PCRI at Outback Steakhouse. Look at this.
Wow.
Isn't that great? And it's in Rochester. Notice how I spend money. I print in black and white, not color. That's how I save, right? And look at this. I looked up at the menu there. Look at these. Look, have you looked at the appetizers? Oh my gosh, this will take you back to Australia, right? You got the bloomin' fried shrimp, the Aussie cheese fries, the Coca Booma wings. I have no idea what that means. Grilled shrimp on the Barbie, Sydney shrooms. That sounds strange. Gold Coast coconut shrimp. You know where the Gold Coast is.
Yeah, that's where I'm from. Yeah.
Does any of this excite you?
I've always wanted to try a blooming onion, so I'm very excited for that.
Wow. See what happens when you change people's lives in the PCRI and do these videos for patients? You end up going to the one restaurant you've always wanted to go at in Rochester, right? And you get to go with the future Dr. Rhodes, and you get to go with Dr. Kwan. And I made sure it was open at lunchtime, just in case you guys want to sneak off and just have a quick lunch. So, okay. So we promised, we only asked for one thing. You take a photo of you eating a bloomin' onion at Outback, and then your colleagues, you also take a photo of them eating whatever else they decided to choose, which is hopefully something unhealthy.
Sounds good.
Okay.
Mm-hmm.
Let's finish up. Listen, I want to thank you all. I know privately how much work you did on this. I also know privately this is a foundation. This is the first major step toward overcoming a denial. And, you know, I think what you showed us all is if you do this correctly, politely, kindly, you can work with AI, you can work with your team, and the squeaky wheel does win the appeal. And I hope that's what people learned. I don't know if you have any parting comments, but A++, outstanding. It was really great. Thank you.
Yeah, we just want to thank everyone for tuning in. And yeah, I mean, coming to the US, this is something I was initially unfamiliar with. And I just think it adds so much administrative burden to patients, to their team, to the physicians, everyone. And I just think, you know, something like this, it's like we're saying out loud the quiet part that no one really wants to talk about or tackle because it's so confusing. So we just hope that this gives everyone a bit of, you know, somewhere to start and using the technology that's available now in this new and modern age.
No, it's really good. I mean, for the rest of your career, I'll never look at this the same way. I don't think anybody will in terms of it's a, you know, as I grew up in the States, and became part of the system, this is sort of a shocking part of it. And anyone that's had cancer in their family or any situation knows that's a vulnerable place already. You're already vulnerable. You're out there. And now, if you get denied, you've now added a new layer of vulnerability. Like, I've got to worry about this and my illness and the right doctor and the right team and the right treatment. This is a layer we shouldn't have to worry about. But you gave us the combat materials, notice how I throw in that, to go after this and reverse these darn things. So thank you again, and I hope to see you soon.
Absolutely. Thank you so much.
Thank you so much for your time.
Thank you, Dr. Wei. Thank you, soon to be Dr. Rhodes. And thank you, Dr. Moyad. We really appreciate the time and the commitment that you guys have spent. I know there was like hundreds of hours, honestly, put into these topics and how does it work and what should we do. But we really appreciate your time and efforts because it's really benefiting us. If you have questions about this talk or you have questions about how to use AI, you can even contact our helpline at pcri.org/helpline. And we can help guide you through this process using the information that they gave us from this talk. It's just a great way to stay empowered, especially if you do get an insurance denial. Now, I want to just remind you, please click that subscribe button to this YouTube channel because it's just a great way to stay up to date with the latest information in senior men's health and prostate cancer and other prostate cancer related issues. Also, we do have a conference coming up this September and I want to see you guys there in person. I want to be able to shake your hand. I want to be able to answer your questions with our helpline team, and that is going to be September 5th, 6th, and 7th here in Los Angeles, California at the Los Angeles Airport Marriott, and it's a great way to get your questions answered in person. We just want to see you there. Now, I would also like to thank our sponsors for this event because they were able to provide all of this education for free to all of you for free on YouTube. So those sponsors are Janssen, Bayer Pharmaceuticals, Novartis, and Dendreon. They have done a great job providing also some educational pieces on what they do in our exhibit hall. And you can learn more at pcri.org if you're watching this on our YouTube platform. And if you're watching this on our website, you can just scroll down to the exhibit hall. It's very easy to access and you can download any of their resources there. Our next speaker is Anne-Marie Chaker. She recently came out with a book this week called Lift, and it's incredible that we were able to have her. She was a Wall Street Journal journalist for over 20 years. She knew Dr. Moyad through that journalism, and they wrote multiple pieces together on collagen, weightlifting, and so much more. And she actually wasn't a weightlifter back then, but kind of changed her life around and then went into weightlifting. And she's going to be talking about the power of weightlifting for prostate cancer patients and for caregivers, what men need to know, what women need to know. It's really a powerful piece of generalized information where it can apply to both. So if you are with your caregiver as a prostate cancer patient, or maybe you're a caregiver watching, this is absolutely for you. This gives you practical tips on what you can do even together, or even with a friend if you don't have a partner you can do it with. But it's very impactful because you can do it sitting down, you can do it standing up. This has been a tremendously impactful session because it's a question that we get asked all the time. Can you give us some weightlifting protocols? We talk about weightlifting in every video, and so I'm so excited that we're able to present this today. She is a wealth of information, and so without further ado, here is Miss Anne Marie Chaker.
Oh man, oh man, oh man, oh man, oh man, oh man, a woman, a woman, a woman, a woman, a woman. Oh, this is 20 years of moderating. This may be one of the most incredible moments of my moderating sessions. And that is, I got to bring someone I've known for over a decade onto the show, and I got to bring her onto the show, and the rest of the world is getting to know about her, and she still agreed to come on, which is amazing. And I'll let her tell you about that in a minute, because this was the week her book, Lift, actually launched. Lift launched. That's kind of a saying. And so you can get it on Amazon, you can get it anywhere else. I've already read it. I read a pre-copy. I felt so guilty I got a free copy. I actually ordered a copy of it.
Aww.
And you're probably thinking, well, this is a women's health discussion. Yes, it is, but a women's health discussion is also a men's health discussion. So we thought every
Damn right.
PCRI, right? We think, wait a second, what about all the caregivers? What about all the people taking care of these men, for example? And not even just that. I want to hear from anyone that's good. So every couple of years, we would shake it up. For those of you who have been around the PCRI for a while, 10 years ago, I remember I invited a top-notch bone health expert from Georgetown University. She's been a friend of mine for a long time, and she gave a talk on women's health and osteoporosis. And so we decided to shake it up again and bring my good friend, Anne Marie. And Anne Marie, I'm not even going to give you an intro. I want you to give us a minute or two, if you don't mind, on how you got here and how this came about. I know this is a weird moment, but I'm going to give you plenty of props during our discussion. I want you to give your own intro, and then I'm going to add or delete to that when you're done. Is that okay?
That's great. That's great. And
Okay.
before we start, I just want to say thank you so much, Dr. Mark Moyad, or Triple M, as I like to call you, for having me on this. I have known you for, like you said, for over a decade. I was a longtime reporter for the Wall Street Journal, 27 years at the Wall Street Journal. And you were one of my go-to sources on my various food supplements type stories. You're at the University of Michigan. And some of our greatest hits, I'm trying to remember, we did a story on collagen.
Yes.
Collagen in food. We did a story on vitamins and supplements, I want to say. The best.
You did a lot on that.
Yeah.
You covered one of my early books.
It was always a joy to speak with you. We had a very fastidious fact checking before publication. I remember this. Very fastidious. And just hilarity and joy. And I'm just, and what I think is funny too, is that I've known you for so long, and you have a deep aversion to Zoom. When Zoom started happening, I think this is actually the first time I've ever met you face to face. So this is a lot of fun. I've always known the voice, but this is the first like live action version of Dr. Mark Moyad in AMC. So this is great.
Thank you. I am a shy person, but I think you saw pictures of me, and I think, I have to put, I'm all red now because that's like an introduction for me. That's very
Don't
sweet.
be red. I love it.
Let me say something back that, like I said before we even came on today, it's not just about strong women in my life. My wife, my mom, who came to this country with nothing, with my dad, who knows 6 languages fluently. I mean, you, Alex.
I love that. My parents were immigrants
this young
too.
person who runs a PCRI, a prostate cancer group. She's in her 30s, and I'm going, what is she doing? And all of a sudden, we realize she knows what she's doing. And, we're bi-directionally learning. So what I do want to say is you continue your introduction for the audience, because we decided this was going to be the one presentation over 20 years. There are going to be no slides. We got rid of all of our slides. This is going to be a discussion and then an exercise demo. At the Wall Street Journal, I will say, and I don't think I ever told you this, that I was lucky enough to do interviews for all the major networks, to appear on all the major networks. But one thing I could always count on with Anne Marie, and you have to pronounce your last name for the audience because I've messed it up for at least 20 times in 10 years.
No, it's okay. It's Chaker.
Chaker. See, like
Yeah.
Chaker.
Yeah.
And so I call her AMC, Anne Marie Chaker. And so AMC is the nickname. So of all the media sources, the reason why when she emailed me, I always answered her is that every time I read her articles in the Wall Street Journal, it was every time it was objective, it wasn't sensational, it wasn't about selling a product. It was so refreshing to hear someone just look at the data, get a bunch of interviews, and even if she thought I was full of it, she would call it out. And I just loved your objectivity. And that's why I always answered your calls. I'm not saying the other media outlets didn't have objective reporters. I'm just saying that sometimes you would do an interview and somebody would spin it in a way that would sell a product. And that was started happening too much, but it never happened with you. So to the audience, she was the best health reporter I had ever dealt with in my career. And I thought the best health reporter, the Wall Street Journal, for sure. Can I say that? I hope I'm not upsetting anybody. And that's why it was so smart to bring her on today as she tells you her story. How about that? I've never told you that, but that was what really attracted me toward your emails. I just knew you were going to write an objective story that always took care of the patients, that always took care of the public, that told them the truth. Woo! That's sort of.
I'm so honored.
That's an Oscar speech, right?
Oh my God. You never told me that before.
No, I didn't tell you that, but I was so tired of people selling off my interviews or my name or putting on a back advertisement to an interview. And I thought, Anne's not selling anything. She just wants to get her audience to know the pros and cons of whatever it is, collagen, you name it. And you did such a good job. And that's why I'm sad that you left reporting, but I'm also happy that you're doing what you're doing. So tell me what you're doing now, even though I know, and tell me why you're here. I mean, of course, I know why you're here. Tell me your backstory and how this came about, which just came out. And take a couple minutes for that, and then I may interrupt if you don't mind.
Sure. So that book was born of a time of struggle in my life. I had my second child and was really suffering from postpartum depression. I had lost my father a couple weeks after my daughter was born, suddenly of a heart attack. My marriage was crumbling. So a lot of tough stuff happening in my life, and was drinking a lot and, not healthy. I was not, exercising and very out of shape. All of this came to a head when I took my daughters on a trip, and we were staying at a hotel, and inside this hotel was a little fitness room. And I poked my head in and saw this mom who was just crushing her workout. She was lifting barbells and pulling bands and doing things that honestly I hadn't seen since I was in a college weight room years ago. And I looked at her and she looked incredible. And I looked at myself and I thought, what happened to me? I had been a college athlete. I'd been a competitive figure skater growing up, and it just felt like that time in my life was a distant memory. I spoke with the woman and kind of started following her regime and got in touch with her coach, who was a retired bodybuilding coach. I started weightlifting, and it was this weightlifting that honestly changed my life. And I eventually became a bodybuilder and wanted to write this book to take people through this journey of transformation, how, this kind of down and out, single mom, newspaper reporter, struggling with a drinking problem, went on to competitive bodybuilding stages with, a fake tan and a sparkly bikini, flexing muscles, to really show people that transformation is possible and that, weightlifting is such a good thing to transform your life.
You're no longer at the Wall Street Journal, so now you're an author, and now you're going to be doing can I say some of this stuff? You're going to be doing a podcast. You're going to be all over the place. I mean, you're starting to be all over the place, but can we tell other people where you're going to be? I mean, we're going to have links to all of this on PCRI, but you've got, besides the book coming out, you got a couple other things coming out, right?
I've got other content, shall we say, entrepreneurial projects cooking. I'm not at liberty to say what they are, but stay tuned and
Stay
follow
tuned is
me.
good.
Yeah.
So yesterday I saw it, for the audience, she looks bright-eyed and ready to go. She's got some verve, but I'm surprised you're even here today because yesterday I think you had to go to New York and do the CBS morning show. Is that right? Was that yesterday?
Yesterday, yeah. Yep. That was fun.
And that's a grind, right?
That's a lot. It was a lot. Yeah. You gotta, I live in Washington, D.C. Took the train in. It's very early in the morning. And, I'm not used to that sort of thing. So I was, kind of practicing what I would say and, very kind of, the answers have to be very tight. And, it all feels like chaos in this studio. And, but I'm so glad that I did it. It got so much reaction from the public. I forget how, when you're out there in the media, like people learn about you and they buy your book and it's all very exciting.
When media starts covering objective people, it makes me happy. So, all right, we're almost done with the beginning and I'm ready for some of my questions for you. Let me just go through.
Fantastic.
Let me just go through some items, okay? Here's a quick quiz. Are you ready for the quiz?
Oh boy. Okay.
The first quiz is, who was your favorite and most knowledgeable, valuable, game-changing, covert health information source when you were working at the Wall Street Journal all those years? Your choices are A, Dr. Mark Moyad, B, Dr. Mark Moyad, C, Dr. Mark Moyad, or all of the above?
All of the above.
Okay, correct.
D.
You're 1 for 1. That means you're entitled to a gift at the end of the talk.
Ding,
all
ding,
right,
ding.
that's the correct answer. All right. Then are you ready for this one? If that's the correct answer, then where was the Dr. Moyad shout out in your new best-selling, amazing, incredible, wonderful book, Lift by Anne Marie Chaker? Where was Moyad? I looked in this thing. There was no Moyad in here, man. That's all right.
I'll autograph you a copy. I'm sure there's like other people that I forgot to.
So just in case you would have put me in, I would have endorsed it. Let me tell you how I would have endorsed it for the public. Because I read plenty of books. I get tons of books from authors that want me to say something, comment on them, pre-print and not. So this is what I would have said about your book, and then we're going to move on because the audience is probably getting nauseated by all the fluff going on back and forth between me and you. All right, this is what I would have wrote. Mark Moyad, circa right now. This would have been a blurb in your book.
Okay.
Although the book Lift initially appears to be a book for women to, quote, reclaim their physical power and transform their lives, end of the quote, I feel it is also a book for everyone. Not only does it call you to action, but shows you how to spend very little money in transforming your mental, physical, and spiritual health in a short amount of time. It's an inspiration for the ages and for all ages.
Ooh.
Whoa.
Wow.
That's a mic drop. Is it mic drop or drop mic? I'll never figure it out. It's one of those, right?
Oh my God. I love this.
That's my review.
Great.
But you know what? That is
so
a
great.
serious review because the biggest problem with your book is the biggest problem I've had writing journal articles and all this. Mm-hmm. There's no super pizzazz magic elixir. It actually just takes you through some of the work you have to do, right? It doesn't promise that if you take this liquid overnight, it's going to transform your body. It's just good advice. And so that's why I wrote that blurb. So if you ever want to use that blurb, let me know. That was from the heart.
Oh, you're the best.
Thanks. I feel like the best today. Anyway, all right. So we talked about your story. We talked about our history. I thought it was, by the way, in case you haven't seen this, there's many, Billie Jean King. There are many people who endorsed it. Here's one of my favorite. I'm so pumped up that Lift and AMC terminates. I love that. Outdated myths and shows that training isn't just about physical strength for women. It builds mental strength and has benefits outside of the gym. This book is a game changer that will open your eyes about female strength. Arnold Schwarzenegger.
Isn't that great?
Same area that my mom is from Austria.
Oh my God. Arnold to me is such a hero. He was a hero. My father was an immigrant and my father loved Arnold. Just like the ultimate American story, came to this country, became a Hollywood star, became governor of California. I mean, what a life.
Wow,
What a
right?
life.
Yeah. No, so it was cool that you got some of
That
these.
meant so much to me. Yeah.
Yeah. I still think the Moyad quote was more powerful, though.
It was really good. I might have to wallpaper my house with that.
So I just want to comment on one thing before we move on to just the weightlifting topic. What do you say to people about that's weightlifting, but what about aerobic? Like I'm a runner. I did a long run this morning and boy, it gives me a lot of strength. It gives me a lot of mental boost. But so what do you say in terms of your book and in terms, I know we're just going to talk weightlifting. What's your comment on just aerobic exercise, treadmills, ellipticals, running, pickleball? Not that I'm a big fan of pickleball. Sorry, everybody out there. But some type when young people ask you, and do you do aerobic exercise or do you just primarily do weightlifting?
So I do cardio activity in the weeks before I compete, where fat loss becomes important. So we cut as bodybuilders in just the few weeks before competition day to achieve a stage lean physique. So that's, specifically for the sport, for the stage, we want to show muscles completely striated and we get very, very lean. And then, when that competition is over, we refeed and we build back to a normal, more healthy layer of body fat. So in those weeks before competition, in the cutting phase, we do quite a bit of cardio for fat loss. But, there's nothing that can replace resistance-based strength training. It is so important for many reasons, which we will get into.
We'll get into, yeah.
Yeah.
So you do your aerobics. I mean, because how many competitions do you have to go to in a year?
I think of it more in every other year. I don't do it every year. It takes a lot out of you. So every 18 months is usually like a good period in between competition seasons. So I will be competing again this year in August and September. And then I'll probably rest up and build back for a year and then compete, 18 months after.
So then before we talk about the evidence behind weightlifting and everything else, I want to cover all the ancillary stuff about around weightlifting before we talk about it directly. In your book, you like to talk about, I don't know why I use the word diet. I guess I started using the word dietary pattern, the majority of what you do. That's become a very she word. Your dietary pattern. So can we talk about some of the dietary thoughts you have? For example, I know you mentioned macronutrients and other things. I thought just breaking down the very basics.
Yeah.
How do you even approach your diet and your dietary pattern and what you tell people as a weightlifter?
Yeah. So I eat very boring. And I covered, when I was at the Wall Street Journal, I covered food trends, right? So I saw it all. The maligning of carbohydrates, was big for a while. And then, these magical ingredients crept up. First it was like cauliflower. Cauliflower was suddenly in everything, and they were making pizza crusts out of that kind of went away. And then it was sweet potatoes became like this hero ingredient. You saw sweet potatoes was going to save the world. So I mean, I've seen, diet. Then I remember it was the coffee. Do you remember the bulletproof coffee they were putting?
Bulletproof. We did that story.
Was that a story we did?
Yeah,
okay,
bulletproof.
Great.
Anyway,
great.
Yeah.
It was so, hey, let's put butter in our coffee and you won't get hungry again until afternoon. Well, duh, there was so much of this. I think of bodybuilders think in terms of macronutrients. And the big three macronutrients are carbohydrates, proteins, and fats. I love to make my own food. I eat out very rarely. And I love eating well at home. You eat best when you make your own food, stock your fridge really well. I do my big shop on Sunday, another fill-in shop on Wednesday or Thursday. And I cook and I cook simply. I do Tupperwares. So the carbohydrates I have are usually, either boiled potatoes or sweet potatoes, and cooked white rice. And I keep that in a Tupperware in the fridge. I always have a big green salad on hand, and it can look like, whatever greens. I like bok choy, like shredded cabbage. It doesn't have to look like a traditional salad, but a big mishmash of greens in a bowl that everybody in my household kind of eats from.
Yeah.
And then my proteins, which are my greatest hits, are frozen bags of shrimp in the freezer. And I love liquid egg whites, which I know sounds weird, but it's the liquid in the smoothies that I make. They're pasteurized, so totally safe to eat raw. It's flavorless, and it amps up your smoothies with a ton of protein. So liquid egg whites, I have cartons of them in the refrigerator.
Where do you get those liquid egg whites, by the way?
Any in the egg section, any grocery store will have liquid egg whites in cartons. So highly recommended. My smoothies are liquid egg whites, banana, and a scoop of like whey protein powder. And maybe for fats, a little bit of peanut butter in there. So delicious. So delicious. That's all. I always consume one in the afternoon.
And do you find them filling?
Filling and delicious and kind of energizing. Just a beautiful thing to consume.
And so as your temporary right now unpaid manager.
Yes.
Why can't I convince you to take your favorite smoothie that you make at home and then we can post it?
Oh, I'd be happy to. Yeah.
Because you've been talking to me about your smoothies for a year. And I've thought to myself, I wonder why I haven't asked her just to give me the recipe and let us all try it, because I know the nutritional content of it is pretty dynamite, and you said it tastes good. And so I'd like to find out if it actually tastes good. And so I just came up with idea number one. You can think about it, but I think you should put together, you can call whatever you want, call, AMC's, the Shaker Shake or something.
I love that. You should be my social media manager.
I should. I've done a couple interviews with celebrities and I've come up with stuff for them and they've said, wow, you should do my social media. So this is where I'm thinking. So the Shaker Shake just made for us. So that's cool. Did you cover all the ingredients or did I interrupt you? I apologize.
No, I think you got it.
Okay. What you said in the book, and I couldn't agree with you more, is carbs have been vilified. And the reality is some of our healthiest areas of the world are actually high carb diets. And what I think also people forget or we're not taught is that fiber is a carbohydrate. And everybody's telling me I don't get enough fiber. I'm not saying me, the world. Yes. And fiber does this, it fights this, it does this, it's heart healthy, it's gut healthy. And I'm going, well, why don't we call fiber what it is? It's a carbohydrate. So if the Mediterranean diet, which was just ranked #1 by the cardiologists all around the world in my business, if it's such a great diet, why aren't we telling people it's very large in carbs? So I don't care if you call them good carbs versus bad carbs, but carbs, I think one of the points in your book in your diet section is don't vilify carbs. And I thought that was cool.
Yeah. About 50% of what we consume and should be consuming are carbohydrates. And, I remember eating with someone who said that they tried to avoid carbs and then they were eating a big green salad. And I was like, you're eating carbs, which is so ridiculous, So carbs is so much more than just potatoes and rice. It's in our vegetables too. And, we should all be eating more vegetables. So stop with the blanket, vilify. We, as a society, I think we like to demonize things, or something is good and something is, but like we need to have like the magic pill or something to vilify.
Yeah, just once in a while when this stuff makes me wacky. I finally read something from one of the families of the individuals that created the blue zones, and there's. Blue zones get some criticism, but the reality is it's a really good way of teaching people. It's sort of the sum of what you do. Lifestyle makes a difference. And so they asked the blue zone person, what's the one food that you've seen consistently across all the blue zones that everybody eats every single day? And the answer was interesting. It was beans and lentils. And I thought, well, that's a carb. That's a carb.
Right.
So that was the one thing he picked of all of his research. I thought that was interesting. The other thing he said is you are who you surround yourself with. In other words, if you surround yourself by healthy people who push you, then you're more likely to become healthy. But getting back to the point, he was basically saying, why are everyone bad-mouthing carbs? Because wherever I go in the world where people have longevity, carbs form a basis of their diet.
Yes, absolutely.
Do you eat fast food ever? Please say yes.
I
say
have
yes.
kids and they love McDonald's, and there's nothing wrong with Chick-fil-A, some of their food. And when I'm there, it's fine as long as you're not eating it like 3 times a day.
Right.
It's important to have a life, and food and fun foods are part of the joy of life. So if I'm 8 weeks out from competition, no, I'm very careful, but in most of my normal life, I eat pizza with my kids and I eat the birthday cake. Sure.
Good for you. Good for you. I always tell this story when we're doing meetings that in my heyday, when I had to travel every week, I got to meet some of the top authors and people working in nutrition. And I'm not generalizing, I'm just saying some of the people I bumped into who would tell everybody everything that they put in their mouth makes a difference. And you have to only eat a certain way. And then I would go to dinner with some of these people, and I found out that they were some of the most stressed out, anxiety-prone people I've ever met because their entire existence becomes about every single morsel that goes in their mouth. So we call it overanalysis leads to paralysis. It was just too much for me. And I felt like it was too much for them. And it helped me back off in my career in terms of the rules. So
it's important to live your life. And, food is part of our social fabric. It's the way that we spend time together. It's the way that we make memories together. And, everything in moderation, as we say. And, bodybuilding is a specific sport. And when I'm training, I have to be very careful. But then when the competition is over, I spend most of my life, in the off season. And part of that is, building and eating enough and making sure I'm eating enough protein and fueling my body. And having fun when I can.
All right, I love that too. I love that, but let's talk about a specific macronutrient that never goes away. It's constant, and you talked about this too. And this is protein supplementation. So you talked about this is important for the audience. The recommended daily allowance is 0.8 grams per kilogram of body weight. Another way of saying that is you're supposed to get 0.36 grams of protein for every pound per day. So you basically, if you weigh 200 pounds, you multiply that by 0.36 and you're supposed to get around 72 grams. If you weigh 125 pounds, that's 45. But the reason I'm bringing this up with you today is you talked about this a lot in the book, and I couldn't agree with you more that there is a real push lately to, as we age, that this number should be taken up higher. So I guess I have multiple questions here. What do you think about this protein movement, and what do you think about the recommendations daily for protein when you're weightlifting?
Yeah. So if you're trying to build muscle, which we should all be, that number should be higher. And I can tell you that a good rule of thumb is to aim for a gram per pound of body weight, of your ideal body weight, right? So generally, I think if you're, for women, for anyone really, aiming for 100 grams or more is a great place to start. And I weigh, around 120, between 120 and 130. So I try to get between 120 and 130 grams of protein a day. Yeah, which sounds like a lot, but once you have to use it, it's actually like, just make sure you're eating pretty lean protein. That doesn't mean like 3 hamburgers a day, but for instance, the liquid egg whites in the smoothie, that's going to help you a lot. The frozen bags of shrimp in the freezer is also going to help you a lot. Grilled chicken is another. We always, do grilled chicken tenderloins on the barbecue, and we have those in the fridge as easy protein. Turkey crumbles, another one of my greatest hits. I mix 93% ground turkey with 99% ground turkey in a pan. I get that brown. I usually throw a packet of taco seasoning, which you can get from you can put any seasoning you want in there. Always have that on hand. The kids do that on tacos. I do that over salad or with rice or whatever. It's just so delicious, so easy. So those are some of the great, and with the combination of those, you can get a ton of protein in, and it's not that hard.
Let's go back to this. So we've talked about protein. You talked about increasing the amount of protein. From my conversation with you, it's obvious you're not vegan.
No, there was one half-hearted attempt years ago, and I will never go back. No.
So do you have bodybuilders I've seen some people, sprinters, bodybuilders that are able to do veganism.
Yeah.
Do you see that?
I've heard of them. I don't know how they do it. I don't know how they do it, but there are some. Yeah.
Yeah. So it's an interesting movement that's there. Well, I've always said I think it's a beautiful movement. I'm not capable of adhering to it. It's just not.
Yeah.
And as I get older, I find that we're all moving that a certain direction anyway, more plant-based, but the idea of going fully, I'm a weak individual.
Hey, have you tried that cellular meat yet? Have you tried that?
It's so funny that you mentioned that. So I've talked to some of my vegan friends. My son is vegan, and so is his wife. And so they have this cellular lab-based meat, right, that you're talking about, and they sell it in Singapore. And I used to have to go to Singapore for work a lot, but I never got a chance to taste it. The answer to your question is, I'm very excited about the lab-based meat movement because it would solve a lot of issues.
Right.
I have not tried it. However, I've looked at the numbers, and I thought it was going to come out in mass format in the next year or two, and it looks like it's so badly delayed that we're looking at years and years away still because of cost.
Oh, really?
Yes.
Oh, interesting.
So I think it was the Wall Street Journal. I don't remember. There was a report, maybe Scientific American. The idea is that people are moving along, but the costs have been so much more than ever anticipated in terms of what they can produce. That, it was a year ago at this time, we thought it would be in multiple places, and it's not.
Right.
It's a supply issue. They can't produce it and fast enough. It's too cost. So this is like anything. Do you remember I had the first Mac computer, which was gigantic, cost a fortune, and now I'm on what I'm on. I think the same thing with lab-based meat. I think it's going to be a big deal for your kids and my kids. It's going to be, but I haven't seen it apart from Singapore. California's opened up the possibility to a couple of companies, two in particular. But that's an important question, and I think that's going to be an exciting change.
I'm excited to try it. I bet it tastes I bet it's great. And it's funny that you say that because I feel like a year or two ago we were hearing a lot about it.
Exactly.
And we've stopped hearing about it.
That's right. That's because a lot of the startups have gone through the money. It's been very expensive, and everything about it sounds great. It's just not ready for prime time. But it will happen. It will be a great moment. But no, I have not. I've been really itching to try it. So we talked about that, and we talked about protein. So plant versus animal-based proteins, whatever floats your boat, right? And at the end of the day, I always argue, what we've tried to argue is that whatever your belief is, are you getting to goal with your dietary pattern? So I used to tell people that there are 5 Bs when it comes to your diet and your lifestyle. And the 5 Bs were, hey, is your diet moving you in the right direction in terms of blood cholesterol, blood pressure, blood sugar, BMI, body weight or belly fat, and then your brain health? Do you feel mentally okay when you're on your dietary pattern? Are you happy? Are you miserable? And a lot of people, when it comes to diet, I have found the fallacy is diet sort of gets a free pass in the sense that everything else in medicine, you have to have an objective marker to tell you that you're getting healthier, right? Maybe it's the PSA in prostate cancer. Maybe it's an imaging test in breast cancer. Diet's the one thing where I don't care what diet you're doing and what makes you happy, but is it moving you to a healthier place? Like if you go to your doctor, are your numbers getting better or worse on your pattern? And so you see all people on all sorts of diets where the numbers get worse, and you see people on all sorts of diets where the numbers get better. I just wish people applied more of that kind of medicine to their dietary pattern. So, for example, if you were getting ready for competition and you were gaining an extra 10 pounds of fat before competition with your diet, and your cholesterol was going through the roof, or your blood pressure, or your anxiety, or mentally you weren't in the right place, that's a bad diet. I just don't think we're applying those principles enough. That's, again, I'll get off my soapbox on that.
It's 80% of the name of the game. I mean, it is in the sport of bodybuilding and trying to shape a body composition. It is like 80 to 90% of the name of the game is what you consume, and it's the hardest thing to zero down. I mean, my coach was telling me, like, anybody can go to a gym for an hour or so. That's easy. But controlling what you put into your mouth for the other 23 hours of the day, that's hard.
It's really hard.
So, yeah. But again, that level of precision is specific to the sport. You want to get it mostly right for most of your life, but without being like super, fastidious about it. Still giving yourself the leeway to enjoy your life. And that's a challenge. That's a challenge. I would say the name of the game is keeping your foods as whole and homemade as possible, and avoiding like junk in a box for the most part. I mean, the problem with that stuff, I don't know about you, I find it very, very addictive. And that's, it's hard to stop eating that stuff. Once you open the bag of chips, or the bar of chocolate, whatever, even the crackers, that stuff it's made to be addictive. That's the food companies want you to not be able to stop eating it. So, this sounds really boring, but unfortunately it's the boring stuff that withstands the test of time.
Exactly. I couldn't say that any better. The boring stuff. So let's talk about something in diet that's not boring, and tell me your stance on it. So I decided to do a quick search before the interview. I wanted to look at, we're not going into that section yet, but we're going into it soon. I looked at the top 3 things people use or purchase in terms of supplementation when they're lifting weights. And in the top 3 was what I thought was in the top 3, but one isn't necessarily a supplement in my mind, and that's caffeine. How do you approach caffeine? Do you utilize caffeine for your workouts? Because some people really like it as a stimulant to get out there before they go running and before they lift weights. But what do you do?
Yeah. I do take a little bit of like a half a cup of coffee before I go out for a lift. There's all these energy drinks on the market. And really it's caffeine. So you can buy one of those, I guess, or you can just, if you happen to have a little bit of coffee at home, use that, which is what I tend to do.
So you use that before your workout?
Yeah.
I have found that's one of the more brilliant things to use before any sport. I used to tell some young football players, it's what I use right before I go running. It's what I use before a race. That's interesting. And it's interesting you said the volume of coffee you use, because I do find that if you go too high on the volume, then you want to use the restroom, right?
Yeah. For me, yeah. And I'm the kind of person, I never finish. It's got to be the right level of hot for me. And after like a few sips, like it's over.
That's fabulous. So caffeine as something in the diet you're a big fan of.
Yes.
That makes me happy. Egg whites we talked about. The other thing I always find interesting too, sometimes we should call this, and I'll call this for other things, is that life is not binary, medicine's not binary. And what that means essentially is, the other funny thing is when we talked about carbs, people sometimes look at insulin as a bad thing. And last time I checked, you need a little bit of insulin in order to build muscle, because so I'm just saying that it seems like in our world, people want to say, yeah, all good or all bad. But in reality, there are these shades of gray all over the place. I guess that was the point.
Absolutely. I couldn't have said that better myself.
I don't think this gets enough attention. So I actually did my own video on it, and it got a bunch of attention, which I'm happy about. And I wrote some columns on it. And I still don't think I'm talking about it enough. And you've brought it up in interviews, you brought it up in the book, you brought it up here. And that is, in terms of weightlifting, life, working out, alcohol. Now, we know in the past year, from the WHO to the Surgeon General, people have now vilified alcohol. And now we've gone from 1 or 2 drinks a day was okay to no amount of alcohol is okay. Fine, whatever that is. But I still think, I agree with some of that, that alcohol sabotages so many things. And I find it to still be one of the greatest drugs people use for self-medication. So I don't know if you can comment or what the question is, but the idea of alcohol and fitness, I don't see those two as being achievable. But help me on that.
I don't drink when I'm, in the weeks ahead of competition. I cut it out completely. And I will say that I feel so much better when I do, no question. However, in my those non-prep weeks when I'm off season, I do have a glass of wine with dinner once in a while. For me, a challenge is moderation, right? I think I'm a very sort of extreme person. Either I'm all in and and so in my life in general, finding like a happy middle has been its own challenge. And a thing that I strive for. So alcohol to me, I always keep that in mind. Like, I limit it. I don't, drink at home. It's when I'm in a restaurant. If, 1 or 2 glasses of wine, I'm good. And that's kind of the happy middle for me. How about you? Do you drink?
That's the same. That's why when I read in the book, I thought that's exactly what we've evolved to at my house. We don't drink at home anymore. I found that with my generation, whether I was in Florida, whether I was in Michigan, I found that as people were going in their 50s, 60s, and 70s, they were drinking a lot at home. I mean, you suddenly find yourself with more time as you're slowing down. And I feel like it became arguably the #1 drug that I saw people succumbing to in all sorts of ways.
Yeah.
And it's easy because when you go out with friends. So a couple of years ago, my wife and I decided we're just not going to drink at home. I mean, I don't remember the last time we drank it home, but when we go out with friends, we'll have a glass of wine, we'll have a beer, and I really look forward to it. But it's even hard to keep that in control. Because it's fun to do, but there's no question that every part of my body from head to toe, if I can abstain from drinking that day, like I did last night, I was supposed to go out and I said, no, I got to interview AMC, I got to practice what I preach. I slept like a baby last night. I sleep soundly when I don't drink. I don't get up and have to use the bathroom. And we know that alcohol robs you of your deep sleep. So it helps you fall asleep faster, but the type of sleep you get is cheap sleep, I call it. It's not deep sleep, it's cheap sleep. And we know it helps put on the weight. I mean, it really helps put on the pounds, changes your cholesterol. We know there's a linear relationship today between alcohol and blood pressure. The more alcohol you drink, the more your blood pressure cranks up. In fact, I always find it interesting that every diet book or the new books on blood pressure, one of the first recommendations is stop all alcohol, and someone goes, wow, I lost 10 pounds. Or, oh, my blood pressure came down 5 points. That's because you stopped all the alcohol. So I just think people need to reevaluate. I've had to reevaluate. My wife and I have had to reevaluate. And we landed at the same place you talked about in the book, that I'll go out and have some for celebration. You've talked about some of the most fit women that you've read about, that they'll use alcohol to celebrate after an event. I think there was a marathon runner you talked about from Ohio, and she's in her 80s or something, or 90s. And that's all I have to say about that, unless you got anything else. I just think it's the elephant in the room. It should come up on every discussion of fitness and dietary pattern, because it's a part of diet.
Yeah, it's an individual decision. And again, what we talked about before, like we're such a society of like, this is good, this is bad, that sort of polarization. I think it's important to, if you're going to allow something, allow it in moderation. And what that does is that, for me anyway, it really kind of opens it to, this is special. This is a treat. I'm going to enjoy a beautiful glass of wine with my partner at dinner, and I'm going to enjoy that. and then I'm going to call it a day. And, at home, if I had it at home, we would lean toward, like, make, I don't know. And I just didn't, I don't keep it at home anymore. Just don't want to have it around.
No, I think that's real. I think that's critical. So the video that I did was called ABV plus V equals WTF. And it was
That's good.
It was my way of shouting back and saying, don't you understand what's going on here? When you have a drug, manufacturers like to concentrate that drug in order to increase the chances, in my opinion, of addiction. I don't care if it's sugar. I don't care if it's fast food. I don't care if it's caffeine. So what's happened is there are all these craft beers now. When I was a kid and we snuck beer, it was 4%, 5%. Now it's 8 and 10%.
Yes.
So you crank up the calories, you crank up the alcohol by volume, and suddenly what you have is more weight gain, more health issues, increased risk of cancer. And what you have also is much more concentrated alcohol, whether that's a wine glass used to be this, and now it's this. A shot used to be 1.5 ounces, now it's 2.5. And it creates a situation where alcohol becomes, that was what the video was about that struck a nerve. It was, hey, look what's going on here. I know it's fun to drink a 9% beer, but it comes with a cost. That was all I was trying to say.
So interesting.
I know a concentrated caffeine drink, everybody loves it, but it comes with a cost. And that is your body wants more and more of that concentration the next time.
Yes.
And the withdrawal that you see from alcohol is scary. I mean, just the withdrawal symptoms. But again, you mentioned.
And as you get older, you really feel it, don't you?
You feel it.
And
metabolically, people forget that when it comes to drugs, it comes to caffeine, it comes to anything. As you age, metabolically, things become more challenging to essentially get rid of and eliminate.
Yeah.
So the half-life becomes longer and longer. Things sit in your body.
Yeah.
And alcohol, man. So
it's a toxin. It's called intoxication for a reason.
Yeah, I mean, I love it, but I can't love it too much anymore. All right, you ready to talk about some one or two supplements and then do the demo?
So I take a multivitamin. I take calcium, and I take fish oil. You and I have not talked about. I don't know if have we talked about fish oil?
I don't know. We talked about so many things that I just kind of figured we talked about everything.
So those are the ones I take. I'd be interested in what you think about that.
What I used to tell people is I still do. I would always just walk through. Just let someone tell you what they take. You said multivitamin, calcium, fish oil.
Yep.
Why do you take a multivitamin? And it's not sarcasm. It's not trying to be I'm not trying to humiliate someone or be condescending. I'm always curious as to what got them to that point, and then it helps my thinking in terms of education. Why did you end up taking multivitamin?
I just think it's something that just a security measure to make sure I'm getting all my vitamins. I don't know.
I think that's a good point, because as we get older, so this is the multivitamin I take. I have no affiliation with this company.
Okay.
It's the only one that's gone through a phase 3 clinical trial 3 different times at Harvard. It just finished up. It was called the Cosmos trial. I talked about it in the supplement handbook, the book I did a long time ago, because it was accumulating so much evidence as a cheap, high quality, evidence-based product. And then people got mad. They said, you must work for Centrum Silver. No, I don't. But there are other good supplements. I said, there's plenty of good multivitamins, but if it was me, I would compare my multivitamin to theirs in terms of what's on the label, because this has gone through such rigorous testing. Anyway, what they found in people my age, a little bit older, was it helped cognitively. So if you start to watch more TV lately, which I'm doing in the summer, if you look, Centrum is now saying improves cognitive health, which is highly unusual. It's highly unusual for a supplement to make a cognitive health claim. And they're allowed to do that because of this massive Cosmos trial of men and women.
Wow.
It found that it slowed cognitive aging by 2 to 3 years on average. It was tested 3 times by Harvard in this big trial. It was tested in person, it was tested on the phone, and then there was web-based testing. All 3 of them surprised the researchers. That's why if you go type in Harvard, Cosmos, Centrum, most of them are now endorsing it. They're saying somebody should take a multivitamin daily. So that reason alone, I think, is a brilliant reason to take a multivitamin. So I'm glad you're taking a multi. I don't know if you have any questions, but that's where I am in the multi. It's as hot as ever before. People then
Wow.
hold it to this ridiculous standard. Some physicians will do this. Well, it hasn't been shown to prolong your life. And I'm going, wait a second. If I found a pharmaceutical agent that cost 3 cents a day that slowed cognitive aging by 2 to 3 years, we'd all be talking about it. Whether it helped you live longer or not, if it improved that level of quality of life, everybody would be talking about that drug. Why are we now holding it to the standard that it's got to make me live longer? I don't know if it makes me live longer. Nobody knows yet. But
Right.
I find there's a group of people medically that get so stubborn, it doesn't matter what the evidence is, they still want to poo-poo the multivitamin. But I think it's a good job to take it. Plus the insurance. That's what Harvard always says too. They said it gives you all these nutrients that if you don't get enough of, it gives you that extra level of insurance. It's not too much or too little, right?
Yeah.
You got me on my soapbox again. I think it's brilliant you take a multi.
Well, great. I mean, I think you're the expert on this, not me, but I think with supplements, you might get something out of it, right? You might get a sheen of a little bit of something. We don't really know, but maybe, and if it's not going to hurt you, then yeah. So that's my, again, it's not a magic pill. It's like, we'll talk about creatine and the buzz creatine has been getting, but none of this stuff is, but you take it because, exactly.
But you should type in Centrum and Cognitive Health.
I will actually. I think the one I take is, I think it's Trader Joe or something, but
But a lot of the Trader Joe's, a lot of the ones, the Sam's Club, a lot of the Costco,
right?
These are outstanding. All I make sure is they've got a quality control seal. I'm just saying that this should become your comparative because this is
exactly
all the clinical trials. It doesn't mean, ladies and gentlemen out there, that I'm endorsing it. I'm saying that you're comparative, but this is the one that was used in the Cosmos trial. And the Cosmos trial was strong enough data that many doctors, including myself, thinks this needs to be now applied to clinical guidelines. It means that in the future, doctors need to be taught that when a patient says, I want some help in terms of improving my cognitive health, it helped with certain types of memory, but I want to slow my brain aging. What can I utilize that's cheap besides exercise, which is probably 10 times better? It's nice that we can say this. So all I'm trying to say is that after 35 years of doing this, to be able to see a commercial that's allowed to say that it may improve your cognitive health and it has evidence is mind-blowing in my world. Because in the past, when people said that, they were getting away with a lot of times trickery. So the lesson of today is I just find it so interesting that people will spend $100 a month on a mind supplement, and lo and behold, along comes this thing that costs me $1 or $2 a month, and it's got the most evidence of anything else out there, and that's called a multivitamin. So
that's amazing.
The other thing is, if let's say you are vegan, well, it's got enough B12, so you don't probably have to take a B12 supplement. Let's say your doctor told you to get more vitamin D. It's got enough vitamin D that you don't have to take a separate vitamin D supplement. So it's really like 3 or 4 pills in one, saving you a fortune.
One of the things that I think is so interesting as a journalist is that how supplements in general have just taken off. And I think it's the podcasters do an incredible job of shilling and marketing these things. And there is so much, money in this space. This is where the money is. I'd be interested in hearing from you, like what you think this whole podcast sphere has done to the supplements market. It's almost like, people will believe anything.
It's $1 billion.
How have you seen this space evolve?
I've seen the space evolve I've evolved, and that space has evolved, and I've evolved into letting people know that I think the first rule of thumb is when you make something available over the counter, the ability to create a generic is almost immediate in almost every case. Meaning, I had a saying with the students, I still do now, it doesn't mean I go there a lot, it just kind of draws home the point that in general, the supplement business is big. I'm glad for one reason, because I do think a number of them are utilized throughout medicine and don't get their due. The downside is there's a lot of people getting also ripped off. However, one of the sayings I still tell the students to say to their patients is if it costs more than Costco, you may want to think twice, meaning that you don't have to go to Costco, but Costco supplements are cheap. And so you think, well, they must not be high quality control. Almost all the Costco supplements, or most of them, have a third-party quality control seal on it. So they have great quality. So do a lot of other places. It's just they are able to get a cheaper price and sell them for cheaper. So I think it's not going to make me a lot of money. It's not going to get me on a supplement commercial. But we do have to tell people that you can find really high quality supplements for a low price. You don't have to spend a lot. And that's been the biggest problem I've seen with supplements taking off. People being convinced that something that costs thousands of dollars is somehow better than something that costs $5. Now, there's some exceptions to that, but I think the first rule of thumb is I want the cheapest price possible, but I also want the cleanest product possible. And then I also look for clinical evidence. And I have found throughout my 35-year career, the moment I could no longer endorse a product, if someone asked me to, is because there are a lot of very cheap, high quality products that have a lot of clinical evidence. You just got to go find them. So I think what breaks my heart sometimes still today with this movement, I'll talk to people that will spend thousands of dollars, sometimes a month or every 2 or 3 months. And I'm just going, look, if you're aware of the truth and you're still doing that, that's fine. But I think you should reevaluate that. I would rather have someone spend a handful of dollars on their supplement and spend that thousands of dollars on a good piece of weightlifting equipment. I think we're paying a price for people trying to expect so much from a bottle. I would rather have them save more money on a cheaper product that's high quality and then use that money for a trainer, for barbells, for hand weights. My wife just got a Pilates machine. I used to make fun of Pilates and her Pilates because I didn't know a damn thing about it. And then I get on the Pilates machine that she bought in our house. I'm like, so this is what this is about. I mean, it's really exciting, right? Now I'm a big fan of Pilates. So it's a long answer to your short question, but I think the movement is positive, like anything positive, but it has a dark side. But I just wish people would follow the rules of if it costs more than Costco, just reevaluate. And so, but it's all perception versus reality, right? I talked about when we were doing the sleep interview with Dr. Rice, I tried to explain that some of the biggest selling supplements in this country are actually prescription drugs in other countries. People want to play this game that it's natural, it's a supplement. A lot of the biggest selling supplements are actually have a prescription option. You take fish oil. Fish oil comes in multiple prescription options today in the United States and around the world. We talked about melatonin. Melatonin in the United States now has multiple prescription options. And in Europe, one of the biggest sellers for sleep is a prescription melatonin. So this idea that supplements are different from prescriptions is more perception versus reality. I think we should be highly objective and highly analytical when it comes to supplements and see what you individually qualify for. And can some of them cause problems? Of course they can. That's why you have to do your homework, but they should be individualized. That's what they do with drugs. I don't know why we don't do that with supplements. So anyway, look what you're doing. You're turning the tables. We're supposed to be talking about lift and you're lifting me up. Anyway, so but that's an important point. And you take calcium. And so what we tell people is if you get the recommended daily allowance of calcium, 1,000 to 1,200 a day, then most people don't need a pill. But if you have a tough time getting enough calcium daily, a calcium supplement is brilliant, right? And there's 2 types of calcium supplements, calcium carbonate. There's more than 2 types, but the 2 biggest sellers are calcium carbonate. That's what you see in Tums. And that's what you see in a lot of products. And then there's calcium citrate, which doesn't come with an increased risk of kidney stones. And you can take it on an empty stomach. So it just depends what you're looking for in your calcium supplement. And then what was your third one, fish oil?
Fish oil.
So you probably take calcium. Do you take it for your bone health or do you take it for,
Bone. Yeah. I think that's pretty typical that they tell women to take calcium. Yeah.
And then fish oil is one of the top 3 or 5 in the country too. So fish oil is a classic example of a little's good, more is not necessarily better. In the studies that have looked at huge quantities of fish oil, it's come with side effect catches. But the studies like Harvard that used a gram or lower, it came with heart healthy benefits. So it just depends on, I've never seen a supplement or a drug that in mega doses was helpful. It's almost all the time harmful. But then again, at the sweet spot, the moderate dose, that's where the evidence lies, right?
I thought fish oil was for brain health. Is
Yeah,
it brain
there's
health or
something.
heart health or both?
Yeah, there's some. Well, it lowers triglycerides. That's why it's offered as a prescription now. So you can get a prescription purified fish oil if you go to your doctor and have super high triglycerides and you want to lower them, and your statins aren't doing that, or another option. It's a viable option to lower high triglycerides. The problem is if you take too much, where these are amounts you would never take. When you're taking 5 grams higher, in a couple trials in the past few years, there's been an increased risk of arrhythmias. And so now, if you look at the data, there's a concern of people megadosing for multiple reasons. Could there be a higher risk of arrhythmias? In some people, it causes a blood thinning effect when you get to those dosages. In some people, because they're two fatty acids, it can raise their bad cholesterol if they take too much of it. So it's kind of counterintuitive. If you take too much of fish oil, some people will have an increase in their bad cholesterol, even though their triglycerides will come down. So the big Harvard trial, which was called the VITAL trial, if you ever want to look at it, the VITAL trial used a gram or less. And the biggest benefit they found thus far, and that was the strongest study done, it was funded by your taxpayer dollars. The biggest find, I think, so far that surprised me, which I had to write on, was it seemed to lower the risk of autoimmune disease in people that had a history of autoimmune disease in the family. That surprised me. And so that if you look at the Harvard doctors working in the autoimmune disease clinic, the lupus clinics, the other ones, they told me, and they say in the medical journals, that they're starting to talk about that data in the families that have a high history of autoimmune disease diagnoses. That maybe
That's fascinating. Any insight as to why?
Well, we think, it's an immune modulator, fish oil. It doesn't let the immune system go too high or too low. So maybe it's that cruise control effect that it provides.
Amazing.
So I think I had to write in a major medical journal on this, and I said, in a lot of areas, fish oil has failed us. I called it fish oil flops. I thought that was cute. Flopping.
That is cute. Yeah.
But in this autoimmune category, in patients with a family history of autoimmune disease, I would certainly talk to my rheumatologist about it. That's where, when I teach on supplements, I want people to start thinking, do I fit in some of these categories? Triglycerides. Does this help my cognitive health? Autoimmune, And so that's kind of the latest on it.
That's very interesting what you said about how, the selection of supplements is something that could and should be personalized.
It
Why
should
not?
be personalized.
Yeah.
Every single supplement should be personalized, and then every 6 to 12 months, it should be reevaluated. And the reason you reevaluate...
People don't know this. Yeah.
Well, you and I used to talk about this ad nauseum, I think, when we were doing interviews, but it was the crux of, the text and all that. They should be individualized, and they should be reevaluated every 6 months, because nutrition has become a billion-trillion-dollar business, meaning that there is huge reward today for adding large amounts of nutrients back into food, fortifying. So you could wake up in 6 months and you are getting way too much calcium from your diet now because of what the industry is doing, so you no longer need the pill. Your questions, we should switch roles. Your timing is perfect. I went to Costco and bought almond milk for my wife. My wife wanted to try their almond milk, okay?
Oh, interesting.
Isn't that interesting?
Yeah.
Cheap, 30 calories. I mean, I don't mind these plant-based milks. Some of them are good. Some of them come with their catches. That's a whole other talk. So I decided, oh my gosh, I had to talk with the residents a couple weeks ago. So I brought this as a demo. I said, I have never seen this before. This is new. If I look in the nutrition facts, 1 cup of their almond milk. Are you ready for this? Now, keep in mind that 1 cup of milk, if you're lucky, contains about 300 milligrams of calcium. 1 cup of their almond milk is 600 milligrams of calcium.
How interesting. Is it fortified?
Exactly.
Yeah.
So now you do 1 or 2 cups of these, you're already at 1,200, and you've had nothing else the whole day.
Yeah.
There's no reason for you to take a calcium supplement. I would have never seen this 5 years ago.
Yeah. Interesting.
Never. So this is why your supplements need to be reevaluated.
Interesting. That is so interesting.
So I'm glad you find that, because I mean, this is the stuff that keeps me up at night, right? This has been my career. Centrum Silver, 10 years ago, I would have never found 1,000 IU of vitamin D in there. They had 400. Now they got 1,000. See, they're all upping their
They
game.
evolve.
They
They're all
evolve.
upping the game.
Now, I'm a skeptic and say it's for the business, but whatever. That's okay. It's for the business. They want to make more money. But in doing so, that means you have to reevaluate.
Amazing. I love this. We're gravitating back towards our old journalist interviewee roles.
I know, but I'm sucking up your time. But
no, it's great.
No, let's talk about creatine.
All right.
All right.
So
here's what I got.
creatine. Yeah.
I think just on the weightlifting demo and this creatine talk is enough for people to watch this video. I think so. And I'll tell you why, because this is so fascinating. I decided to make a few signs. People don't realize there's some great food sources of creatine. The foods that you like are high in creatine. So anything that comes animal-based, shellfish, anything that moves out there, food sources, fish, shellfish, mussels are a good source of creatine. Get it? Mussels.
Good.
I'll be here all week. Don't forget to tip your wait staff. All right. It's not in plants, but plants have the big three. And what's the big three? Your body makes creatine when it has 3 amino acids to utilize and manufacture. And I used to teach students by saying, remember that with the acronym GAME. G is for glycine, A is for arginine, and M is for methionine. And by the way, you mentioned methionine in your book, which there's not many good plant sources. You got to go animal for that. See, I read your book.
I'm impressed.
Thank you. So if you get those 3 amino acids from your diet, your liver, your pancreas, and your kidneys will make a decent amount of creatine. That's the important thing, which maybe is why vegans and vegetarians should be the ones really paying attention to creatine supplements, right? Because they're not getting meat sources and they're not getting a lot of those 3 amino acids in general. The creatine studies have been interesting. We're going to cover this a lot more at the fall meeting, but I'm just going to add this for you some more. It's just the biggest problems I've had with creatine supplementation is that it's one of the causes for the increase in a creatinine blood test. So even though it's a safe product, if someone's taking a bunch of creatine and they go see their doctor regularly to get blood tests of their kidney function, one of their measures of the kidney function, which you don't want too high, is called creatinine. It will raise the creatinine number, and that could scare your doctor. So everybody out there who's taking creatine, if you take a lot, 5, 10, especially 20 grams, it can increase your creatinine enough that it's not necessarily we're saying it's dangerous, but your doctor's going to go, what's going on here? This is a concerning increase. You could get an increase in your blood test from a large intake of cooked meats, fish, high intensity exercise. If you're a larger muscle mass, that could increase your creatinine and some medications. I don't want to waste your time here, but sometimes that blood test, your creatinine blood test, will come down when you stop the supplements, when you become a vegan, if you don't work out, and if you have liver disease. But the point of creatine is that it gets converted into this thing called creatinine, and your doctor measures that blood test. And if he or she doesn't know you're taking those supplements, you might scare that person.
Interesting. Yeah. Well, I will tell the story of creatine in my bodybuilding and how I talked with you about it. So when I first started, so this was before anyone was talking about creatine. I started working with this bodybuilding coach, and she said, I want you to start, when it became clear I was going to compete, she said, I want you to start taking creatine, a spoonful of creatine each day, about 5 milligrams you can put it in water, you can put it's flavorless, blah, blah, blah.
Yeah.
So I thought, ooh, this sounds kind of like, is this some weird thing? And I mentioned it to my mother, who said, don't take that.
Don't take
So then you and I happened to be talking for a story, and I said, I'm doing this, but I didn't know you well at that point. I said, can I ask you a question? I'm starting doing this bodybuilding thing, and creatine, I never heard of it. And you said to me, well, for one thing, you should know the research on it is chef's kiss, impeccable. It's not going to hurt you, but your body makes it anyway. So whether you get anything out of it, who knows? But you can take it with good confidence that it's been researched to the hilt. And, so So I've taken it. There's been periods when I've kind of forgotten to take it, but most when I remember to, I'll put a spoonful of it in my smoothie or in my workout water.
Yeah.
Whether it does anything though, I don't know. What's your opinion on it?
Well, if you ever go look, you can go look at any reputable website. They'll all repeat the same mantra. It's generally super safe. There's been
Right.
thousands of studies. Right now, if you have a really bad kidney function, you probably shouldn't be on it, which makes sense because, if you're going to make your kidneys work a little harder, even though someone's not going to study people and kidney failure on it, it's a politically correct thing and probably the right thing to say. If you have significant kidney disease, you got to be careful with this stuff, anything that makes your kidneys work over time. But generally the safety's been good. It's allowed in all the competitions, right? They don't ban it. Last I checked, they allow it for bodybuilding, for the Olympics. It's all good.
Oh, it's a widely accepted supplement.
Yeah, and so that's what they say in all the websites, which is true. And the other thing they say is it's for explosive movements, people who are weightlifters, people who are sprinters, people that need that kind of fast, explosive movement. And I see that, I understand that. The problem is that nobody's ever done a really good study of, okay, I'm getting plenty of it from the diet, and now I take a bunch of it. Is it going to give me people love to use all these little micro measurements. Is it going to make me feel, is there something clinically tangible? Is it going to be a dramatic change in my time, a dramatic change in my workout?
Right.
Well, that still has to be figured out. But I think it's a good product. Where I got interested in it, which you might find really fascinating, is they started to test it for people that have muscle wasting diseases. And there was a thought that it could slow the progression of Parkinson's disease. So the Michael J. Fox Foundation and the U.S. government published in 2015 the LS1 study. The LS1 study was published in JAMA, and it's one of our top journals.
Right.
This was done at 45 sites. It was a major clinical trial, and in the end, it didn't.
Interesting.
Some people will still tell you from that study that it helps some people with muscle wasting and have trouble with muscle and coordination, and maybe that's true. But it was my hope that trial was going to shed new wonderful light on creatine. So I don't lose any sleep by somebody taking it. I just want them to know what the catches are. And the catches are, it's pretty cheap, right? I think that's pretty.
Yeah.
The catches are most people are who can continue it are doing 2 to 5 grams. They don't have to do these super duper dosages. Some people want to do 20 grams, but that can take your creatinine up. And I'll tell you, just for today, for you, I thought you'd find this interesting. In my business, where everyone's freaking out about creatine in terms of excitement now.
Right.
Because it can cross the blood-brain barrier. Because the two sources that really use creatine a lot for energy are muscles and brain. So they did a pilot study at Kansas and just published it in Alzheimer's patients, and it seemed to help with cognition. It was a tiny study, but it's the first time someone's really looking at, hey, can this really help with my cognition and my memory? And they're saying it can, and it should go to a bigger clinical trial. So creatine has not lost its steam.
I heard about this Alzheimer's study. Yeah. So it was a small one.
It was very small. But here's where I find something so interesting. Everybody said it was it's as safe probably as placebo. So I did this for you because you and I spent so much time together on medical research. Look what increased. It didn't go to abnormal, but it jumped, the creatinine, the blood test.
Oh, interesting.
Right. So it increased from an average of 0.94 to 1.25. Let me just put that in perspective. Very small changes of 20% or 25%. Your doctor would go, whoa, what's that? So I found it interesting that the paper said it was perfectly safe. And I'm going, well, yeah, it was safe, but they should have really highlighted the fact that.
So what was the percent increase of the creatinine?
So, it was 0.94. The creatinine was 0.94 to 1.25. So it would be in that range.
Okay, it would be
a
in
big
the
enough
range.
jump, right? It would be a big enough jump that for women, for example, that have lower values, it would scare their doctor, I think.
Very interesting.
So, but that's.
Hey, can I ask you, what is your view on supplements in gummy form, which is something that's become increasingly popular?
Did we do that? I think we did that article.
We didn't actually. We didn't.
No, we did.
And I find the gummy form easier to take than a capsule. Sometimes the capsule can be big, but I've been told that they can be lesser quality when they're in gummy form. Is that right?
That's right. So I always like it when a gummy product has been subject to third-party quality control. NSF. In your game, there's a thing called NSF for sport. A lot of athletes use any product that says NSF on it. The collagen you and I used to talk about that said NSF, we would recommend that if you were going to take collagen. It just means it's been tested, it's reliable, what it says. USP is another reliable. UL. There's one in Canada called ISURA, ISURA. There's if you just look and you ask the company, you know, how do I know that what you're advertising is actually what's in it? If they can prove it, then it's a decent form. The biggest problem I had besides that was the sugar content. Some of the gummy vitamins.
Yeah.
What I said, I thought it was the Wall Street Journal. Oh, maybe it was Time. I said, people got mad when I said it. I said, it's like for your kids, it's like every day is Halloween. That's what I said.
That's great. I'm sure the reporter ate that up.
They did. And so what I always say is check the caloric content and the sugar content. But you know what? There are a lot of elderly people that they can only take small pills. They can only take gummies. So hey, whatever floats your boat as long as you do your homework.
Right.
Here's what I've seen in 2025 so far in weightlifting. And it's really a disappointing year for weightlifting, in my opinion. So I think you should have to defend this. This is all I found from the data in weightlifting. Let's see. I put it in here. I'm going to read you my list. It seems to help you live longer, seems to help you with balance, reduces your risk of falls, helps you with coordination, reduces your risk of fractures, improves your blood sugar, reduces insulin resistance, improves your overall muscle development and skeletal health. You use the word on the show, it helps keep you more, I think it was you in the book, maybe it increases your chance of self-sufficiency, being self-sufficient, taking care of yourself. It improves your cardiovascular health. It reduces pain because you're building up muscle around the joint. That's what it did for me, so I can run again. And it seems to help with mental health, including stress, depression, anxiety. And here's the one that when I talk about them in interviews, I'm always scared to talk about it. But before I do, also almost all the side effects of cancer treatment that we talk about on this channel is helped through weightlifting. Whether that's bone loss, falls, fractures, cognitive, energy, fatigue, metabolism, sexual, sleep. So that's the only thing that weightlifting does for you. So you should be disappointed. From A to Z, I just read you the list of what weightlifting does for you. And so I hope you're embarrassed. It doesn't really do that much.
I mean, if we could bottle the stuff as a supplement, right? So it is going to help you live a longer and stronger life. There is nothing better. Studies have been done on memory retention. One of my favorite studies, a deck of playing cards on a population that did weightlifting only. One group did weightlifting plus cardio. And then there was a control group. And when the subjects were asked to remember what was on the cards, it was the weightlifting only group, even more than the weightlifting plus cardio group that remembered the most, which I thought was fascinating. Depression, particularly among subjects who were very clinically depressed, weightlifting helped. There's just been countless. From my own experience, the reason I wrote the book was just this sample size of one. The impact that it had on my life was so profound. I was in my life having such a hard time. And when I started this journey of going to the gym in the afternoon, lifting weights, coming back, I would have this, it was like I was a brand new person. I would have this rush of ideas. I could hear it in my voice when I interviewed people. Confidence came out, more productive. I ended up getting a raise. I started wearing lipstick again. I created a dating profile. I met my future partner. It was just like my life completely changed due to strength training. And, particularly for men and women, I think, but particularly for women, I think we've been conditioned to gravitate towards becoming less, weight loss, exercise as a way of reducing ourselves. And the wonderful thing about, my weightlifting experience was it was all about the moreness of muscle, right? Building and fueling yourself to optimize performance, to make more of yourself was it was so delicious to me, and and different, and particularly for bone. Talking about calcium for bone, muscle is the ultimate protector. It's the cushion of bone, and it is on a cellular level something strength training helps build bone. So there's nothing better you can do, especially for women, who are more susceptible to osteoporosis, osteopenia. Strength training is something that will help you, in your quality of life. Bring those bags of groceries in, help you lift a grandchild. I think I read somewhere that falls are the #1 reason that elderly people end up in hospitals. So anything you can do to help protect bone. So, whether it's for mental benefits or longevity benefits, strength training is the best thing you can do for yourself. So,
yeah, well put. The other ones I pulled for today's was there was a huge review of randomized control trials in the British Medical Journal just recently. There was 8 studies, and it suggests exercise, including weightlifting, helps some people with long COVID. I thought that was interesting. I thought you'd find this interesting.
You remember I had long COVID.
Oh, you did?
Yeah. And it went away, and maybe it was due to, there you go. Yeah.
I mean, it's a pretty solid review of all the data. The one I told you I don't like to talk about because it's a weird space to go into. You get nervous on the internet talking about it, but you got to talk about it. Is first of all, there's a higher rate for whatever reason. I have theories. There's a higher rate of suicide in female physicians. So that's JAMA
Wow.
JAMA psychiatry. So what does that mean? It's just, I think, not just in females, but in adolescents, you see this high rate of suicidal ideation. And I always kind of thought, oh, it's a tough world to live in. I understand it's tough out there. It's like medicine and all these professions. Being a female, I understand that. But then I started to look, where are the solutions? Could they lie in some of these places? And then I looked at every meta-analysis on suicidal ideation behaviors and a culmination of all the data in all the major journals from 23 to 25, and among adolescents and among adults, and they all came to the same conclusion. This one identified 17 randomized controlled trials. And, so these are a large number of controlled trials, and they all come with the same conclusion, that exercise either reduced suicide attempts and or suicidal ideation. People who did resistance training and aerobic training. And I'm going, look, nobody's trying to suggest that this is the solution to an epidemic problem, but it's kind of like COVID. Why are we talking? I mean, I don't mind talking about the vaccines and all these things, but why didn't we talk about exercise as a possible solution? Why aren't we talking about suicidal ideation and exercise as a possible way to mitigate it in the higher risk people? And it goes back to the book you mentioned. I think in the mental health category, weightlifting doesn't get its due in the uncomfortable to talk about subjects.
Oh, I love that so much. Well, there's, it goes hand in hand with the vast, mental health benefits of weightlifting.
Exactly.
And the research is there. Talking about it in terms of suicide mitigation prevention, I think is a great opportunity. And I hope,
Exactly.
I hope somebody hears this. And
well, I think people. Well, I'm not trying to be too strange about it, but I think this is the power of this stuff. You reach people that sometimes you could consider non-reachable. It's what speaks
So
to them.
true.
'Cause I can tell you, when I played sport in college and I played in high school my whole life, man, this is what kept me out of the dark spaces. Well, that and my
Yeah.
faith, but I just,
And got me out of the dark spaces too.
Yeah, and whenever
Yeah.
I still go back there in this day and age, and we all have reasons to go back there. This morning when I went for my run and my lift, it just gets me the hell out of there. There's no better way to say it,
Well, we spend a lot of time up here, in our minds and on our screens. And the wonderful thing about my strength training is it gets me into my body, gets me out of my head. And I think it's really, physical activity in any way, shape, or form is so important for that reason. We get disconnected, in this
Absolutely.
space. We get disconnected from ourselves in that way.
My SPBs are this. Before you start this demo and how we're going to do this for the audience, and let me know if I missed something. By the way, I have all these funny things here. I had tuna fish yesterday, and I looked, because of you, I looked up the protein amount, and it was 32 grams
15?
on this can I ate. I'm like, I just had 32 grams on
Wow.
a piece of fish. Anyway,
It
you
must
got
have been a large can of tuna fish, because
It was-
oh,
it
well, I
was-
guess it was about, I would have guessed 20 grams. Was it a standard can of tuna or a little bit larger?
It was a little bit larger,
Yeah.
exactly. But
Yeah.
you know, I still, because some of them at some of these cheap places, whether it's Costco or these places, they're selling like slightly larger can. And I just thought, wait, I'm going to talk to Ann. I wonder how much protein I'm getting here. I'm going 30 some grams. This is pretty impressive.
You know, I actually love, they sell them in pouches now.
Yes.
And I think they are so fantastic. Some of these flavored pouches of tuna fish, it's just I keep them in my purse or in the car. It's just a
Yeah.
really quick way to get, and sometimes they come with a little fork in the
Yeah,
pouch.
that's great.
Highly recommend. Yeah.
That's a really smart. That's exactly. I mean, some of these changes are really brilliant. SBP, before we talk about the demo, do you have anything to say, or do you want to show anything about stretching? Do you stretch before lifting, or do you go right into it?
I do. You know, I do some feel good stretches. My little weird little habit is at my gym, they have a sauna, which right now it's summer, it's like kind of, but especially in the colder months, it's like my great little treat to myself to
Wow.
go into that hot sauna.
Yeah.
And I just, you know, I put on some meditative music in my headphones and I do a series of stretches, and really I don't overthink it. It's whatever feels good and gets my old bones moving. Sometimes there's another woman in there, or sometimes people are like, can I join you? I'll say sure, and I'll start
Yeah.
doing stretches. But you know, 5 to 8 minutes of stretches, and I also do like a little bit of warm up. So I'll pick any of those cardio machines, maybe a step mill or whatever, do 8 minutes of just to kind of get the heart moving. And then I go into my lifts.
Nice.
Yeah.
So that's stretching before lifting. The other thing I hear a lot about is breathing. You can show us. I mean, this is all I know. You're not supposed to be, correct me if I'm wrong, but you're not supposed to be holding your breath the whole time, because that creates too much
Yes.
internal pressure. Now you're looking at the increased risk of injuries internally.
Yes.
So the other three things are stretching, breathing, and posture. You can show us the posture if you want during the workout, but do you have anything to say about breathing? Because I go to these gyms and some of these guys are lifting these huge weights and they're just holding their breath the whole time, and they're making this noise, and I'm going, that can't be good.
Yeah, I think, you know, especially for people who are starting, they feel like they're really focused on the lift at hand and they forget to breathe. Just make sure to keep the breath moving. You know, don't hold your breath. Keep
Thank
it moving throughout the exercises. I'm glad you brought that up.
No, that's an important point, not to hold your breath and breathe through the exercise. Okay. Did I miss asking about something? I had a whole other list, but that would take another 3 hours. So is there anything you want to say about the book or anything else before we try the demo? Because you could think about it for a sec, because this is
I'm gonna grab, I'm looking at the weight from across the table. The only other, what do you got there?
I said resistance exercise, Demo City with AMC as the mayor. Moyad is her favorite student. This is the first time ever attempted in the history of our organization. Nobody's ever during a conference tried to show us how to lift some basic weights.
I love that. I'm so honored. I was going to say one more thing, Mark,
Yes.
which is there's a misconception. If you're going to go to a gym, for instance, and start lifting weights, is to, you know, do your cardio, a big cardio exercise first. You know, if you want to warm up 3 to 5 minutes of cardio, 5 to 8 minutes, it's fine. But if you're combining big cardio, you know, 30 minutes on the Stairmaster or whatever with your weightlifting, do it after. Expend your big energy in your lifting. That's where you're going to get you want to save the big energy to get the most out of your lifting sessions, and then the cardio can come after. Don't waste your energy on the cardio first and then do the lifts. You'll get so much more out of your session by doing the lifting first. Okay.
And what do you say to the person that says, look, I don't have that much time. I just want to do my lifting, then my cardio. a couple days a week. I mean, does it really matter? I hear from trainers all the time that, no, you got to take 2 or 3 days off during the week. I mean, what's your stance, your advice to people on who just want to get their cardio and weightlifting in? Do you recommend 2 or 3 times a week? Do you got to?
Yeah, 3 times a week is great to aim for, and you don't have to do like an hour-long session in the gym. Or what we're going to talk about is 30 minutes or less. I like to think in terms of threes. So pick 3 exercises, 3 sets of 10 repetitions, perform 3 times a week, 30 minutes or less, and you can get a lot done. And if you're going to ask me pick 3, how can I think about which 3 exercise to pick?
Yeah.
Think about a push exercise. So that'll work your chest, a pull exercise for your back muscles, and then a leg exercise. So
getting upper and lower body on the same session. Yeah, I like that. Okay.
Yeah.
A couple times a week, like 3 times a week, and 30 minutes or less. And you're going to show us. Are you going to show us those kind of exercises now?
Yeah, let's do it.
Let's do it.
Are you ready? If you're at home,
I took my
you don't
jacket
even...
off. I was wondering why my face was beet red, and I'm going, well, first it was when you embarrassed me at the beginning. And second all, because I had a jacket on. All right, I'm ready if you're ready, but I'm going to watch and figure out what the heck you're doing.
So for our push exercise, and you can do this from home, I have, these are 5-pound dumbbells, but really if you don't have dumbbells around, look in your kitchen cupboard. This is a can of Progresso chicken noodle soup. I measured as about 1.5 pounds. This is a jar of spaghetti sauce, which I measured at 2 pounds. You can grab anything that's a weight. This is a little bit heavier at a 5-pound weight, but whatever you've got. So this is an overhead press. So we're going to do 10 of these. And this is great for your upper back, your shoulders, especially your bicep. And you can do one arm at a time, or you can do both at the same time.
Do you do them sitting or standing, or does it matter?
This is done seated. Make sure your feet are planted on the ground.
It is. Okay.
Yeah.
I only have one and you have 2.
Nice and high. And that's it. Aim for 10 of those.
Okay.
And I feel better already. I don't know about you. It feels great.
You do 10 in the chair. Oh, okay. That's
awesome.
awesome.
You can do it standing also.
But I like the chair. Okay.
Yeah, you can totally do it seated in a chair, actually.
Okay. So that's called an overhead. Now,
so
remember, for everybody watching, these are going to be posted on the channel.
Now, for our pull exercise, I've got a resistance band like this. I've got different variations all over the house. They're super cheap to buy online, there's this version too. Or if you don't have one, you can even use a towel. Okay. I am going to loop this over my foot, or both feet. And I don't know if you can see me, but I'm going to pull back like this.
You're doing that with your foot at the other end of it.
Exactly.
So you're just pulling like that.
And I'm just pulling. And I'm seated in the exact same spot. And I've just now gotten 2 awesome exercises in that will help improve my strength. Okay.
Wow. Okay. So when you want to do a pull with the dumbbells, like what do you call these things? Hand weights. I don't know, whatever you call it.
Yeah, you can actually, if you want to use a hand weight, and you can do a seated row. So now I'm going to use the same chair. And I'm raising the dumbbell to my armpit. And I've got my left, I'm leaned over, I've got my left leg and my left arm anchored down on this bench. And I'm rowing like this, and do the same with the other arm.
Switch sides. I see.
Yep.
So that's the pull portion.
That's the pull.
So that's so we did the push, then we did the pull, and that was okay. And then the last but not least, because you have a couple exercises within those islands. So one island is the push. You got a bunch of there. Then you got a couple exercises with the pull. And now the last island is legs and core.
Yeah, so we're gonna do a leg exercise, and here I can, you don't even actually need, I'm gonna do a leg extension. And this is a kicking motion. I'm seated, and I'm just slowly kicking up my leg. And this is working my quadricep leg extension. Now, if you're at the gym, you can do this with a machine.
Right.
But you don't need to. You don't need any weight at all. If you want to put a weight, I'm going to squeeze the dumbbell in between my 2 feet and try to raise. That makes it more challenging.
That makes it really hard.
Yeah.
So that's got to be a lightweight.
It's a lightweight. Yeah.
So you're saying you put that by your ankles?
Yeah, you squeeze that weight in between your.
And then you try to lift both of those. And then what if you're not using
You can even try it with the band, doing the leg extension with it gives me a little bit of resistance.
So you're putting the band below the foot and then trying to lift your leg up.
Exactly.
You're still doing this from a seated position,
Still from the seated position, yeah. Those are 3 exercises. Let's not complicate things.
Yeah.
But you can do these in a circuit and then start right back from that first one. And, maybe that gets done in 10, 15 minutes. And you haven't left the kitchen, you haven't left the house, and you've done something incredible for yourself. And I guarantee, I feel better already. I don't know about you, but you will feel so much better in terms of your mental and, spiritual self.
Well, part of the reason too is you're talking to me. It's like a big deal.
Let's be honest. Right?
So, okay, so can I ask you one more thing then?
Yeah.
So can you just repeat? Because I think everybody watching this should invest not only in soup cans, but resistance bands, but they should go out. They sell these at Target now. They sell these
Marshalls, TJ Maxx. Yeah.
TJ Maxx. Can you one more time through the push, pull, and legs and core with just if I've got one of these?
Yep.
I think a lot of people in our audience actually owns one of these things.
Yeah, I think most people have them at home.
Yeah. So the push again is
the push is
both arms.
Yeah.
So you do single and then you do double, or you just go from
either or. You can do, I think, you can do one at a time, or you can do both at the same time. Doesn't make a difference.
And then what do you recommend? Let's say you're doing this and after a few weeks, this just becomes really easy. Do you recommend going up a pound or 2, or do you recommend?
Exactly.
Okay.
Yeah. Yeah. The name of the game is to push your muscles to fatigue.
Okay.
And by fatigue, I like to think of it as, I think we know what fatiguing your muscles feels like. It doesn't have to feel like hell on earth, but it should feel like, oof, I'm getting, on a scale from 1 to 10, it should feel like you're hitting an 8 or a 9.
Okay.
So if you're not getting that from 10 repetitions, keep going.
Go to 20.
Shoot for 20 until you're feeling like you're hitting that 8 or 9 is what you want to aim for.
That makes sense. And then when the chair where you had your knee down and you were pulling up, that was the pull.
It's called a row. Yeah.
It's called a row. And then the last island, legs and core. So you recommend getting a really low weight of this and then putting it between your ankles or your legs and then lifting.
Yep.
And when you're done with 1 rep of 10, is that enough several times a week? Or do you recommend taking a couple minutes and then doing another rep of 10 with the same weight, or is 1 enough?
Ultimately, you should be doing 3 sets of 10 repetitions for each of those exercises.
Oh, okay. So you want 3 reps, 3
sets of 10 repetitions.
With how much break in between?
No, well, you take a little breather, but the idea with the circuit is to keep it moving. Yeah.
That's where you start to feel the fatigue.
Yeah. Yeah.
So you're saying go in from push to pull to legs and core all in one motion.
Exactly. So you do the 1 set of that first exercise, then move into the other set of the second exercise, then the third set of and then after you've completed those 3 sets, Then you take a break. Maybe you take a 20-second breather, then start again with the first exercise.
So I'm doing push, pull, legs, core.
Exactly.
So you're saying I do a set, push, pull, legs, core, and repeat.
Yeah.
And then repeat again, and I'm done for the day.
Yeah.
Okay. So that's what takes the time. And you find that holds muscle development, strength, as well as muscle size done if you do it 3 times a week.
3 times a week, yeah.
Can it just be really?
Yeah.
I don't look, I'm talking about from a science standpoint. Everything what you're saying is exactly right, but I've never thought about even just doing it sitting on my gluteus maximus or just in these just using this and I'm good.
Hey, I mean, if it feels too easy,
Yeah.
do more,
Yeah.
But the idea is to it shouldn't feel like a chore, right? It should bring some joy to your life. Not everything has to make yourself miserable to work. Like make it something you look forward to. And just because you're hitting, that muscle fatigue, it doesn't mean it has to be miserable. I associate it as like a kind of a good feeling,
Yeah. Well, what if I just want to do this Friday, Saturday, and Sunday? Those are my 3 days because I'm too busy Monday through Thursday.
Great. Yeah, you can do that.
So it's really about just putting the time in.
Absolutely. Yeah. Ideally, I would give a space of a day in between.
Okay.
Because then you're letting your muscles rest. In order for muscle, quote unquote, hypertrophy to take place, for muscles to get bigger, they need a period of rest. But you could one way around that is you could work one set of muscle groups on your Friday, then make the Saturday, your leg day, and then make Sunday, one of your push-pull days.
Yeah.
So you're giving the one muscle group a rest.
I see. I like that breakdown that you're going to do a push exercise, you're going to do a pull exercise, and a leg and core because that's covering you from head to toe.
Mm-hmm.
That's covering all your major muscle groups, right? I mean, the ones that don't get much attention: back, front, bicep, tricep, quads, hamstrings. That's cool. So that's the one.
And actually, I think it's in chapter 7 of my book. I have to check, but it's the chapter called Building Your Routine. And it kind of takes you through how you can set up your week, your days of the week with those movements. And then, there's a section on ones you can do with just body weight even,
I found that to be the chapter I read twice. And that's exactly building your routine. You have my top 10 body weight strength movements. And it goes through push-ups, squats, lunges, and explains what they are: planks, frog pumps, donkey kicks, monster walks, dead bugs. That was the one I flagged. I flagged my top 10 body weight strength movements, and then I underlined all those. And then the equipment that you can use for those. So from all different types of weights, to the straps, to Velcro weights. So yeah, that's funny that you say that part, because that was the part I flagged with one of my cards.
I spoke with a CEO of a menopause company, really wonderful woman. And she told me that she's very busy, right? Starting a company and running it. She keeps these sets of dumbbells in different corners of her house, so that when, she walks by, she's reminded, okay, I'm going to do 3 sets of 10 of something right now.
Yeah.
And so she think of it as like a workout snack almost. And I thought that was so genius, you could do that with a kettlebell. I don't know if you know what that is, but that's another great kind of weight to have. You can tuck these things in different corners of your house. When you're bringing laundry from room to room, for instance, you see your kettlebell or your dumbbells, you can do one of your push-pull exercises or any one of those exercises from the chapter.
I like that a lot. In fact, man, we covered a lot of stuff here. I don't want to rob the book of its credibility here, but we didn't touch upon so many of the different exercises, but that's what people can purchase the book for. And remember what I said about your book. I said it's an inspiration for the ages and for all ages. So with that in mind, when are you going to let your daughter start lifting?
So I have a little basement set up. I have, an incline bench, a squat rack, a barbell, so when you start building up from just your dumbbells, you can get a few more toys and stick them in the basement or garage or what have you.
Yeah.
And, the girls, it's great. They've seen my crazy bodybuilding journey and they're so proud of mom, and I love that they've seen their mom develop into someone strong. And once in a while, I'm not going to say all the time, but once in a while they'll come down and they'll start imitating me with some movements. And it doesn't last very long, but I think it's great that they don't think anything of it and want to get involved a little bit. Hopefully it'll be more as they get older, but the oldest one is 14 now and the little one is 10.
Yeah, that's a good time, right? A good time to at least be exposed
Yeah.
to it. Not necessarily start it, but be exposed.
Yeah.
Wow. Is there anything you wanted me to ask you today that I didn't cover? I mean, I had a ton of stuff, but that'll be for next time.
I sort of felt like we went right back to old times. No, that was great.
The only time I haven't worn a suit, I got my workout top, my sweatpants. Thank God I didn't have to wear a suit and tie.
I owe you a little video or something on
Yes.
the smoothie.
Yes. So
Okay.
what we
Do you want me to do that as a video for you?
You could do it as a video would be great. I could do it as a video with a write-up, whatever's
okay.
easiest for you. So what we agreed on today is your go-to smoothie, which I found to be so fascinating, so nutritious, so high protein. Then you gave us the little quick how to use the push-pull and your back, work on your back, all those areas. And then there's another thing that I know, Katie Kirk, there's a write-up of push-pull and a video. We're going to try to access that. That's yours. So
Yeah.
what I want to make sure the audience know, it wasn't just about me and AMC just catching up on old times. We made sure that all the little things that she's developing right now, as the book's getting attention, is also going to be accessible for us. And you agreed to that, thank goodness. So yes, we want all of that.
Okay, fantastic.
Yes, and I do want to say, okay, how can I not sound like an Oscar speech now and cheesy? You and I have had a great run. I mean, I really appreciate what you do. I hope it continues. Anything I can do to help get this word out that people need to incorporate resistance activity in their life to feel stronger mentally and physically, and for me, spiritually. And I appreciate you taking a chance and coming on here, because this is not our typical guest, but these are the kind of guests that we need more of to reach more people and to excite more people about lifestyle.
Yeah.
So
yeah,
that's my way of saying thanks for being you.
Oh, thanks. Yeah, this is the kind of message that will improve people's lives and improve their health. And, I think as a population, we are so focused on taking care of others, first. And we forget that, taking care of yourself is like the oxygen mask that you have to put on yourself in order to be able to take care of others. And just, it doesn't have to be hours a day, just 30 minutes or less. Just do something so good for yourself so that you can be strong, be well taken care of, and ultimately be able to take care of someone else is so important.
Yeah. And then the last thing I would say, since we're asking for all this free stuff from you, which makes me happy. I love free stuff. It's my favorite 4-letter word. The other thing I think, which was really cool, which I saw on the CBS show, is I think when you send the recipe and the video and all that people can do at home, you should send a couple of pictures from the competition that I saw on CBS. I mean, those are mind-blowing that you are, because you're doing this on your own. I know you work with people, but you were this reporter who developed this body, this muscular body, this strength, and the photos are really sort of shocking, the development, right? I mean,
yeah.
I think it's easy for all of us to take it for granted, but if you
it was such a different world, it was like
world.
I was so immersed in the world of newspapering and kind of deadlines and interviews and Ann Taylor pantsuits, and I kind of ended up in this crazy world of fake tans and big muscles and big hair and fake nails and posing on a stage. I mean, it was so unlike me,
Right.
but I met people I wouldn't have met before. It's, the parking lots of these competitions are a crazy mix of, red state and blue state bumper stickers and everyone in between. And so, great fun, and I still enjoy competing, and I enjoy kind of exploring, making more of myself in every way. So it's been a fun ride.
Yeah, so if you don't mind, I mean, it's not easy being a pro bodybuilder. I mean, dear Lord. So you should send, because we're kind of talking here, but people can see. I mean, I could even see in the CPS morning show your biceps. I was like, what? Where did those come from?
Yeah,
And
yeah.
so it makes sense to me before you leave that, you're doing all this investigative reporting and you're doing all these health topics, and you realize, wait a second, maybe I could be the story here. I've got enough knowledge and enough background that I can be the story. I mean, because you're always reporting for other people and on their stuff. So I
Yeah.
always found that transition to be really interesting. So even with Alex, who runs our PCRI, as we're moving her into investigative reporting. So she's kind of coming that direction because today, a lot of these topics, if you spend the time and you have an objective mind, you can do great things. And I just find the transition, what you did, made so much sense to me, even though you think it's weird,
No, yeah, no, it's relatable. And I
Yeah.
think, as people, we all hit hard times in our lives, right? And life is not easy. We face death, we face illness, we face divorce, and getting yourself out of it, and transitioning like a butterfly into something new is a story I think we can all kind of relate to. And, if you're there and in the middle of it, I just want people to know that, it's not the end of the story. There's always something on the other side, and don't despair, and grab a set of weights and get out of your mind and get into your body. And I think you will be surprised at what it can do for you as it did for me.
Of course, I got so caught up in talking with you, I forgot everybody gets a gift. We forgot to give you your gift.
Oh,
So what do you give the person that has everything? You give them a puppy? No, I think she's got a dog. I don't know. New car? It's not in our budget. We figured it out. So actually a bunch of us talked like, what would be the ultimate gift that she would never forget that she did this show? And we were looking online, and whammo, this goes so well with the demo that you just did. I guarantee you no one's ever given you this. Can you show Peter the present that's going to be sent to her house? It's called Heavy. It's the new coffee cup that weighs 5 pounds. So
that
you see that
hilarious.
Isn't that incredible? And they're on back order right now. And they have one that weighs 22 and one that weighs 5. And we got you the 5-pounder. It's also a good gag gift. It's got a regular handle like you would have in a dumbbell. And that one's 5 pounds. The company's called Heavy. I had never heard of it before. And that's going to be your coffee cup. And it will remind everyone that you lift weights and you're a pro bodybuilder.
That is the most hysterical thing I have ever seen. They really made it look like, one of those one of those gadgets in the gym. And they handle, it's unbelievable.
Exactly. And the reviews are through the roof. And I thought, we've got to get that for her. So that's going to be sent to your home address.
I mean, I think we need to, at some point, retake the little video I did with you with one of those coffee cups. I mean,
yes.
That's maybe next year.
When you get it and put coffee in it, then just do a quick video and send it to us and we'll put it on the site.
It's a deal.
I mean,
that's great.
Anyway, that's like, I know, sorry, it's not a puppy, but man, I thought you'd love that.
Fantastic.
No one's going to steal it. It's too heavy if they take it away.
Exactly.
What a brilliant invention. So anyway, thank you again.
Well,
There's your
thank
gift.
you. That's just adorable. Thank you.
Thank you, Ms. Chaker, and thank you, Dr. Moyad. We really appreciate it. If you would like to learn more about Anne-Marie's book, which just came out this week, Lift, you can go ahead and look in the comment section and also on our exhibit hall. So you can go ahead and visit the exhibit hall for more information, and we just appreciate that she was here today. So without further ado, we're going to have Dr. Mark Moyad and Dr. Mark Scholz covering our extended Q&A. And this is great because they're going to be talking about and reviewing the content that was presented today. But they're also going to be talking about GLP-1s. They're going to be talking about ivermectin. They're going to be talking about a wealth of questions that we get on our website and in our comment section all the time. Our job here at PCRI is to provide you with education and answers to your questions. And this is a really great way to do that. So thank you, Dr. Mark Scholz, and thank you, Dr. Moyad. Without further ado, here's our Q&A.
Here we go. My favorite part, the end of the conference where I get to rest. Take it easy and let Dr. Scholz talk for the most part, and I will interrupt him for the most part. No, okay, I'm semi-kidding. This is the end of the conference, the famous Q&A, and I'm excited to see you. Your background is prettier than mine, but I'm not allowed to open the curtain and show you my trees, so you have that competitive advantage.
It's hard to show you up living out there in paradise, but temporarily we'll win that particular competition.
I went running the other day and there was a coyote and a bear. Sounds like a joke, right? But that's my average day. Coyotes, bears, rabbits, baby fawns.
Is that how you run more quickly when you see bears out there?
I do. I run more quickly. I also run more quickly when the PCRI asked me to moderate another meeting. I kind of try to run and then you catch me. So
you have put in the time, Mark. This one time I'll commiserate with you. You've really done a nice job. And it was a pleasure reviewing the talks in preparation for our time together. I was very impressed. I wonder if I have anything to add. I mean, the level of expertise that was presented was pretty amazing. So,
okay.
So we'll touch
you
on
have a lot to add. You have a lot to add.
Yeah, I have a few questions. I have a few questions. Yeah. So, should we just jump right into it? I think I don't have a lot of expertise in the area of sleep, but as you know, as a doctor, we write prescriptions sometimes to help people sleep. And Dr. Rice pointed out that even though those things do put you out, that the quality of sleep that ensues is not always optimal.
Yeah.
And he mentioned a couple of medicines, though, that I wasn't familiar with. And as a physician, I thought I should be, as you're probably familiar with them. And I thought maybe you could just expound a little bit. One, we'll just take them individually. The first one was Roserum. And so this is a sleep aid of some sort, but apparently it's different than the usual like Valiums and Ambients that are so popular out there. Is there pros or cons compared to those other medications?
Well, can I tell you a story about Roserum?
Sure.
I got to tell you a story about Roserum. Roserum came out in early 2000 as a prescription drug, and it's a melatonin agonist. So it's very much acts like melatonin, but acts on the receptors. There's a couple different receptors for melatonin in the brain. And so it generally comes in a dose, I think it's 8 milligrams is the standard dose. But anyway, this came out as a prescription melatonin, great quality control, a lot of hype. And for the past 20 years, I don't think I've seen a single commercial on TV. Yet a lot of people really like it. So think about it. What's the criticism about over-the-counter melatonin? Quality control. A number of studies shown that depending on the company, you may get a lot more or a lot less than what's advertised in the label. You know, you're dealing with a hormone. So melatonin's a hormone. So you'd think that when this prescription came out, it would get a lot more attention. So here's the background story. I had a friend who was, this is a sad story, but it shows you why education's important. He was in hospice. And I just went to go see him, and I was talking to the nurse and doctor there, and I was asking him about all the different sleep aids they give, this and that, and he was having trouble sleeping. And I don't know why, I just threw out, I said, well, you know, theoretically, you could always use Roserum. And they said, what's that? And I really thought that, I almost thought they were kidding. And I sat there and I explained how this prescription drug form of melatonin, Remeltion is it called, and has been out there for 20 years, and it's good quality control. It's a melatonin agonist, and they tried it, and they got some success with it. I mean, nothing is a home run, but it was at that moment I thought, well, wait a second. everybody needs education. The fact that even people who work in such an important area of sleep and getting good rest during illness, for example, I just thought that they should know about it. And then they came back and said, thank you. And then since then, I've been talking to more people about it. So I think Rosarum should be reserved for those people that are either not getting the kick they want or not getting the benefit they want from melatonin, or they're nervous about the melatonin they're buying is not quality control. They're not sure they're getting enough. And to add to that story, I thought you would find this really fascinating. I also told the story of when I went to Italy, and a friend of mine, a doctor, said, if you're having trouble sleeping, you can take one of our biggest selling drugs in Europe, which is Circadin. And so Circadin is here. This is the advertisement on the website as of a few days ago. Circadin can help with sleep problems, approved for primary insomnia. And I thought, wow, this has really impressive data. It's got all these clinical trials, right? So when I was just about to say yes to it, if you look on the label, it says Circadin right here is melatonin prolonged release 2 milligrams. So in Europe, Asia, and other places, melatonin's primary way of getting it is a prolonged release, and it's a prescription. So I always find it funny when people tell me over-the-counter stuff is separate from prescriptions, when a lot of times it's perception versus reality. So when people go to Europe, they say, should I ask for Circadin? Sure, why not? This is 2 milligrams. But what you're learning about all of this is well controlled, it's good quality control, and the dosages aren't really high. What happens in cancer right now is there's a lot of clinical trials that they're trying to give 15, 20 milligrams and higher of melatonin because they think it might have an anti-cancer effect. And I can explain that at some point why they think that. But the problem you run into is like the problem with all these prescriptions. If you take them too long, the next day you can run into daytime fatigue. You're just not on your game.
Well, that being said, Mark, you probably have some experience with this. I haven't used, I have patients who take melatonin, and some of them feel it benefits. Do you have like a starting dose? If someone asks you, say, hey, I'm tired of not being able to get to sleep. I don't want to take a prescription drug because we can get melatonin over the counter here. Do you put them on 1 milligram, 2 milligrams, a half a milligram? Do you have them escalate the dose over time? Do you tell them to cut back if you're drowsy the next day? How do you handle the dosing?
Well, how I handle the dosing is, remember, I'm a doctor's doctor, meaning that the doctors all call me and ask me what they should do for their patients because they can't answer it, because that's my primary teaching job as of now. So I'm handling mostly doctors who have trouble with patients, like when you and I talk about certain things, or Lee Rice calls me up all the time and says, hey, I'm having trouble here. And then I'll mention some stuff. What I mentioned briefly to Dr. Rice was very fast, but it's highly significant as how it should be dosed, I think, by doctors when they talk about melatonin. Unfortunately, it's a very unpopular answer. So they decided to look at in the bloodstream, when you make an adequate amount of melatonin from your pineal gland, from the brain, when you make it at night and you make an adequate amount, what's that equivalent to? How can you get there in terms of dosing, right? So they've done those dosing studies, and you'd think that the number was 4, 5, and 6. The biggest selling dosages, I would argue, are 3 and 5 milligrams. All right. So they looked at this study several times, and they found out that about 0.5 to 1 milligram, like this is a Walgreens 1 milligram dissolvable. I don't work with Walgreens. It's just that Walgreens now has applied quality control to their supplements, just like CVS has. This is 1 milligram. I would bet you, I don't know the answer, but I bet you at Walgreens, this is one of the least selling products on the shelf, because people see 1 milligram and think, that's just
I'm not getting my money's worth. I should have 10 milligrams.
Right, and it should have 10 other ingredients in here that have never been tested with melatonin, right? And then you want to pay 10 times more. That's an interesting trick. But truthfully, that's the dosage that's physiologic that should be started on. Second of all, it's nothing that has ever been pushed for consecutively. So you try it every once in a while. The idea of taking this every single day for weeks upon weeks, there's not only the question of tolerance, there's also, or tachyphylaxis, there's the question of you start to really experience those side effects. So the idea is single digit. It's 1 milligram, maybe going to 2. That's the approved concentration in Europe. and then going to 3. For things like jet lag, pilots use 4 and 5, right?
Yeah.
But there was an old study long ago where people were using super high dosages in cancer patients, including prostate cancer, and they were arguing that it was giving them a boost of an effect with their conventional drug. Now, I'll tell you why I think that was possible. I don't know if I believe it's to be true. When you start going into these really high dosages, not only do you experience more daytime fatigue, sometimes you experience more LH suppression, a little bit more. So theoretically, this is not a constant, but in a minority of trials, some people who have taken massive dosages have seen a little drop in their testosterone. So you wonder, in the old days when they used to give LHRH, they still give LHRH drugs, and they couldn't get down the testosterone below 50 or 20, maybe it gave them that extra 5 or 10 points, not much. But I like the story of melatonin for many reasons. There's great over-the-counter quality. There's a prescription Rosarum, which you bring up, which I really, really believe has not been utilized, that with a coupon and talking to the pharmacist, you can get for a cheaper price. And I think these should be exercised. But remember, what I told Dr. Rice is that none of this stuff has exceeded the efficacy of cognitive behavioral therapy for insomnia. None of it. And so if you look at all the sleep foundations, national sleep foundations, all the different physician groups, the first recommendation for sleep disorder is CBT, cognitive behavioral therapy for insomnia. And you can do it online with an expert, or you can do it in person with a sleep expert. But it is an underutilized option to teach you how to think differently when it comes to sleep, and what to do differently when it comes to sleep. So,
or maybe learn how to stop thinking about sleep. That's that seems to be the exercise. And the patients that have gone through that type of therapy, and I've seen amazing success pursuing that. These people feel released from their perseveration, their thoughts, and they discover techniques to be able to just let their brain shut down, and that allows them to sleep. Briefly touch upon the other medicine.
Balsamra. Yeah, these are every couple of years, I don't say I'm an expert in this, but every couple of years somebody comes in and says, oh, there's a new pathway to successful sleep. So essentially there's this neurotransmitter they discovered in the brain called orexin, O-R-E-X-I-N. And what it does, its primary purpose in the brain is to promote wakefulness, to keep you awake. So what they did is they developed a drug that blocks that essentially receptor, or that neurotransmitter. So it's a different pathway. People like it. But you remember the days of Ambien when it came out. Oh, it's the greatest thing since sliced bread. Then Lunesta. Oh, it's the greatest thing since sliced bread. I mean, these are all good options. A sleep expert, a doctor that works in them is better than anybody I know. But it's another pathway to success that you can ask about. It just doesn't get a lot of attention. Part of the reason that these sleep medicines are not getting the attention they did 10 years ago, you remember you turn on the TV and every other commercial was like testosterone replacement, right? Now it's testosterone replacement, but every other commercial was a sleep med. I don't know if you remember. I remember those.
Sure, yeah.
Part of the reason that's gone away is generics, and part of the reason it's gone away is they have undergone a heck of a lot of scrutiny. Scrutiny for dependence, scrutiny overall for chronic use, it's just being pushed way too much, and scrutiny that scared the public over what's called, I mentioned the word to Dr. Rice, but it's the word that I know that he wouldn't necessarily know. He uses a different word for it. We call it a fugue. It's where somebody takes the pills so much, they get up in the middle of the airplane ride and walk around the airplane, or they get in a car and drive, and then they park the car, and the next morning you say, what in the heck did you do? You just drove a car. And they said, what are you talking about? I don't remember any of that. So it happens in a very small percentage of people, but that kind of side effect that's so rare is ultimately terrifying, right?
Yeah.
So I just think the idea is to go
I mean, daily dependence on anything, we all know, is not optimal. I mean, some people, I know they get so desperate, and pained with their lack of sleep, and they'll, sell out to this constant utilization. These medicines, I think, in a healthy sense, are for people who are trying to reset, or just taken very sporadically. to get back on a schedule.
Yes.
This is all covered very beautifully in the conversations that you had
But
with
don't you?
Dr.
But
Rice.
don't you find it funny in this conversation? Don't you find it funny that if someone comes to the office and talks to their doctor, cancer or not, and they say, "I want to take a pill," that's great, but that's also basically a treatment without a diagnosis,
Yeah.
right? So
Absolutely.
that's why
It's putting a Band-Aid on something, and it's not getting to the root problem.
that's not, and that's what's so great about why I try to spend so much time with Dr. Rice on home sleep studies. I don't care if it's the Aura Ring. I don't care if it's any of these new gadgets. Whatever floats your boat, whatever gives your doctor more data, I think it's great. But these new home sleep studies are awesome in the sense that you remember the old days, which is just a couple of years ago. If you wanted to do a sleep study, you had to sleep in a lab on some kind of gurney. I thought it looked like a gurney. And I'm thinking, who can sleep here except Rip Van Winkle, right?
Right.
So now that they can do it at home, they can tell you what's going on the whole evening, including, do you have sleep apnea, which has become a major problem? Or maybe you don't have sleep apnea, but you're having trouble going into the deeper phases of sleep. Or maybe something else is interrupting your sleep that they identify. So it's so funny how throughout medicine you want a diagnosis and then a solution, but here you're starting with a treatment to somehow figure out the diagnosis, which is done once in a while, but that was one of the biggest pieces of advice is just getting to the root cause of the problem. You know where this is really getting early attention, which we're going to cover in our conferences, is there's a theory which I adhere to, and a number of people are looking into this, which is when you go on these drugs, whether it's ADT or chemo, when you go on these systemic drugs for prostate cancer, and you look at the list of side effects from A to Z that we talk about, whether it's the weight gain, whether it's the cognitive, you can list, you and I can list 20 different potential side effects. A lot of people believe that the root of a lot of these side effects are actually coming from sleep deprivation that actually happens when you go on these drugs.
Yeah, and it's funny too, like we emphasize the weight gain, loss of muscle, whatnot. And because those are so dire and problematic, the fact that they can't sleep and they're absolutely miserable in that regard doesn't even get talked about.
That's right. So they have lower energy, right? They don't have energy to do things. Cognitively, they're not sharp. And people would say, well, that's the effect on the drug on the brain. A lot of people are showing that, okay, maybe that's true, but what could be the root problem here is that you're hurting quality and quantity of sleep, and that ultimately transcends into a lot of these problems that you describe. So if I'm only getting 4 hours of sleep, I don't want to go lift weights. Or I know in your case, 4 hours is good. I need 7 or 8. And so if you're not getting enough quality and quantity of sleep, I'm not going to want to lift weights. My anxiety is going to be through the roof. Because you notice someone who hasn't slept a lot, they have more stress, they feel their anxiety. The risk of depression goes up. So mentally and physically, they can't be on their game. And I love the idea that they're now attacking these issues through sleep improvement. I think it's cool.
Yeah, it's interesting. You talk a lot of these high performers that, have been so successful, like Bezos in the financial world, and they talk about how a good night's sleep is what magnifies their productivity beyond anything else. It's a very simple priority, but oftentimes, as you see, the complexity of actually achieving optimal sleep is a rather complex challenge.
That's right. So the standard becomes cognitive behavioral therapy for insomnia. You don't have to go into an office. You can do it web-based. It's 4 or 6 sessions. You can talk to the experts. And as I've learned about what they teach sleep hygiene. And you kind of give these tips and you see them and you don't think twice about them. But when you apply them to your daily life, I never turned the house down to 65 to sleep. I never drew in blackout curtains to the point where when I put my hand up and I'm sleeping at night, I can't see my hand. It's that dark. I didn't get rid of all the light in the room until I started learning about sleep hygiene. There is no light in our room whatsoever. It is so dark, it's almost scary, right? And so utilizing some of these tips overall, I have found it to be so much easier to go to sleep. And then I go back, and I hate to say this because this is going to sound boring, but there is no question that the regular exercisers are much more likely to go into deep phases of sleep, much more likely to get refreshing sleep. And think about it, Mark, we are a nation on alcohol. The worst possible way to rob you of sleep is alcohol. It doesn't mean
it's like taking a sleeping pill, basically, which is the yeah, it'll put you asleep, but the sleep quality is degraded.
The sleep quality stinks. So that's what I told Dr. Rice. And I said, alcohol cheapens your sleep. It robs you of sleep. It makes you tired. Last night I had about a quarter glass of wine. There was a big party with a bunch of California folks that came into our area. A lot of California folks want to come into Michigan, of course. And so it's a person who used to own a winery. They used to own a wine business. Everybody was drinking wine. I was a quarter way in and I thought, if I go more than a quarter glass here, I'm not going to get sleep. I'm not going to be sharp with Dr. Scholz, and we can't have good banter. So I shut it down at this party for 5 hours because I'm trying to practice what I preach. The biggest thing over the counter robbing you of sleep is alcohol, I think.
These are not popular messages, but
No.
we're getting back to the roots of these issues, and for people to at least be aware of the fact that they have power over these things and it can make a big difference. It's a very, very valuable message.
You know what my favorite part was? That I don't know if Dr. Rice knew it, but I think it's so cool that you should test it out in your practice. Is, we talk about all these mutational and genetic tests. There's a genetic test for fast and slow metabolizers of caffeine. It is a fascinating test. You can go look over the counter, give a cheek swab. There's plenty of them now, and it has validity in the sense that 95% of the caffeine is metabolized through a certain pathway in the liver. And you are either a fast or a slow metabolizer in between. I have friends who can do an espresso at 11 o'clock at night and they sleep like a baby. Makes no sense. They got tested, they're fast metabolizers. I got other people like myself that if I have caffeine after 1 o'clock, I essentially can't get sleep. It makes no sense. I'm a slow metabolizer. It is such a fascinating way to learn more about your body, because the other thing besides alcohol that robs people of sleep is caffeine, because the half-life is long, but it only gets longer and longer and longer with age because the liver is not capable of metabolizing it as efficiently.
Yep.
So now in my 60s, I noticed that a cup of coffee, a single one, can keep me up late at night. And in the old days, 2 or 3 would never do that. And I think that's mostly age, not just the genetic metabolism. So that was a thing we talked about. I talked about was that test. And I think that's all these little tidbits, hopefully.
Well, that's kind of fun. I mean, but if you're cognizant of these things, I mean, I know I'm a slow metabolizer. I could have a cup of coffee in the morning and I'd have insomnia at night. So so I had to be very, very careful about the use of caffeine. But yeah, it's kind of cool that, like you say, you can actually test and objectify that estrogen.
You can. And then the other question I always get all the time is, how do I know if I've had too much? That's one of my favorite questions. Let's say I haven't had the test. Let's say I have had the test. How do I know? And you can describe to someone, you can say, do you know that feeling when you almost feel like your heart rate's going up, your blood pressure's going up, you're almost starting to feel anxiety and stress from your coffee? You know that you just don't feel the same. There's the cup of coffee in the morning where you go, this is great. But then you reach a point with caffeine where you get that jitteriness, you get the heart rate change, you feel the blood pressure change, you feel more anxiety, I said, that is one of the barometers. You know that moment. I know when that moment kicks in. And
we're so privileged that, in this era, we have these access to these resources, these pharmaceuticals, which can selectively at the right time give you a boost. Like, if you're traveling, you can take a sleeping pill and recalibrate your rhythm and enjoy your trip much more because of that power. And then the overuse of all these things, having a little bit of alcohol at a social occasion versus that conversation that you had in terms of, not having alcohol in the home. So in that conversation you had with Anna, and the selective use of these resources to improve our life and take control rather than them taking control of us.
It's a really important discussion. I mean, a year or two ago, I thought we have all this alcohol in the home. We hardly ever drink it. When we drink it, why are we even drinking it? We drink it just to relax. So I thought, all right, we can't let this take our bodies over and our minds. So if I took you downstairs to the shelf, I've been given so much alcohol for free. Doesn't make any sense. Of all the favors I've helped my doctor friends, their patients, they've sent me so much alcohol. I don't even know what to do with any of it. So we haven't touched it at home in years. When we go out, we might have a little drink. And I'm not saying it's easy, but it has found a way to control it. What I said to Anne Marie and what I said to Dr. Rice, I will go to my grave believing that the way you get somebody addicted to any substance is you concentrate the substance more and more, and you tell them they need it more and more, whether that's with ultra processed food ingredients, sugars, whether that's with caffeine. If you notice, when you and I were growing up, caffeine, like, wow, this is in a little bit of coffee. Now you have these energy drinks that are 300 or 200 or 100. They're so many times more what we had. Alcohol's the same way. You know, we used to have beers that were 4 and 5%. Now they're 9 and 10%. A glass of wine was was a couple ounces, and now it's a 6, 7 ounce pour. You know, a shot used to be an ounce or an ounce and a half. The other day, someone wanted to pour me a shot that was part of a standard drink at 2.5. And so you start getting exposed to all these concentrated ingredients, and then suddenly the dopamine, the part of your brain that says, I like this, says, I want more of it and I want it more often. And that's the danger. So when people tell me there are two lies I don't believe. One says, oh yeah, I drink every single day, every other day, but not that much. It's no big deal. I could quit anytime. When someone says that, I get nervous. It's like when someone goes to Vegas. You ever notice people go to Vegas, they go, you know, I really don't like to gamble, so I really don't gamble. And when we go to Vegas, I just go to the shows. And I'm going, those are the biggest gamblers. It's called denial. It's more than just a river in Egypt. So, you know, so people need to be, the point of that conversation is people need to be sensitive to how much melatonin they're taking. They need to be sensitive to how much caffeine they're taking. They need to be sensitive to how much alcohol they're getting, because ultimately when you cross a threshold, that creates dependency.
Can we talk now a little bit about the time you had with Anne-Marie and her, what a wonderful resource for someone that, you know, had such a turnaround in her life, and the process of her building muscle is so relevant, I think, to our audience, because we're dealing with a lot of men who are in the same space and also don't have testosterone. There's this issue of, you know, can you build muscle without testosterone? And the answer is you certainly can, but you saw her passion, her commitment, her diligence, her consistency, and sadly, that's what it takes. It takes that level of commitment to accomplish what is absolutely necessary for our patients who have low testosterone levels and are trying to regain a semblance of normalcy in their lives.
Yeah, yeah. I think, well, the backstory of my relationship with her is pretty amazing. You know, I was the guy that she would go to when she did all these stories fairly often and say, are these objective stories, or do you want to comment on this product or that product? And a lot of people ask me to do that, and most of them I ignore now because I'm getting old and cranky. But the reality is that she was the one, like I said, who, when I read an article in the Wall Street Journal or in most newspapers, they were really objective articles with multiple sources that challenged those sources. And she would always refer to the data when there wasn't data. And so I thought it was the ultimate honor over a decade or plus to be a source for her on a regular basis that sometimes she would quote and sometimes she didn't. And then all of a sudden she realizes, okay, I've done this game. I need to find something else to transform into, to uplift my spirits in my life. And she picks up bodybuilding. And so here's this woman who we never talked about bodybuilding on a single interview in over a decade. And suddenly she calls me and says, I'm a bodybuilder. You know, it's not, plus you just don't declare I'm a bodybuilder. I mean, you have to get in, you have to compete, you have to be a professional. You have to be good enough to make the team. So she makes the team. Now she competes once a year. Total transformation, I think, physically and mentally. And then she writes this book the week our conference is coming out.
Perfect.
I mean, what the? So I called Alex and I called the team. I said, look, this is going to be the oddest thing we've done for men's health, but this is someone who is uplifting and motivational for women's health. But to me, it's for everybody if you really read the book. So she's an incredible story who has great scientific knowledge, and she applies that.
Wonderful inspiration. This is something that we all need inspiration, because I remember Jerry Seinfeld was queried about his exercise habits, and he said, "I don't want to go there. There's absolutely nothing funny about it. It's it was a but his commitment and his diligence in pursuing that was unquestioned. He was very much a believer in exercise, but
Yeah.
it's hard and it's uncomfortable and it's boring and all these sorts of things. So to bring her on, the inspiration that she is and the transformation that's occurred is a wonderful object lesson for our patients that are trying to find motivation and to implement this type of activity in their lives.
Yeah, and it's a way of, you and I have talked about this for 20 years. Medicine moves so fast that sometimes the expert in the category is the one who's just done the most homework recently in that category, right? And we'll be talking about that with medical insurance in a moment. But, she's done a lot of homework. The science of weightlifting has moved so quickly. I would bet you that compared to 10 years ago, there's several thousand more papers per year on weightlifting than there were just several years ago. I can tell you that firsthand. And so the science has really caught up. And so she's able to capture that in the book, and we're able to capture that in our discussions. And now when you look at the science, it's like the ultimate drug. And you're kind
It
of
is.
whatever it takes.
Mark, you may have an answer that's been in the back of my mind for a while, is that how long is it going to take for them to synthesize the drug that comes from us building our muscles up, makes us feel good, apparently stimulates our immune system, probably multiplies stem cells, all the other magic and goodness. Why can't we just identify whatever that hormone is, synthesize it, and inject it? Yeah. Has anyone got any idea? Is it a constellation of things that is causing all this? As you know, the studies clearly show that if you look at the difference in people in our age group or my age group who are pursuing fitness versus not pursuing fitness, it's not just a feel-good thing to be fit. You live 25% longer, well-established fact. It prolongs your life expectancy substantially. And of course, you have a better quality of life during those years as well. But is there any evidence for some underlying hormonal thing? There's no doubt that these are chemical messages that are going out to our body, making us feel better, making us stronger, stabilizing our emotions. What is the underlying hormone that's doing all this?
There's a lot of things. This is a really good shout out for someone I've wanted to bring to the meeting in almost 20 years. He's the person who's published the most in the history of prostate cancer on weightlifting. He's from Australia. And he's coming to our conference. And not only is he going to give a lecture, and with me moderating, we're going to get to really go toe to toe because I've actually done papers with him. So there'll be great banter. It could get aggressive. It could get pugilistic. You never know with me. And so we have sometimes you can say there's number 2 and number 3. This is the standalone world's guru in prostate cancer on weightlifting. And he is flying in from Australia to not only do a lecture, but Sunday morning, you and I are going to attend his class before our Q&A. He's going to do a 1-hour class that if you have any stage of prostate cancer or you're a caregiver, this is what the research shows. Now, to answer your question, he's done a really good job of identifying 10, 15 different compounds. They've just started discovering these neurotrophic factors that come from the brain and are released from the muscle. They're discovering all these compounds that we never knew existed that are helping with anything from cognition to muscle development, which also encourages that sort of anti-cancer environment. And they're even looking at now the idea that when you get systemic therapy or you take a pill against cancer, of the timing of exercise when you take that to increase perfusion into the tumor cell itself to deliver more toxicity. So they're also looking at what happens with cancer, how you end up delivering greater blood flow, for example, to certain tissues, which also seems to be to the tumor, and maybe this provides an enhanced killing effect. Then you start to see all these other compounds, whether that's the reduction in insulin resistance. See, one thing that weightlifting doesn't get enough credit about is that if you look at it, consistently lowers your risk of insulin resistance. So it really uses insulin effectively, not too much, not too little. And we know that insulin in high amounts is a mitogen for cancer. So he's also going to tell you why we're looking at some of the most basic compounds, and it's helped keeping the human body in a sort of cruise control where it doesn't allow for too much production or resistance, tissue resistance, but then the tumor can utilize it for growth. So I could give a 3-hour lecture on the 20 different compounds, but there's so much there And in fact, there's also what we call cell line serum studies, which a lot of people have done, meaning you take a cancer cell line, you take a group of cancer cells, and you subject them to certain things to try to learn more about them in the lab. But what they actually sometimes do now is they take the blood after a workout from a cancer patient. They did this in Canada, which I've talked about the past few years. That was called the ERASE trial. They took blood and then they exposed the cancer cells to the human blood that was just exposed before and after to the aerobic and resistance exercise. And the tumor killing ability, at least in the laboratory, was enhanced many-fold when they pulled the serum out right after an exercise routine. So,
Wow.
so immunologically, the real focus of Newton in the fall, I know we're going to talk about it, is the immune surveillance also seems to increase significantly after a workout. So maybe what all we're doing with these workouts is we're enhancing the capability of the human body to recognize tumor as tumor and kill it, along with systemic therapy. You know, something happened in the past 4 weeks that nobody talks about in prostate because they don't know about it. We had our first ever evidence in colon cancer patients over the past month, maybe 2 months, the first ever evidence presented, and they've talked about this at our large meetings, that shows that patients who are diagnosed with colon cancer in various stages who are able to maintain exercise after diagnosis and remission were much more likely to potentially beat the disease and improve overall survival. It's the first glimpse in cancer patients, strong glimpse, that exercise with conventional therapy, we know increases quality of life, but may actually impact survival with more robust data, not laboratory work. So long answer to
No,
a
I mean,
short
that,
question.
yeah, fitness definitely prolongs survival in people with and without cancer. And it's a very substantial outcome. It's not a small change. It's a significant change.
Yeah, that's why she said, you know, the number one cause of going in the nursing home in our generation will be from falls and fractures, and that's true. And so the thing we didn't talk about, though, is the idea, and I'll talk about this in the fall. It's very important if you're starting a weightlifting routine. There's several important points that you brought up in my mind. A lot of people will start lifting weights, and after a month or two will go, my biceps don't seem that much bigger. My triceps don't seem, my quads, I don't know. But what they're not realizing is the first few weeks and months of muscle development and lifting is more of a neuromuscular adaptation. So the nerves are becoming more adaptable to the muscle tissue. So what you tend to feel it more is in coordination, right? You can feel it more cognitively. In other words, the nervous system change, it's called neuromuscular change, happens before the actual muscular hypertrophy. So you're getting the neuromuscular benefit in the first few weeks, and then the strength and the size comes later, right? If you've ever tried, I tried doing leg weights a few years ago when I was getting weaker. And before I added another plate, it was several months. But I started to feel more comfortable with my coordination and walking. So always be patient with yourself. The neuromuscular change happens first, and then the muscular change happens later, the increase in strength and size.
Yeah, before we leave this subject, we should probably mention that, you know, this is an art form that was developed, you know, here in California. We have Arnold Schwarzenegger, you know, the bodybuilder and future governor. And he actually worked out at Gold's Gym, where I hired a trainer many years ago when I was overloaded with work and I knew I just had to get stronger. And that trainer initially took me not to my max, but basically didn't want to, you know, get into this so aggressively that an injury would occur and then take me offline altogether. And I was wondering, you know, hey, when do I get into the big heavy stuff and, you know, become big and puffy and all that stuff? And the issue was that there is a whole art form to this, to build a foundation that you can later embark upon more aggressive muscle building. And you know that if you simply just jump into it, you risk injury and then you're offline altogether. So for patients who have the financial resources or have access to professional supervision in this whole process, there is a real upside. There's a whole art form to doing this properly. And it is wise to incorporate you know, those resources if you can access them. The other thing to be aware of is that you have to find someone congenial. You're going to end up spending more time with this supervision perhaps than your own family. If you're meeting with them, hopefully 3 hours a week, it becomes a big part of your social structure. And of course, good trainers know that, and they know how to not be oppressive and whatnot. So when people look for something like this, it's almost like hiring an employee. And then sometimes maybe even have two different people for variety and for a different style and whatnot. But utilizing professional resources to help find the optimal outcome makes a big difference in terms of results.
If you're one of these guys in the gym that's always going for the really heavy weight and you're making these terribly horrible noises out loud, just making these screaming noises that sound like, I don't know, it sounds like a dinosaur in trouble. I mean, it's just one of the worst sounds you'd ever hear. Even though that might seem impressive, it's not really. Because what we learned essentially, it's not doing the heavy weights a few times, it's doing the lighter weights more often, more reps, more. And that's why she said the key word. She said until fatigue. So when they look at people as they age, if you can do lighter weights with more reps, let's say you can do a lightweight 20, 30, 40 times to fatigue, it's a lot better than jumping up to a weight that you can barely handle and doing it a few times and being impressed, because it's going to increase your risk of a lot of problems, including like an aneurysm potentially, a hernia, another reason. But also it doesn't necessarily build more strength, and it certainly doesn't build more muscle. So is less more or more less? And I always would say less is more. In other words, you lift lower and lower weights, but you do them with more reps until you actually feel tired. And then you can go up slightly incrementally. But that's also how people get hurt. How people pull out their back or something goes wrong when they're lifting. They're like, watch me lift all this weight. Oh, or my legs. And that's how things snap and injury occurs. So that's a good point. To your second point, look, I couldn't agree with you more. I used to always say trainers are like therapists. It's a marriage. So we got really good trainers out there and we got really bad ones. Same thing with therapists, same thing with doctors. So if you're not feeling right, some people, they go in there and it's not about the training, it's about what else they can sell you, the potions and powders. Or so if you are feeling right and you're getting to goal, that's different. But yeah, if you have to move on from your trainer, you have to move on. But if you have a bad experience up front, don't stop. It also fits your personality. I don't like going to a gym. Probably because I've been traveling too much in my life. So we built a home gym here in the past 4 years, and I just love it. I love everything about
it. And these trainers will come out to your house. I mean,
exactly. They'll do it on web.
And I recognize this can be expensive, but if you think about investing in your most valuable asset, your health, and if people have the discretionary income, I think it's misallocation of the healthcare dollar to not be willing to spend some money on professional supervision. And it's motivating too. And it's also, there's a component of accountability. A trainer that I had many years ago, I've already mentioned, would, if I was out of town traveling on a vacation, there's a message waiting for me when I get home. When are we scheduling our next? They gently but firmly and consistently pursue you to make sure that you don't drop off the map. And of course, they're making money on this, so they're motivated. But there's that balance of yes, respecting your privacy and your lifestyle, but also that you're better off if you're seeing this person and you're consistent.
And to go with that story, and this is a great advertisement for fall. For those of you listening, this is the best opportunity we've had in 20 plus years to talk to the guru and see what the guru says. And I've known him well. We just did a paper together that gave us a lot of attention in the urology oncology world. And I was an honor to be on a paper with him, but I know what he's capable of. And during his class, it's going to be extremely, extremely impressive. But what you say about the trainers is so true. But this was the other point you reminded me of. And this was studied in prostate cancer, which a lot of people don't realize. The great news about weight training is the neuromuscular and muscular development, as the neuromuscular happens immediately within the first session. All these things happen immediately. And if you can go 2 or 3 times a week, and what their group has shown, just using 30 minutes, 2 or 3 times a week, a few upper body, that's what you have to choose. I choose 2 or 3 upper bodies, and I choose 2 lower bodies, and you're done. That's it. And then you're out of there. That's for me. I want to be a minimalist overall. So my point about that is that that's the good news. The bad news they learn in prostate cancer, because the average age of the prostate cancer person that they could study was in their 50s, 60s, or 70s, is that if you took several months off, there was a precipitous decline in strength and muscle size that put you right back to baseline.
Yep.
So what we learned from these studies is the idea of taking a month off or several weeks off, you're going to pay big time as you get older. The body's going to go back to baseline. Now, if you're sick, that's one thing. But they let these people take several weeks off to a month, and they had lost a large portion of their strength and muscle size. And that was stunning to me.
Yeah. Well, this is even emphasized more in our prostate cancer patients who don't have testosterone. And
Yes.
I'll tell you, it's not a month off, it's 10 days off. And so where did my body go? So it's something that we emphasize and reemphasize in our patients who are on testosterone deprivation, that there really can't be any compromise. You can't say, well, I'm going to Europe for a week. And no, you have to find a gym while you're in Europe and get at least 1 or 2 workouts in there to remind your muscles that you love them. You don't want them to go away, because they will disappear like that when you don't have testosterone.
They'll disappear. And that's why she's great in her book, and it was great on the tape. You know, you don't have an excuse, because even if you're some remote place in Siberia, you can still do push-ups, you can still work with cans, you can still do push-pull and leg weights. And so you don't have to have a gym there overall, but that's true. It's really incredible how you lose everything you gained if you take time off. And you bring up a really good point with hormone therapy. So the group that, again, is going to be there in the fall, they did this landmark study where they took a group of patients and they waited 6 months to do muscle development and weightlifting. They found a group of patients that at 6 months had still done nothing while they were on hormone therapy or another drug. Then they took a group of patients where purposefully they started their weightlifting routine a week or 2 before they started hormone therapy. And lo and behold, what they found was a massive, profound difference. That the group that started at 6 months, even a year or 2 later, they weren't able to get to where the group was that started weightlifting before the first injection or pill. So it's such a slippery slope that if you wait too many weeks or months after you started therapy, the climb of getting back to where you need to is almost insurmountable for people.
Yeah. Well, think about it. If you're going into the treatment with normal testosterone and a normal complement of muscles, and you hold on to those muscles by consistently exercising from the get-go, clearly you're going to be way ahead of the person that, goes into the ditch and now has to climb out of the ditch 6 months later because they've lost so much muscle due to their low testosterone levels.
That's right.
Anyway, I'm glad we've been able to emphasize this, but let's move on now and talk about the issue with insurance, which I'm not an expert in, but I'll tell you, it impacts our decision making, the resources that our patients can, for example, getting a PET scan. We this is a common problem, and insurance almost universally will not cover PET scans in men that don't have a pre-existing diagnosis of prostate cancer. But some of our well-to-do patients have purchased PET scans because if they have a high PSA and an MRI showing a lesion, they would rather have a PET scan than have needles poked into their prostate. And PET scans are about 90% accurate for picking up cancer inside the prostate. And so if the PET scan doesn't light up, there's an encouragement then that maybe they don't even need a needle biopsy. So they're able to sidestep a needle biopsy, which is clearly an attractive option if you can get it. But this just shows how powerful insurance is in guiding what people can access and their overall outcomes. It gets more frustrating in men that have been diagnosed with prostate cancer and are asking to get a PET scan and can't get insurance coverage for it. These are $5,000, $6,000, $7,000 scans, and the idea of that kind of money is a big barrier for a lot of people. They can't just go out and write a check. To me, that's always a frustrating proposition, because here you are fighting cancer. You've got all the struggles of learning how to deal with a life-threatening illness, and then on top of that, you're fighting the insurance company. So what I would say up front is the time to buy insurance, of course, is when there's no illness, and buy the best insurance you can get, because it's to protect you against that possibility of something bad in the future. Bad insurance is fine as long as you don't get sick. So what do I mean by good and bad? Well, in the prostate cancer realm, 80% of men are over age 65. If you're an American citizen, almost everyone has access to Medicare insurance. And I am concerned about people who maybe are a little short-sighted in buying some of these Medicare Advantage programs where they'll, it'll reduce the cost of your pharmaceuticals and whatnot, which can save you money. But if you get sick, these Advantage programs are like the PPOs, which they say, now we'll decide when we're going to pay for your PET scan. And you're going to have to, jump over some hoops and hurdles to get that PET scan and learn how to write good letters. And yes, if you're in that situation, it's good to have the expertise that was imparted through that presentation. But it is a real struggle for patients when, they say, we know what we need to do. This is a very clear-cut path forward, but we can't get coverage for it. So I'd say my reaction to that presentation, because I'm not expert enough to talk about the sophisticated ways to twist the arms of insurance companies, my reaction is do your best to try and keep your regular Medicare insurance if you're over 65. And that, thankfully, does not, there is no such thing as a pre-authorization for someone who has standard Medicare with a secondary insurance. That only comes with the PPO alternatives. They call them Medicare Advantage programs. And I tend to call them Medicare Disadvantage programs. And they are a situation where you're limited to what they're going to allow. And so that's a big fork in the road for patients. Are you going to keep your standard Medicare and all the freedom to do what's covered by standard without having to do any pre-authorizations whatsoever, or are you going to give a lot of power over to an insurance company to probably save some money up front and keep your fingers crossed that nothing serious happens and that you don't need more sophisticated insurance coverage? So that's my little diatribe about the situation with pre-authorizations, and it does impact me. I delegate a lot of this to my staff to try and help people get insurance coverage for things that the different PPOs and Advantage programs are denying. There's a game that these insurance companies play. That they'll say, well, maybe they won't be as sophisticated enough or motivated enough to pursue this authorization program, and then we save a lot of money. We end up not having to buy a scan for this person. But it is it's frustrating, and it's a difficult issue to confront at a time when you're already fighting another battle. And so thank you for going through that in such detail with those experts in terms of, well, here's some expedited ways that you can, you're in that situation. You have no choice. You have to pursue the pathway to get coverage. And there is a pathway forward. It may be arduous, but it's less arduous with the resources that were shared, particularly with the artificial intelligence stuff that was imparted.
Yeah, I told a story of how last year I went to my new primary care in Michigan, and lo and behold, they approved a surgical consult because I was looking at a little, maybe possibly an inguinal hernia thing. I just wanted to examine it. I get there, the surgeon looks at me, I get this massive bill. And I said, what's going on? So our first point in that lesson is true, that sometimes simple errors can correct it as long as you make the call. I called the primary's office. I said, why did I get this massive bill? I said, I got a referral. And the manager went up, and she goes, oh, this is not the right type of referral to get it covered. Sorry, I'm going to put in the right type of referral, bing, bong, bink. She said, call back in 7 days to the surgery group and see if they got it. 7 days later, bing, bong, bink. Oh, yes, we got it. Now, instead of paying a huge amount of money, I pay $30, right? And so that was my first introduction to it. You may have mentioned the creme de la creme of why everybody has to watch this 1.5 to 2 hour Q&A, because what you said there has become the recurrent theme of what I'm experiencing as one day I'm moving closer and closer to Medicare. So when I would watch Medicare Advantage commercials on TV, they seemed attractive. And then I started talking to all my doctor friends who were 65 and older, and they would tell me exactly what you told. Just be careful. Medicare by itself comes with a lot of advantages. Then, since I have to go through the medical journals because I'm publishing and editing, here are some of the 2 top articles that I had to read in the past few weeks. This one's called Delays and Denials in Medicare Advantage, Fixing the Systemic Conflict of Interest. This was published in JAMA this week. All right. And then the other one published in JAMA earlier this year was May 13th, Steering, Switching, and the Medicare Advantage Trap. These are in our medical journals talking about the Medicare Advantage problem. And I'm thinking, wow. So what you said is so true that when you get to that point, you really got to look at the pros and cons. I guess there's so much pre-authorization going on that people are stumbling. But it's with the idea that you pay less, right?
Yeah, but this is, I mean, I have a patient out in Louisiana that I've been supervising with, advanced progressive metastatic cancer. Xofigo is a radium-223 is FDA approved. If you have regular Medicare, the doctor can start you on it tomorrow. He had an Advantage program, and he says, I find that, he's in a waiting program. His PSA is 450. And he's hoping that it'll get approved in the next month or so. So, I mean, normally in the prostate cancer realm, we're not really worried about delays, with earlier stage prostate cancer. Yeah, we'll get it in the by and by, no big deal. When you have androgen-independent metastatic prostate cancer, time is of the essence. These are real cancers, and they grow. And you don't want to be waiting around when that may be the only thing that could make a big difference in his future. Getting that in a timely fashion, finding out quickly, is it effective or not effective? And then if it is, continuing it. And if it's not, switching to something else in a timely fashion. Time is of the essence in these men with advanced androgen-independent disease. So lack of access, and it was kind of like a normal thing. Yeah, it'll take a month or so to find out if it's approved, where if he'd had regular Medicare, it's just a matter of sign me up, let's go.
It's what I'm learning. It's learning from myself, and what you mentioned, that's a powerful part of this. The other parts of it, I just do want to shout out to the future medical student and the future urologist, Dr. Nancy Way, who work in Kwan's clinic on the Mayo team for putting together, which is how to write an appeal letter using AI. And at first, when they presented it, I thought, man, is this going to be a snoozer or what? And then when I'm watching it, I'm going, wow, these are brilliant letters that are combating denial that you can hand to your medical team. You can send in yourself. You can utilize it for notes when you're appealing the denial. And I hadn't seen a really comprehensive one on the internet. Now, I'll give another shout out. That's part one. We're going to talk to in the fall meeting, at the very end of the meeting, we're going to talk about all the other pathways of how to handle denial, not just using AI. So I will tell you, because I mentor a lot of students. And so I pulled Alex aside and I said, you and I are going to do this for 15 minutes. You're going to learn everything. She already has good knowledge on it, but you're going to become a PhD thesis on it. And it's going to be 15 minutes. And when you give a 15-minute talk, you got to prepare 15 times more than you imagine. And if you give a 150-minute talk, you don't have to prepare at all. That's the old saying. So we're going to cover it. Boom, 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 boom. It's going to be part two. Alex jumped at it. She's going to do it. We're going to be rehearsing all summer. And by the time she presents it at the end of the conference, we're going to have the ultimate combat manual with part one. So that's another surprise of the fall conference. It's going to be the last lecture of the day, is going to be the ultimate guide and manual how to pursue different pathways. So let me just give this as a teaser, because we're putting this. See, there's the AI for letters, but then there's a million other ways to combat it. You know this, and you can combat. People can actually appeal if they're not getting a drug or they're not getting an imaging test. They can appeal to the company, and the company can advocate for them. You remember how many times we would talk in your old clinic that a patient couldn't get a certain drug or experimental drug, and then you appealed for the patient, or the patient appealed to the drug company, and the drug company would provide it for free. Yep. Can you give one of the millions of examples that I remember coming into California, and you would appeal, or that patient would appeal to the drug company?
I can give you an even more stark example. There are expensive immune-stimulating medications that are FDA approved for a dozen different cancer types, like melanoma, lung cancer, whatnot. These medicines like Opdivo, Yervoy, Keytruda, which are not FDA approved in prostate cancer. But Dr. Kwan worked on a large clinical trial at the Mayo Clinic showing that Yervoy had life-prolonging effects. It became within this far of FDA approval but didn't get over the threshold, never got approved. We use Yervoy in our clinic and select cases in men with advanced cancers who are not responding to other things because it tends to be well tolerated and it can be quite effective. But you can't get insurance coverage for it. Bristol Myers, which makes that product, and Merck Pharmaceuticals, which makes Keytruda, another immune therapy, have been incredibly generous, simply asking them to send this medicine to the office. It's provided free of charge, and we can administer these medicines, which cost tens of thousands of dollars in a retail sense, to these patients who are benefiting over an extended period of time. All we had to do was ask. And that example, I think, is such a clear way to see that there are resources outside of the insurance company, as you're pointing out, that you can go directly to the pharmaceutical companies and get these medicines if you're willing to ask and provide a rationale. The response is oftentimes amazingly generous.
I went to a number of imaging companies to prepare for this piece for the conference. Most of them said, if you get rejected, here's some advice, or here's the number. I mean, let's face it, at the end of the day, this is a business. They want you to utilize their product.
Yeah.
So I got certain complaints about things, but at the end of the day, if they're giving me extra tips on how a person can get it, that's pretty awesome. So that's another pathway. In the fall, we'll talk about, there's multiple ways to appeal. There's an internal appeal, an expedited appeal, an external review. There's peer-to-peer. So some doctors will actually get on the phone if they have time. Some of them don't. And they'll get on and call the insurance company, and they'll work it out or not work it out within a 5-minute phone call. I called one of my friends who deals with prostate cancer a lot, and I said, tell me about your peer-to-peer calls that you do with the insurance companies. And he threw out about 10 expletives. And then he went into, I gave him therapy. And then he went into the fact that, look, we're really busy, but on a couple of egregious situations, I'll get on the phone, I'll set up an appointment, and usually the person on the other end doesn't know diddly squat about prostate cancer. I give them the evidence, and it gets approved. So peer-to-peer is another way. A lot of thing I learned is human resources. If you're like, I work for an employer, I still work for an employer. We have a human resources department that finds that unacceptable. So if you get rejected, they'll help you. My wife's a social worker. She taught me too. I mean, how many times do social workers jump in? They're your advocate. They help you. And then the medical team office. But we'll go through all this. But the last thing I want to say is, and we'll give this list, and Alex will give the list, and we'll ultimately have a publication. I found a couple nonprofits sort of stunning on how good the advice was. They have really good advice at American Cancer Society. There's one called patientadvocate.org. And then I was talking to one of my social worker friends, Allison, who works in the desert, and she works there part-time. She was the main social worker at Eisenhower, and now she lives in Tennessee, and she comes back and forth and does work still in the desert. And she said, I love triage cancer, don't you? And I went, what in the HE double toothpicks is triage cancer? Triage cancer is a nonprofit that gives you basically a handout and a step-by-step instructions of how to appeal. And then they have legal help and legal advice that you can call them, these nonprofits, and they will tell you what to do. Or if you ultimately need legal help, they can give you advice there so you can get legal help. And so this is just the tip of the iceberg, how we can change this number. This was the number that stunned me the most. What percentage of denied health insurance claims are appealed by consumers, according to the Kaiser Family Foundation that monitors it every year? And it was a trick question, less than 1%.
Yeah, people just give up, and the insurance companies, the insurance companies are encouraged to. So let's just address the big question which this raises, and that is, when is there a time that you shouldn't appeal? Should you just appeal everything? And the answer is no. There are ridiculous things that are never going to get approved. And where do you get that information? Well, I think normally you would get it from your doctor. Say, realistically, doctor, is this something that would be typically covered by insurance? And if the doctor says yes, then that's the type of thing where you want to pursue an appeal. The other resource, which I think also, I don't know if it was talked about in your discussions with the people from the Mayo Clinic, but I'm finding that AI is getting much smarter about what is sensible medical care. So you can ask questions of AI. Is this a sensible thing that I should be pursuing? And I think you're going to get good answers in general if you from that resource as well.
Yeah, that's a good point. So we decided to look at AI. This is why it's going to be great for the fall meeting. This is why I'm so glad some people at PCRI listen to me, because we can do great things together. That's my therapy of saying, oh my gosh, I can't believe I was thrown into insurance denials. What a terrible, ugly web of a mess that now I think is starting to make sense overall. But AI, so here's the new act that was passed in California and now is passed in Massachusetts, Texas, Washington, which we didn't talk about. And that's called the Physicians Make Decisions Act. So here's what they signed in California, that real people, doctors, providers must, once this act is passed, review the decision or denial that AI exclusively cannot be used to turn you down because they're worried. So this is a new act that just kicked off January 1st, 2025. It's called PMDA, Physicians Make Decisions Act, which give you a little bit more of a fight against AI if AI is coming at you, which is why we said, what I learned from all of this is the squeaky wheel still wins the appeal, right? Squeaky wheel still wins the appeal. But yeah, because the AI thing is daunting. The other thing that I learned from talking to all my physician colleagues around the country, I talked to some here in this state, I talked to some in the East, there was a consistent theme I heard about appeals when they didn't have time for appeals, including when I talked to Dr. Kwan, they give the patients a packet and then they can appeal and all this. They kept bringing up something which I thought was, I don't think it's funny, but I think it's interesting. The NCCN guidelines for prostate cancer. They said if you could find any evidence in there, and I used it in my appeal, or the patient did, a lot of times the appeal was overturned. So looking for the NCCN guidelines, the National Cancer Comprehensive Network guidelines, and then just pulling out prostate cancer, I signed up for those guidelines in less than 2 minutes. I just had to put a password, blah, blah, blah. There's the guidelines. And then if you're fighting, you look to see if in guidelines, the experts are saying, hey, this scan is appropriate, and you use it as a reference. A lot of the doctors were saying that the denial would be overturned. And I thought that was interesting.
Well, I think that's absolutely correct. The couple comments on that. One is that how shocking it is that an insurance company, which should know these guidelines, would be denying care for something that is, for me, guidelines are 5-10 years out of date. This has been around it takes a long time for guidelines to be generated. And so that they are so willfully out of touch with what the guidelines are and are unwilling to pay for standard guidelines is shocking. And it's hard to believe that it could be that bad, but it is definitely that bad. And this is why I started off this, my comments on this whole area of insurance approvals with get the right insurance to start with, because it's unethical, immoral how the insurance companies must know that the guidelines will cover these things, and yet they have set up barriers so that people have to, jump over hoops. You pointed out that such a small percentage of people persevere through the process to, yes, they could get it if they're willing to write letters and be the squeaky wheel and all this sort of thing. But is that something to ask a cancer patient, when they're dealing with other, major emotional financial problems, and now they're fighting their insurance company as well. So it's so yes, we do run into that a lot, where the guidelines are clear cut, and yet the insurance companies are pushing back and saying, nah, we don't want to cover that. So it's a great place to start. One other comment about guidelines, in my experience, is that they are very rudimentary. It takes, as I mentioned already, 5 to 10 years for guidelines to be generated. Medicine is moving quickly. If you look at the way I was treating prostate cancer 5-10 years ago, it's different than it is how we're treating it today. PSMA PET scans started being covered by insurance in 2022. So it's that's 3 years ago. So the guidelines haven't caught up to speed with all the wonderful new technology. So guidelines are not always going to ensure that you get state-of-the-art care, but they will ensure that you don't get denied something that obviously should be covered. And that can certainly be useful in that regard.
Yeah, I think that's a really good point, because it's funny because you and I think of guidelines. We think, oh, of course they say that now. Of course, that makes sense. I remember I don't know if you remember. I remember it was 7 or 8 years ago at the meeting, and I was moderating and talking to someone who worked in advanced prostate cancer. And I remember saying, well, why doesn't everybody get mutational or genetic testing, when they have advanced cancer? Well, we got to wait and see what happens. And then obviously now you look back and just a few years ago, that wasn't a part of guidelines. You're going, wow. But
Yep.
you're exactly right that you would think at the most rudimentary level that the guidelines are saying you can get all this approved, but yet it's still being denied. And that's
Yeah.
why it goes to the funny conversations. And for the audience who doesn't know me and everybody else tends to, I laugh not at you, I laugh with you because if I don't laugh at some of this stuff, I'm going to be crying all day after doing all this investigative. I mean, this is just, I find the whole thing just pathetic that people even have to deal with this. In terms
One
of
of the
cancer
problems,
stress.
yeah, let me jump in there because one of the problems is in the past, research advanced in a very small incremental fashion, and you needed large clinical trials to show that there was an advantage with these new treatments because the advantages were small.
Yeah.
Technology now in 2025 is going forward by leaps and bounds, and any sensible person knew that genetic testing is going to be a worthwhile addition to knowing how to treat someone with advanced cancer. But the insurance companies say, no, 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 we have to go through the usual process of doing our 5-10 year studies. And until those studies come out, we're going to call this investigational. So
Yep.
this is the trouble with guidelines. And I know I addressed this already to some degree, but in an era where the advances are huge, any sensible person knows, even before the guidelines establish, that there is going to be a genuine advantage to implementing these things early. You were able to see it. Anyone with any open mind could see it. So this is going to be a bigger and bigger problem as technology is getting better and better, and the advances are obvious, but of course insurance companies are financially motivated to call these things investigational as long as possible because it's their job to make money. So Mark, in talking about it in our general health men's clinic, even though I'm a prostate specialist, prostate has evolved with modern technology to be somewhat more of a chronic condition. And many of the men coming to see me are at risk. They're in such good health, even with their prostate cancer, they're at greater risk of dying of some other unrelated cause, heart disease, colon cancer, whatnot, than they are from their prostate cancer. So it only makes sense for me as a physician who's managing these long-range mortality questions. I'm coming to see you, Dr. Scholz, so I don't die of prostate cancer in 18 years from now. Okay, I'll help you out, but why don't we consider something that might kill you tomorrow? And so this gets into a lot of different screening stuff, which I think we should touch on briefly if we're going to be talking about men's health as a global issue. And one is something that I've been doing for 20 years, and that is to get a quick $100 CAT scan of the coronary arteries. Do you have a lot of plaque on your coronary arteries? This is a much more accurate future indicator than what was your cholesterol level, what's your blood pressure, what's your family history. Those are indirect ways to know if you're at risk. But finding out how much plaque is already there is a wonderful way to find out what echelon. Are you at high risk of an unexpected heart attack? Maybe you have no plaque at all. You're at very low risk for an unexpected heart attack. So that was one thing I wanted to just jump in and mention and allow you to comment on briefly.
Wow, there's a lot there. You got 3 hours?
Well, we got a lot more to move on to. So what is your top 2 or 3 things?
There's 2 types of scans that your doctor's going to talk to you about with a CT. One's called a CT calcium score. That's the one that you talk about. No contrast, quick picture, looks at your coronary arteries, all the vessels there, tells you if there's any calcium. So the pros of this thing is a lot of us are in this category called indeterminate risk. You have, for example, maybe a bad family history, but you have an A+ grade from Mark Moyad for your lifestyle. You do everything right, but then you have this family history, right? Or maybe it's the opposite. Your family history is stellar, but you quite don't have the numbers you need. It's tough to lose weight. So a lot of people fall in this pool. In fact, you could argue that a third or more is called indeterminate risk. They don't know if they should give you a cholesterol drug or not. They don't know if they should take that next step because some things say you do and some things say you don't. So where CT calcium score has become a game changer is for the cardiologist and the GP. Once you get that shot, if there's any calcium there in significant amounts, especially in some of the very concerning arteries, like the widowmaker, the left anterior descending, then that's enough to put people over that threshold to give you medication or to simply step up your game lifestyle. It's usually a combination of medication and lifestyle. So it really has been game-changing technology. The technology's also changed in the sense that it's becoming cheaper and cheaper and cheaper. Those are the pros. And more accessible. Cheaper, more accessible, and telling you more. Wow. So they're becoming better and better at picking up calcium overall. And you should compare prices if you're going to pay out of the pocket. One place might charge $80, another place might charge $500. You should check it out and get that stuff done. So that's the CT calcium score. And everybody should talk about whether or not you're a candidate. Now, it's my job to tell you and everybody listening that in 2025, CT calcium score was relevant, but became that much more relevant. How did it do that? It did that because cardiologists use these algorithms to decide your risk, your 10-year risk of an event, your 20-year risk of an event. So what's happened is that this year, there are a couple algorithms that are out there that your cardiologist can plug into. They put your calcium, they put your blood pressure, they put your cholesterol, they put your weight, they put your family history, and now added to that algorithm and calculating your score on what they need to do for you. Some of the newer ones now include calcium scoring. The reason they can do that is because now we have data over the past 5, 10, and longer years of a lot of people getting calcium scores to look at predictability. So what has really changed, I know you push them a lot, and I think that's a good thing, but I also want to cover...
Well, what you're talking about, the one I'm familiar with, I don't know if it's one, it's called a MESA risk calculator.
Yes.
Yeah, so you can just Google MESA risk calculator, and it's a very simple algorithm. It's self-explanatory. You put your LDL cholesterol in there, you put all the information, and it renders, say, this is a chance of a major coronary event in the next 10 years. It'll give you a percentage. I think it's a good thing to contextualize. Why is Dr. Scholz so concerned about preventing heart attacks and, say, colon cancer in his prostate cancer patients? Well, let's say someone with, low to intermediate risk prostate cancer is on active surveillance. What's the chances of them dying of prostate cancer within 10 years? 0. Absolutely 0 if they're properly managed. So what's the chance if you don't screen for colon cancer of dying of colon cancer? And the answer is about 3%, and it's a bad death, and it's preventable death. What's the chance if you just have average, let's say you're a 65, 70-year-old male with, moderately good cholesterol and you exercise lightly, and what's the chance of dying of a heart attack in the next 10, 15 years? And the answer, you do a MESA risk calculator, it's going to be somewhere between 3 to 7%. So these are not big numbers, except that if you're in the 3 to 7%, it's a disaster, absolutely disastrous. And there are things that you can do to reduce that risk and change the future. So that's why I get passionate about, even though these are relatively small percentages. If you think about from a doctor's point of view, say, well, I have 100 patients, only 3 of them will be dead in 10 years. Well, what's to worry, Well, I think I have an obligation to each individual to try and optimize their chance of not becoming a statistic. It's not that difficult to get a 5-minute scan, costs $100 if you shop around for price, and then plug the numbers into the MESA risk calculator, find out. This can be very motivating. People say, whoa, I had no idea there's a bunch of hardened plaque on my coronary arteries. My MESA risk calculator says that I have over a 10% chance of a major coronary event in the next 10 years. I've got to take action. And you can't believe the intensity of patients who are coming to see me from all over the country, even all over the world, sometimes shaking like a leaf in fear about their prostate cancer and haven't given a single thought to the fact that the possibility of an unexpected coronary event is 10,000 times higher than their risk of dying of prostate cancer.
Yeah.
It's so out of perspective.
Well, I used to get in trouble for this when I used to lecture a lot. And it wasn't to be mean. It was just to drive home the point with a dramatic example. I used to say, do you know how many support groups there are in America or around the world for people who have suffered from sudden cardiac death? And people would go, wait a second, didn't they die? And I'm going, exactly, because it's such a dramatic event, a stroke, a heart attack, it's dramatic, it's over, right?
Yes.
Whereas in prostate, there's time to meet, there's time to talk, it's drawn out. And I was not trying to be condescending or just mean about it. I was trying to show people that these are immediate events and they're lethal events. And
Yes.
that's why you want to prevent them. So the CT calcium score, which you mentioned, MESA is a really good one. Even all the traditional scores, the new one from AHA Prevent, Framingham, all of these, you can go look these up. And even though you can plug the calcium score in MESA, the cardiologist or the doctor can look at a series of these scores and go, okay, this is what we've clearly learned from the CT calcium score. The other thing that's happening with people doing these, I think, is a positive, is that whether there's nothing there or something there, it's sort of a call to action, right?
Yeah.
It's something tangible, and especially ones that can see their score and read about their score on what they can do. But the point being is you're going to be offered one of two types. The first one, the cheapest one, is CT calcium. The other one's called a CT angiogram for people who want to go more. So the pros of the CT calcium score, just for the audience, is it does pick up calcium around. So if your arteries are a straw and you see calcium on the periphery of that straw, you're to assume that inside that straw there might be a plaque, but we don't know for sure. What the CT angiogram does is look intraluminally. It looks inside the plaque.
Let me bust in there and talk. A CT angiogram sounds like it's a lot more involved, but interestingly, all you need is an IV. It's also a CT scan. It may cost a little bit more than a CT coronary calcium score does, but the precision of information you get about the interior lining of the arteries is much superior, and is going to give you and your heart doctor more clarity as to the urgency of addressing possibly even a stent, something to open up the arteries and forestall a future heart attack.
Yeah, so a CT angiogram gives you direct look. It's intraluminal. You can see inside the vessel to see if there's actual plaque. It's not an indirect look. So the CT calcium is good for most people, but some people that they're very nervous about might bring in CT angiogram. It's more radiation, it's contrast, but for the people that need it, it's life-changing. It really is overall, because I'll tell you there's a couple catches with the CT calcium score. The CT calcium score is called a CT calcium score because it only looks for calcium. There are plaques that are deadly that occur in some people that are non-calcified, especially non-calcified, right? They don't have calcium. Those tend to occur more in the younger, and they're more lethal. So that's why if you're a young man watching this, young woman, whatever your situation is, you want to have this discussion about if any of these are right for you, because they come with their selective pros and cons. I do want to add one other catch that people need to know about, because they'll freak out if their doctor hasn't told them this. When you take a picture of the coronary arteries, you tend to catch other areas on that picture. And sometimes this happened yesterday to a friend of mine. Yesterday. I wanted him to get a CT calcium score because he's in the indeterminate area. He's had everything else done. He's in the indeterminate risk. They don't know whether they should give him a statin or not. CT calcium score looked beautiful for a man his age. But then they saw something in the lung. They saw a nodule. Or another friend of mine had something in the adrenal. It gets picked up in the shadow areas and the periphery. So now they got to follow that up. So just when you go in there, you have to have a discussion about what else the camera could pick up. And if something else is picked up, like a lung nodule, a lot of times these are benign things, but there's going to have to be a discussion about how to follow those up. And that's really important. My last point about all of this is this is not indefinite. You don't have to repeat these. A lot of times, a CT calcium score is strictly used to decide to whether or not to go on a statin, for example. And what people haven't learned about CT calcium scores is many people who are already going on a statin and are being very aggressive, they don't have to repeat that scan in a couple of years, because they're already going on what the scan is trying to determine what they should go on. The second point, what people don't understand about CT calcium scores is there's a quantitative and a qualitative aspect. The quantitative aspect has become very good. We're still working on the qualitative. That means that many people will go on a statin, they'll go on a CT calcium score, and they'll say the score is the same or has gone up. And you go, I'm on a statin, what happened? What's happening is that calcium, that plaque that you had, is becoming more dense. So think of it this way. If you're in a road with a pothole and they put something very superficial over that pothole, you're still going to hit that pothole with your tire. If they put on some really good asphalt and they make that pothole really strong, you won't even know that you went over the pothole. And that's kind of how a blood vessel is. What the statins do is they take that unstable plaque that's ready to break open, that pothole that was filled very superficially, and instead they condense the material, the pothole becomes stronger, and the chance of a plaque now breaking off becomes less and less. So just because your score goes up or the calcium seems to be more there, it's more dense. It's more the type that won't break off and kill you or cause a myocardial infarction. It's doing its job.
So it's a very good point, is that these CT calcium scores are not to be used to monitor progress.
Exactly.
Unless let's say you had a fantastic score 5-10 years ago. Yes, repeat it again after 5-10 years to make sure you still have a fantastic score. The plaque hasn't come up in the interim.
That's
I want
right.
to comment one last thing about this, and then we'll move on, is the issue of, well, if these virtual angiograms, we call them, or CT angiograms, are so marvelous and accessible, why aren't the cardiologists using them more? And the answer is, sadly, that these compete directly with a revenue source that cardiologists, their bread and butter is doing angiograms where they stick a catheter in your arm or in your groin, and they squirt contrast into the heart to get beautiful pictures of the anterior lining of the arteries, standard coronary angiogram. And they get paid to do that. So a CT angiogram, many cardiologists will argue, is not as precise or accurate as a regular angiogram. Therefore, we want to do a real angiogram, which is an invasive procedure that could have complications.
Yeah.
And you say, well, okay, how much more accurate is a real angiogram over a CT angiogram as a screening tool? And the answer is, oh, maybe about 10%. So any practical person would much rather have a non-invasive procedure to get an idea of what's going on first. But the cardiologists are grossly underutilizing virtual angiograms, which are easily accessible to the general public, because unfortunately it does compete directly with their revenue sources and their comfort zone. And it's not just money, it's also the fact that they're more familiar with using regular angiograms, and it's hard to change physician behavior. So it is possible to approach this idea of, I want to get more precise information, and then you're going to get some kind of weird pushback from your cardiologist. And this is the underlying reason that can happen.
But and also keep that, it's a really good point. But these are the things that people should be looking into. They should look at the pros and cons of these things, the costs. But these have become, here's a word you never heard before, game changer. Everybody uses game changer, so we've diluted the word. But it is really, in cardiology, men's health, women's health, become game changers because you're no longer guessing at what's there. But again, keep in mind, the other thing is, the better the technology, the more important our words become. And I feel more relevant. And what do I mean by that? Everybody thinks with more and more technology, lifestyle is get diluted. It's not as important. What I keep learning from the technology is actually lifestyle becomes more important than ever. So I just give you an example of the calcium score or the CT angiogram. What we've learned is that people who do follow-ups just in studies of those things, the people that eat right, the people who follow a good lifestyle, they don't smoke, the exercisers we've learned even when they have calcium, even when they have plaques, those plaques become more stable plaques, because what scares the cardiologists are the unstable plaques that suddenly break off, and then you've got this huge clotting reaction and it occludes the artery. So what you're doing is you want a stable road. You don't want any potholes. You want it smooth, like the roads in Michigan. You know, they're just beautiful and smooth, quick advertisement. And so what we've realized through these scans is, oh, now it makes sense. When I eat right, the plaque becomes more stable. When I exercise, the plaque becomes more stable, because we all are going to end up with plaque at some point, because aging is one of the biggest risk factors. The final point is this. This year was one of the first few years, and this is going to happen the rest of our lives, that blocked arteries ultimately is not going to be the #1 killer of cardiovascular disease. It's going to be hypertension. If there's another message to be passed on to the young men and women watching today, hypertension is becoming the #1 cardiovascular killer in this country, and it's still not getting enough credit. it not only damages the heart, it damages everything from the head to the toes. It increases the risk of dementia. It increases the risk of end organ damage. You can say the kidney, the liver, you name it. So there has to be as much of a focus there is on plaques and arteries. I always love to ask people, hey, what's your home blood pressure device called? And what was your last reading? And a lot of people will say, what do you mean by a home blood pressure device? I don't have hypertension. And I'll go, how do you know you don't have hypertension? Well, I go into my doctor's office once a year. It's taken inaccurately. And lo and behold, it says it's fine. And I'm going, there's no other number in medicine that's more inaccurate unless it's done right. And there's no other medicine I can think of or measurement in medicine where you go into a doctor's office, boom, 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 they take a reading, and that's supposed to satisfy you for the next 364 days of your life. So blood pressure, all of this stuff are pieces to a puzzle that have to come together to give you the picture of cardiovascular health. The last thing I'll say about this, and this is your fault and my fault. We have not pushed this enough, and I'm embarrassed by this. We've pushed it, but we need to use more of our street cred in pushing this farther. The idea that a man who goes on hormone therapy or any other therapy, systemic therapy for prostate cancer, is not immediately put on some type of cardiovascular reduction medicine has got to become standard practice. In the world of HIV now, giving someone a statin is a no-brainer because of clinical trial. Now we're moving that way on some leukemias and lymphomas because of the cardiac effects of some chemo drugs. Now we're moving that way in breast cancer. For how long have we known that these medicines can increase the risk of cardiovascular events automatically from day one? If they've got to go on a statin or they've got to go on another cardioprotective medication, they should be put on it immediately.
Well, just to punctuate that, Mark, there's been very good studies, not perfect studies, showing that the cure rates in men that undergo radiation therapy to cure prostate cancer are enhanced by being on cholesterol pills. And same can be said for baby aspirin as well, which is another way to reduce the risk of thrombotic events. Let's just very briefly touch, because I think we're running out of time, on the your policies and recommendations for screening for colon cancer. We have this Cologuard test, which is covered by Medicare. It'll be paid for to be repeated every 3 years. The idea of doing a colonoscopy every 5, 7, or 10 years. Is this something people should do both, one or the other? What is your usual recommendation for screening for colon cancer?
Well, two things happened this past year, and that's not, you and I think are similar in the fact that, we believe in screening, but sometimes people don't screen enough and sometimes they screen too much, right? Colon changed in the past year. They lowered the screening guidelines, the number of the groups to 45. So it was 50.
Yep.
And some people now they're saying in family histories, strong family histories, there's many. Lynch syndrome, familial polyposis. You'll be diagnosed with this genetic condition, high risk. But anyway, some families are being told maybe you should do it at 40. If I could ever think of another screening test where 45 makes sense or earlier, it has to be colonoscopy. It really does. And the other thing I want to say about this, without going, you're going to always have alternatives to colonoscopy. Look, I hated my last colonoscopy. If you liked your last colonoscopy, I'm going to come over and examine your head because nobody likes going through that. I just disliked it completely, but it was over pretty fast. But here's my point. I always find it interesting that all these other viable methods exist for average risk people. Cologuard. Great method. If you like working with your own number two, though, you got to work with your own number two. You got to send in your own number two. Some people find that absolutely disgusting. Some people don't mind. That's fine. You can also, they can just fecal occult blood test in the GP's office. There's a thing called colography or CT. Actually, you can, with the CT, look now. It's now, in the past year or two, it's now become standard. It just doesn't get any advertisement that you can now do a CT, like you do a CT angiogram and a CT calcium. You can do a CT of the colon to see if there's any risk. However, here comes the big however. I always go, okay, let's say you do any of these tests and they find something they don't like, or they find something they can't figure out. What's the next thing they recommend? Colonoscopy. So I'm going, wait a second. if I do all these other tests, which are not as good in general, and they're not clear as to what's going on here, which is a number of these situations, or there's something that comes up that flags you that, maybe a little bit of blood in the stool. What does your doctor tell you to do next? That's colonoscopy. So I'm thinking still in 2025, why not just cut to the chase and get that done? Nothing against all those other ones.
So all right. So you're a healthy guy. You had your colonoscopy at age 45. Are you going to do it again at age 50, 52, 55? How many years are you going to have between your two colonoscopies?
So this is so graded now. I'm going to give you a politically correct answer because this is an advertisement that doesn't get out. It's a really good point. If you are completely clean, nothing suspicious going on. See, what I used to learn when I was a kid was if I had a colonoscopy and they didn't find cancer, this is what I thought. And I'm sure a lot of people think it. If they don't find anything significant, then I don't have to come back for 10 years. This is great. Oh my gosh, what a dream. I don't have to redo this. But what we didn't realize is that this has been well studied now. There's gradations everywhere. So in my last colonoscopy, they found a small tubular polyp in one part of my colon. And for those of you who don't know, the tubular polyps are the lowest risk of all, practically. There's a couple different kinds. They found this small one, and they found it in my ascending colon. And that's the brilliance of colonoscopy, that it just doesn't look at the rectal area. It doesn't look at the transverse colon. It goes all the way to where the ascending colon is that almost meets the small intestine. That's where they found it. And those are a lot of killers there because the old instruments couldn't go that far. So I have to come back in essentially 5 to 7 years based on that guideline. I'm going to do it in 5. So my next colonoscopy is going to be when I turn Medicare age. I'm going to do the 5. So what's important is
So let me interrupt. So if you had a completely clear one,
yes,
would you have been comfortable waiting 10 years? And the reason I ask this question is one is that colonoscopies aren't perfect either. If they don't get the colon completely clear, they may miss a polyp or something like that. In my long career now, over 30, 35 years, I've had 2 patients come down with colon cancer, clinically significant colon cancer, who had a colonoscopy like 7 years previously.
Yeah.
That was supposedly okay. Now, that's just anecdotal information. But let's say you had Mark Moyad, young, healthy guy, had a completely normal colonoscopy. Would you feel comfortable waiting 10 years?
I don't know. It depends. You brought up a really good point that there's two, we always say in prostate cancer, what the patient should keep are second opinions on pathology. This is true of everything. So here's how I'm going to answer your question. I asked for a copy of my pathology report. I wanted to make sure there was a clear finding of a tubular polyp. There was no question about it. It's true. It was, even though it's still pre-malignant, it was the most benign type of polyp and it was small. So that made me feel good overall in terms of waiting a little bit longer, potentially there with that colon polyp. So look at that. The other thing that I think very few people realize, including physicians, is that everyone's supposed to grade your catharsis. In other words, your bowel cleanse that you've gone through. It's actually a grade that you get. Some people grade it by letter. Some people, there's a validated scoring system, but you essentially get a grade of A, B, C, or D on how clean your highway looked. That's why people who want to cheat the system and not take all their Go Lightly or their polyethylene glycol, you're not cheating just the system, you're cheating yourself because the person doing the colonoscopy. So I followed all the rules, did the whole jug, the whole thing, sat on the toilet incessantly for a day, and he graded mine A++. No debris, perfectly clean. Those 2 things made me feel better, but at the end of the day, I still picked the minimum number, 5 to 7, I picked 5. Now, there's something else that's going to change in future colonoscopies, AI. AI is going to work. They're already using the software. AI is going to work with the person doing the colonoscopy to find things that they're not picking up on potentially if they're missing. They've already put in a couple software programs that's doing a good job. We're probably a few years away. To answer your question, depending on my risk factors, depending on the person who did it, depending how clean it is, depending on the ongoing, I'm probably always going to lean toward the smaller number.
Yep.
So if I had a perfectly clean one, knowing my colonoscopy person, he'd probably say 7 to 10. I probably wouldn't wait 10. I'd probably do 7. But you have a job to do in order to get a stellar colonoscopy done. And people don't realize that. You have got to clean that bowel beautifully so the person can see what the heck is going on. And next time, for anybody watching this who's had a colonoscopy, ask for your report and see what grade you got. You would be shocked at how many of these I've looked at lately, and the person gets a grade of a C or D. I have a bunch of friends that just got one that thought that they were done and got a C and a D. One just got a D, called up the person and said, I got a D. I just couldn't tolerate it. And they said, oh, yes, you did. You need to come back and get another one.
Yeah. So that was a patient initiated a solution, which means this is what the PCRI is about, is patients taking responsibility, researching their own options, and as a result, getting better outcomes.
The most amazing thing I've learned about colon cancer is if you want to tie heart health into prostate health and colon health, almost everything that lowers your risk of cardiovascular disease today, whether it's lower cholesterol, whether it's exercise, whether it's not smoking, whether it's quitting alcohol, is dropping colon cancer rates in some of these older groups.
Yeah, taking baby aspirin drops the risk.
If you qualify, yeah.
All right, so we are over time, but there's one thing I don't think we can drop, because I get this question all the time, and I want to get your feedback. This is our last thing, and that is, Dr. Scholz, I have prostate cancer. Should I take ivermectin? Should I take mebendazole? These are medicines that have been out there a long time as anti-cancer therapy, but not just anti-cancer therapy, because I'm not a generalist. I'm not a general oncologist. I'm a prostate oncologist. And I have an opinion about these medicines, which I'm happy to share. But I
just published a paper 2 years ago on some of these. I want to hear your opinion. I really do, before I give my opinion. And you're not allowed to give your opinion until I can end the talk. I can end our discussion with the question we're getting the most. And I promised Alex I would answer, which is, what's the latest on GLP-1s, which I'm going to show in one sign. All right. So I'm going to throw this back to you.
Very quickly, I'm on the front lines with this mebendazole and ivermectin situation. And of course, I'm not commenting about their effectiveness for other cancers. They may be marvelous. But these medicines have been around for 15 or 20 years now. And we looked into them in depth when the first signal came out that they might have some anti-cancer efficacy in prostate cancer. Sadly, I've had dozens and dozens of patients that I've written prescriptions for, not because I had any great belief or hope, but because they're reasonably well tolerated. And let's see if we can get any kind of anti-cancer efficacy. And sadly, I have not seen a single instance of where I go, oh, wow, I'm so glad we did that. So that's been my personal experience. And it's literally within the last 2 to 3 years, I'd say 20 plus patients that have embarked upon a trial of ivermectin. I've had 2 patients that developed some liver damage that was reversible when the medicine was stopped. But so they are not entirely harmless medicines. So that's my take on those 2 medicines. And I think it just comes up so frequently because maybe there's something great happening in other cancer types that I'm unaware of. But for prostate, I don't see any favorable signals.
I mean, I would love for you to give a different opinion to me, because then I could jump all over you like a tiger, and make sure that I could correct you. But I have to tell you, that's a good summary. So let me give it an introduction. I discount nothing, whether it's on the internet, I discount nothing. Just because it doesn't have proof doesn't mean it doesn't work. It just means that we need some proof and we got to figure out. So I talk to all of my colleagues who are on the front lines like you. I look at the clinical trials. I look at the history of working in this field for 35 years. But you have to remember, I started working in cryptosporidium and infectious disease long ago, published a few papers there. I would love to believe that these anti-parasitic, they're basically drugs to kill intestinal worms, right? There's multiple types of worms. That's why they were developed for dogs, cats, for humans. If you've got a hookworm, a whipworm, a roundworm, dear Lord, I can't believe I remember even those 3. If you've got a tapeworm, these are incredibly effective. Now, notice how I keep using the word intestinal. They were designed to mostly have efficacy in the intestine with virtually little to no absorption systemically. So the first problem that these medications ran into, which is not a problem. They were designed for intestinal parasites, is the majority of the drug is supposed to stay in the intestine to kill the parasite. If it was absorbed in any significant amount, it couldn't kill the parasite. In one case, for example, this class of drug robs them of glycolysis. It robs them of the respiratory pathway. Another one's directly toxic. So the first point is exactly what you said. They're intestinal, very little absorption, but that means they have to go through extensive first-pass metabolism in the liver. So one of the primary toxicities are liver enzyme increases and liver damage, especially with more and more exposure. And that's what's been happening in a lot of the clinical trials. Now, in your case, it was reversible. Some are reversible, but that's a scary, scary side effect. So I decided to say, well, wait a second. If this mostly works in the intestine, then isn't the first place you want to test it is in colon cancer patients? So I had to publish on this, and there was a trial that was published in colon cancer, and it was actually done in scientific reports. It was a phase 2 study. Here it is. I have it. This is what a total nerd I am. So I'm thinking, if you're showing efficacy, I'm not talking about a colon cancer cell line in a lab. I'm talking with human colon cancer patients. Let's see what mebendazole does. Here's the quote from the abstract. It was well tolerated, but all patients, I'm reading this verbatim, all patients experience rapid progressive disease. So this was published in scientific reports by Mansouri et al. And so that was disappointing. Then I looked at the combination. This was a Hopkins study of mebendazole with temozolomide, which is something used for brain tumors. You probably know it well. And even though it was tolerated okay, they had serious liver toxicity overall, and nothing statistically significant on overall survival. So then you have case reports. This is the mebendazole at the Hopkins study. Then you have case reports of drug-induced liver injury in a patient with non-small cell lung cancer. So if I'm not getting enough, if I'm getting most of the drug action in the intestine, how am I getting it in the prostate? That's what I'm concerned about. What this has led to is a story beyond mebendazole. It's another drug in its class that's given to animals. And that's the one that I've had to write about a lot. And I don't know if I put together the latest paper. It's fenbendazole. It's available over the counter. So you can get it on Amazon, and you can get it for your dog for an intestinal parasite. And so people have been taking me that. They've been taking that and then sending me the wrapper and saying, this is what I'm taking. You know, I take this. So they don't need you. They get over-the-counter access to one of these. But it runs into the same problem. It runs into most of the concentration. So what's another side effect we've seen from some people that absorb it well with some of this class of drugs? It's not only liver toxicity, it's neutropenia. And it's supposed to affect...
That means low white counts for the
low
cells
white
that fight bacterial infections.
Yeah, you just pulled a Mark Moyad. I was supposed to explain that, and you came in. I'm sorry. So, so it reduced, it caused immune suppression.
Yeah.
And we know that some chemos do that. So maybe in some world where you can get good availability in some clinical trial, maybe this mimics a type of chemotherapy. Maybe. And maybe that's why it causes neutropenia. Because if you look at some of the human studies, they identify one of the mechanisms of action is it inhibits microtubules. So when you need this part of the cell in order to divide rapidly, it shuts that part down. So is this just a chemo light in disguise? I don't know, but there's 3 or 4 more trials I looked at that we're waiting to hear from, but it's exactly my experience that I understand the excitement, and I always get excited about anything alternative, but it just hasn't gotten me off my chair yet.
Yeah.
Now,
well, your point is well taken that if patients have easy access to this, please let your doctor know that you're taking it so that you can have your liver monitored, you can have your white blood cell counts monitored, so that you don't, create a problem in the process of trying to help yourself.
Yes, and now the criticism is going to be, well, the right study hasn't been done. They have to give it IV, or they're going to have to give it a delivery method that gets to the tumor. Okay, that's all fair. But at the end of the day, it can be quite toxic. It can run you into a number of problems. The dosing's all over the place. And I understand the appeal, but again, this should be between you and your doctor. And you should just keep watching these trials. So what I wrote in this article that was published in a major medical journal is, look, you can't poo-poo this stuff, but at the same time, we should be keeping an eye on it. And right now, the preliminary data is mostly anecdotal. That's what it is. Because I don't care what people say about conspiracies. There's a ton of people like me in academic medicine that want to find anything like this that can possibly help conventional care. Absolutely.
Well, what I've told patients is that the effective agents do not remain hidden for 20 years. Something that actually works, where people have cancers melt away and people live longer, it becomes common knowledge very quickly. That everyone's scouring for effective treatment when they have a cancer. There's hundreds of millions of people that are fighting these battles. All right. Well, anyway, thank you for that information. We need to talk about the GLP-1s just briefly. These medicines are, to me, miracle medicines. Each year that goes by, the more we find out about them, they are just game changers in terms of capacity to lose weight and have better quality of life and increase longevity. So please, your comments on that, and then we'll call it a day.
My comments is I'm a victim of my own prediction. It was 5 or 6 years ago as the drugs were coming out. When I was doing a lot of media, I still do, I said, listen, I am totally against the weight loss category for the most part. This was at that time because most of them that have been approved have ultimately been removed from the market because these are just stimulants. They are unhealthy when it comes to the cardiovascular system, but ironically, they help you lose weight. But if they help you lose weight, but then they end your life sooner, that makes no sense.
So you're talking about things like fen-phen. You're talking about
we're talking about sibutramine, which was Meridia, which got pulled off the market. I remember being in Singapore and people were taking it like candy. It was approved everywhere, but it was raising blood pressure and stroke risk. So I thought, we're never going to be able to invent a pill that makes you heart healthier as you lose weight like bariatric surgery does.
Yeah.
But then I looked at the GLP-1 data and I thought, wow, I think this is what's going to go. So I said that on a bunch of shows and a bunch of places. I said in a couple of years, these will all get approved. These are going to change medicine, and they've changed medicine. And that's the number one call I get. I don't get called about supplements. I don't get called about prostate cancer. I get a call about what did you see that you thought these would be game changers? And that's what I saw. Now, that doesn't mean it doesn't come with its own catches. And that doesn't mean that we have to be realistic, that they're still too expensive, and that a lot of people have poor compliance on them, that a year or two later, they can't continue them, and then they regain a lot of the weight. That's all true. But for the people that qualify for them, and let me reiterate that, the people that qualify for them, this is a serious drug for serious weight loss. It's not for the person that needs to lose 7 pounds for the next Top Gun movie. That's not who it's for. This is a serious drug for serious weight loss where the weight is life-threatening day by day. That's the way, that's how we handle it in bariatric surgery. That's how it should be thought of here. So of course it's going to come with some GI toxicity, intolerable, and problems. But now the other thing we have to accept is if you have diabetes, the weight loss will not be as great. It will still be good, but not as good in someone without diabetes. Now it got tested a little bit in breast cancer, people on hormone therapy, and they got good weight loss with good safety, people being treated for breast cancer, and they're getting decent weight loss, maybe not the weight loss you would see in the average person, but it's a significant weight loss, 5–10% of body weight. And I think you have a number of people where they've had that too. They have significant weight loss, even though they're going under prostate cancer treatment, correct?
Correct. Absolutely correct.
And that's what you have to keep in mind, that the moment you start systemic treatment for prostate cancer, it's a battle. It's a tough battle to win because everything's slowing down, metabolism. When you eat a calorie, it's more like eating 5 calories. It's just very difficult game. So they're here to stay. I mean, can the shoe drop? People are waiting for the shoe to drop. Like, is it going to cause this bad sort of thyroid disease or pancreatic cancer or something? Well, now we're 7 or 8 years in. In fact, we're not even that. We're coming up on 15 to 20 years. That's when the first ones were approved, and we're still not seeing that signal. That's a good thing. And it doesn't mean you got to be on blind. Let me tell you how it's changing as of today. So the FDA approved Wegovy, semaglutide or semaglutide. They've pronounced it both ways. Injection. The average body weight loss is 15%. Wow. Recently, Wegovy went up against tirzepatide, which is Zepbound, the other injectable that's approved by Eli Lilly. This is Novo Nordisk, 15%. This is Eli Lilly. They come in at 20%. And that's been very consistent. Now we have a head-to-head trial, and this one won. So people always say, well, what's the best one that's out there right now? And it's Zepbound, but maybe the best one is the way you and Kwan used to talk about PET CTs, that just get one. Let's not argue too much on which one, just get one. So I just want to let you know that these two are still the big winners, and Zepbound, Eli Lilly, I don't work with any of these companies, and I published on this, is right now, this is here, but the field's about to get extremely competitive. Semaglutide as an injection just went through a phase 3 with a pill at 50 milligrams, a daily oral pill. The weight loss was almost as significant, if not the same significant as their injectable. They have now filed for FDA approval. So they expect to be approved last quarter of 2025, the first pill, or beginning of 26. Right now, nothing seems to be standing in their way. They've got the data. And we know this already works because there's a lower dose kind called Rybelsus that's in diabetes at 14 milligrams, right? This is a 50 milligram pill. It's semaglutide pill for people who don't want this injectable. This will come out unless there's some surprises this year or the beginning of next year. However, hot on the heels of that is an Eli Lilly pill, the ones that make Zepbound. Here, they have their own pill, and it's called orforglipron. Say that 3 times fast at a party. Orforglipron. Orforglipron is also a GLP-1, and the average weight loss is also similar to the pill of Novo Nordisk, right? But here's the catch. There's no restrictions. When you take the pill of semaglutide, you have to take it on an empty stomach, so you can't have any food, and you can only do 4 ounces of water. So when you get up in the morning, you have to remember that when you take this pill, there's dietary restrictions. So far for this pill, orforglipron, there's no dietary restrictions. So either way, but this one's going to come out first. Last but not least, coming up on the heels of all this is another product called retatrutide. I could say that 3 times. It's an injectable. It's the first drug they call a triple G. It works on 3 receptors, not one, not just a GLP, but what's called a GIP and also a glucagon receptor. The average weight loss from one of their most recent studies was 24% in that year. So now it's beating all the other ones, but it won't be out till 26 or 27 if the safety continues. What I love about these pills coming out, whether or not people use them, is it's going to force price competitiveness. It's gonna force a cheaper option, I believe, than the injectable, even if you don't want the pill. But the pills are coming, and the other ones that are going to compete with these two are coming. And so far, nothing's getting in its way. Now, does it do all these things? Does it fight prostate cancer? Does it reduce the risk of dementia? They just got, one of them got an approval to fight sleep apnea. I mean, it makes breakfast for you. It does everything. The truth of the matter is, in bariatric surgery, when you lose 20% of your body weight, 25%, 30%, you do see all these changes. I mean, the drugs are great, but let's put it in perspective. The weight loss, that kind of weight loss is revolutionary. And then the people who get the biggest effect are the people that are still exercising and still practicing some sort of dietary, healthy behavior. They seem to get the bigger hit, because you have to remember that the things that I worry about with these medications is bone loss potentially and muscle loss, because of about a third, 20% to about a third of the weight you're losing is muscle loss. It's inevitable when you lose this much weight this quickly. The only way to combat that is by weightlifting and eating right and everything that we said, if you really want to get the most out of your drug overall. The most other fascinating thing that will happen next time you and I talk this time next year is there's a number of people who have been able to be on these drugs for a couple of years. This is a minority, but it's so fascinating. Then they quit and they don't gain that much weight back. Why? It's not the majority.
Right.
Why? And we were going to have that answer. I think it's a lifestyle thing. I don't know. Or maybe it's a sustained half-life effect. But as you can see with the GLP-1s, there's a lot coming out. And
well, I think I might have an answer for you, because I think, there was a time, I weigh 165 pounds, and there was a time when I went to get that trainer when I was over 200 pounds. And what changed in my life was that when I changed the habit of eating, my body acclimatized to that new way of eating, and that became the new normal. So back then, the normal was, stuff everything at will into my mouth and enjoy the process. And that when I changed my behavior, that wasn't as enjoyable. I think I could retrain myself to be 200 pounds again and enjoy eating lots of food and whatnot. But there's a habituation to what is your normal. And I think this is one of the struggles people have had until these miracle drugs, weight loss drugs have come along, was to retrain your habits. It's like quitting alcohol or quitting eating. And this gives people a leg up in the process of living the right way over an extended period of time, and that becomes what they're familiar with, and that's the normal for them. You have to keep eating to stay alive, and so that temptation to overdo is always there. But I think the retraining process that can happen is something, what is it, 15-20% of these people that are sustaining after they stop these medicines?
Yeah, I mean, it's probably, it may be a little higher, maybe lower, where it's being figured out, because a lot of people in these clinicals will stay on it. I mean, they have the motivation, they have the professional support. But even if it turns out to be 12.5%, it's a very large number of people overall. And, what's going on there, because the rule is, I think we have to explain aging better. People don't realize that as every decade you get older past 40, 50, 60, your body requires about 100 to 200 less calories per that decade. The machinery starts to slow down. So if you start filling it with more alcohol, more food, you're just going to keep gaining more and more weight. That's why I think a lot of people are stunned to learn how little they need for food and how much they have to exercise just to maintain their weight when they're 65. It's a terrible game. It's ugly. It's not fair. But it is the reality, because I would think as you move closer to retirement, the body would need more calories and you could eat more and get away with more. It's quite the opposite. The time when you were supposed to eat a lot was when you were young and active. So this is fascinating. The options are all over the place. I don't like the cost, but I like that the pills are coming along, because I just think of it like hormone therapy. Look, there was always the injectable, then the pill came along, and some people just love that pill. Other people just want to stay on the injectable. But the fact that there's now going to be more options means it's going to make your job that much easier.
Yeah,
and
it should bring the prices down over time.
Yes, but I do think it's also going to make it interesting in clinics like yours, because a lot of people qualify for these. And a lot of people with prostate cancer arguably need these, or need to, if they want to get into a clinical trial, whatever, and it's not being addressed. And the idea that, just eat less and move more, people forget that the more you move, the more you drive up the appetite. When I did my 10-mile run yesterday, I think I ate almost a large pizza. I was a caveman, just wacky, voluminous amounts of food I needed. It's a tough game. So what I'm trying to do is tell you, if you're going to Scholz or any other clinic and weight is an issue, these are a strong possibility for you, because when you take these drugs for prostate cancer, most of them, even think about prednisone and abiraterone, they just want you to gain more weight, right? I mean, all these things make you want to gain more weight.
So they help a lot. Mark, we got to wrap it up, but I want to just say thanks. I know you worked extra hard on this conference. There were so many highly technical aspects that took tremendous background research. The speakers that you were able to get to us were amazingly qualified. You made it enjoyable and entertaining the whole way.
Thank you, Dr. Scholz, and thank you, Dr. Moyad. It was an awesome session. It was an awesome conference, but we're eternally grateful for you, because the volunteer work you've done in finding these speakers, reviewing all this education, the hours and hours and hours that you spent building this conference, Dr. Eugene Kwan for getting us, Dr. Wei and Lauren, and just getting all these details together. All of you as physicians are working together for us as patient advocates and for us as patients. And I want to thank you, patients and the caregivers who are watching. I want to remind you, you're not alone alone in this. There are people who really are cheering you on from the sidelines, and we want to make sure that you get the resources you need. If you need help, call our helpline, email us, let us know. There are other advocacy groups that we're going to be listing in our exhibit hall, and we're going to be sharing their information because there are people who want to help. And if you have left a comment or subscribed to our channel or supported us in any way, thank you so much because we really appreciate you. But please continue to leave your comments, leave those questions, and get into conversations with other patients. Everything we do here at PCRI is driven by the comments and the questions that you ask. When we get repeat questions, we go, we need to cover this. They have questions and we want to provide answers from world-renowned experts. And it does take us a little time sometimes, but we do it. And so I just want to say thank you so much for giving us that feedback. We would not be who we are today, and we would not do what we need to do without it. So please continue. I would also just like to say thank you to the incredible sponsors who have sponsored this event and helped us provide all this education for free to all of you. So I'd like to thank Bear, I'd like to thank Jansen, I'd like to thank Novartis, and I'd like to thank Dendrion. They have worked with us for years on just making sure that we are able to support you guys as patients. And I understand that, we could see them as drug companies, but really they are cheerleading from the sidelines. They are supporting PCRI and other advocacy groups just like us to help get education out there. And it's just a really great way to support you guys. So we really appreciate them. You can find out more about what they do and who they are on our exhibit hall on the webpage for this conference at PCRI.org. I'd also like to say a big thank you to our speakers. Dr. Moyad has spent probably thousands of hours by now developing this content and everything that he's done, because we talk about these conferences well in years and years ahead, and he really spearheads our men's health conferences. He does every conference, but the men's health conference is really his sweet spot, and he has just done an incredible job moderating, finding the speakers, reviewing the content, and so much more. I'd like to thank Dr. Mark Scholz because he is our executive director. He founded this organization. He volunteers also thousands of hours to us every year as far as filming and just spending lots of time developing content with us and reviewing all of it so that we can provide it to all of you. I would like to say a special thanks to Dr. Eugene Kwan, because without him we wouldn't have our AI talk today, and Dr. Rhodes, and soon to be Dr. Rhodes, and to Dr. Wei for being available to us. They're young and creative, and they're coming into medicine, and I'm so excited and inspired that we have people like them coming into the medical field and advocating for patients so early on, and that AI talk is really transformative as far as what we are capable of as advocacy groups and how we can help you. I would also like to thank Ms. Chaker because she has an incredibly busy schedule. She's very popular right now, and the fact that she made time to be here for all of you is awesome. Now, please remember, this is a wealth of information. You can go back and you can review it, you can rewind it, you can pause it, you can take notes. Please check out again the exhibit hall and check out all the resources that PCRI has on our website. We really appreciate you. We hope to see you in September. And please remember, most of all, you're not alone.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing. And that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
The key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up-to-date all the physicians are.
And they are very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging, I mean, this is not a dull conference. This is, I don't want to use the word entertaining, I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.